Scientific Congress pre-conference day. We started the day off with a talk from Professor Olasinde from Nigeria, and the morning session ended with a patient perspective. So it was great to hear and start the day with the patient's aspect from radiotherapy. In the afternoon, we had multidisciplinary discussions, and now currently we're having our trainees, registrars, doing contouring on esophageal and breast cancer cases. So it's a day that has started with patients, multidisciplinary discussions, and now our trainees learning from senior colleagues. I'm
Dr. Kevin Makori. I'm a consultant clinical and radiation oncologist in Homa Bay County Referral Hospital, as well as Tenwek and Victoria Cancer Care and Research Centers. Today's events have been excellent. We have had a number of sessions from distinguished speakers discussing a wide range of topics, and especially this afternoon we've had a very interactive session regarding the role of radiation therapy and the techniques that are applicable in prostate and breast cancer and even beyond. One of the highlights of this afternoon session was how we can be able to optimize the few machines that we have in our populations to serve the needs of our patients, particularly through hypofractionation techniques. It's also been a very interactive session that has seen colleagues demonstrating to those that are in training about how to approach radiation therapy in terms of contouring, planning, and so on. I'm looking forward to very interactive sessions in the upcoming days, and I know that this is a conference that has a significant impact, not just in Kenya, but in the entire African continent.
My name is Rosalina Kumu, the President Oncology Nursing Society Kenya. Today, I'm super excited to be attending AFROG conference with the theme, Innovation and Precision in Radiotherapy. The day started well with the pre-conference workshops. We've learned about toxicities, patient perspectives, the support, the researches that are coming up, and just to ensure that we have end-to-end care, multidisciplinary talks, and a lot more is expected tomorrow. So I'm requesting you people to join us tomorrow early morning, and we're gonna have a very exciting dinner at Carnival on Saturday. See you there.
Today was the first day, actually the workshop, for our 11th African Radiation Oncology Conference, AFROG, here at the Adel Grand Hotel in Nairobi, Kenya. And being the 16th of July, our theme for the conference is Innovation and Precision in Radiotherapy. So basically, the day has been amazing. We started very early in the morning at 9. Before then, we had breakfast from 7 to 9, and then from there, we started our presentations. So we've talked about challenges, solutions for oncology care, the patient journey, patient navigation, and ultimately we've had international speakers talking about precision oncology. This afternoon we are crowning it up all with contouring. We had 2 amazing presentations in breast and esophageal cancer. Then we had residents from the university who are doing radiation oncology contour cases practically, given the platform through Varian, and they are contouring, and we are just hoping to see the final product as we close the day. And thank you, Vital Science Studio. Thank you all the sponsors for making this possible, and MMS for being like the coordinator for this conference. Thank you so much, and we're looking forward to day 2 of the conference, where we are going to meet government officials, and we are really looking forward. We are hoping our CS Health will come. We'll have Anyang' Nyong'o and other industry leaders, CEOs of hospitals, and more amazing presentations. And we really thank you, and we want you viewers to be locked in. Please see you tomorrow morning. I will not miss, I'll be here. Thank you. Bye.
Good evening, colleagues. What a wonderful day we've had at the AFROG 11th Scientific Congress pre-conference day. We started the day off with a talk from Professor Olasinde from Nigeria, and the morning session ended with a patient perspective. So it was great to hear and start the day with the patient's aspect from radiotherapy. In the afternoon, we had multidisciplinary discussions, and now currently we're having our trainees, registrars, doing contouring on esophageal and breast cancer cases. So it's a day that has started with patients, multidisciplinary discussions, and now our trainees learning from senior colleagues. I'm
Dr. Kevin Makori. I'm a consultant clinical and radiation oncologist in Homa Bay County Referral Hospital, as well as Tenwek and Victoria Cancer Care and Research Centers. Today's events have been excellent. We have had a number of sessions from distinguished speakers discussing a wide range of topics, and especially this afternoon we've had a very interactive session regarding the role of radiation therapy and the techniques that are applicable in prostate and breast cancer and even beyond. One of the highlights of this afternoon session was how we can be able to optimize the few machines that we have in our populations to serve the needs of our patients, particularly through hypofractionation techniques. It's also been a very interactive session that has seen colleagues demonstrating to those that are in training about how to approach radiation therapy in terms of contouring, planning, and so on. I'm looking forward to very interactive sessions in the upcoming days, and I know that this is a conference that has a significant impact, not just in Kenya, but in the entire African continent.
My name is Roslyn Kumu, the President Oncology Nursing Society Kenya. Today, I'm super excited to be attending AFROG conference with the theme, Innovation and Precision in Radiotherapy. The day started well with the pre-conference workshops. We've learned about toxicities, patient perspectives, the support, the researches that are coming up, and just to ensure that we have end-to-end care, multidisciplinary talks, and a lot more is expected tomorrow. So I'm requesting you people to join us tomorrow early morning, and we're gonna have a very exciting dinner at Carnival on Saturday. See you there.
Today was the first day, actually the workshop, for our 11th African Radiation Oncology Conference, AFROG, here at the Agile Grand Hotel in Nairobi, Kenya. And being the 16th of July, our theme for the conference is Innovation and Precision in Radiotherapy. So basically, the day has been amazing. We started very early in the morning at 9. Before then, we had breakfast from 7 to 9, and then from there, we started our presentations. So we've talked about challenges, solutions for oncology care, the patient journey, patient navigation, and ultimately we've had international speakers talking about precision oncology. This afternoon we are crowning it up all with contouring. We had 2 amazing presentations in breast and esophageal cancer. Then we had residents from the university who are doing radiation oncology contour cases practically, given the platform through Varian, and they are contouring, and we are just hoping to see the final product as we close the day. And thank you, Vital Science Studio. Thank you, all the sponsors, for making this possible, and MMS for being like the coordinator for this conference. Thank you so much, and we're looking forward to day 2 of the conference, where we are going to meet government officials, and we are really looking forward. We are hoping our CS Health will come. We'll have Anyang' Nyong'o and other industry leaders, CEOs of hospitals, and more amazing presentations. And we really thank you, and we want you viewers to be locked in. Please see you tomorrow morning. I will not miss, I'll be here. Thank you. Bye.
Good evening.
Manabud. She's going to be co-chairing with Dr. Zahra Mohammed, who is also working at XCG, also my very good friend since Sheikh Khalifa. So I think today is a Sheikh Khalifa affair here. So I'm going to hand over the microphone to the co-chairs. Welcome, Dr.
Thank you very much for your kind introduction and invitation. Welcome to the morning session of Day 1 Plenary 4. Initially, I think the program was supposed to be optimizing care in common cancers. Unfortunately, or fortunately, we have an amendment in the schedule. So, in the interest of time, good morning, distinguished faculty, colleagues, ladies and gentlemen. Please let us welcome our first speaker, who needs little or no introduction in our region. But for international delegates, our first speaker is Dr. Catherine Nyongesa, who is the president of the AFROG. And among many hats that she wears, she's one of the pioneers of the radiation oncology in the country. She's been in the leadership of oncology programs in the country. Please, Dr. Ari, welcome and give us an update on the enhanced study. The podium is yours.
So, good morning, everyone, and thank you all for joining this session. I'll be presenting about cervical cancer and how we can enhance treatment, and this is the enhanced study. It is meant to evaluate the impact of HIV on the non-inferiority of accelerated hypofractionated radiotherapy in cervical cancer. So why are we trying to enhance? Because we know that the World Health Organization has stated that there's a strategy to eliminate cervical cancer. And one of the strategies is to ensure that over 70% of all patients who are diagnosed with cancer get treatment, timely treatment. So every year, thousands of Kenyan women die from cancers that we already know how to diagnose and treat. The problem is not the treatment. The problem is the pathway. Because all of you, we've gone to school. You know how to treat cervical cancer. So for over 25 years of my practice, the hardest part of my job has not been treating cancer. It has been meeting women whose cancers could have been cured if they reached us sooner. Looking at the GlobalCon 2024, which is now live, I got these statistics today. They say that in Kenya, more than 10,000 women are diagnosed every year with breast and cervical cancer. With breast, 5,822 new cases with the 2,882 deaths, which means 50% of women diagnosed with breast cancer may succumb to the disease, while cervical cancer, 61% may succumb to the disease. So why is this so? It is the broken pathway from symptoms to diagnosis and all the way to referral and arrival for the first dose of radiotherapy. And that is what AFROG is trying to innovate to ensure that we reach these women faster. And this story will be told by another woman who traveled thousands of miles to reach radiotherapy. One of the women is Akiru. She's a 47-year-old mother from Turkana County. She has 4 children.
And if you guys know, Turkana is one of the remote counties in our country. And when this Akiru notices some abnormal symptoms for cervical cancer, like bleeding, discharge, pain on intercourse, months passed, she didn't know what it was. And she was hoping these symptoms will go away. Then she tried everything. I mean, every woman, when you are sick, you'll try everything. So what did she do? She self-medicates. She asks her best friend. In fact, they are told this is a disease of women in the village, so they hope it will go away. She consults her traditional healer, who gives her concoctions to take. And she confides in her pastor, who prays with her. And for a woman who is on the right path to care, you and me know that this is not cervical cancer treatment. So the coast now gets to her house, and the husband is frightened with the disease. She's having discharge, bleeding, so he leaves. And now Akiru is left alone to take care of her family. Akiru goes to the nearest county hospital. A biopsy is confirmed that this is indeed cervical cancer, and by then the disease is too advanced for surgery, and radiotherapy is the next option. The dress I'm wearing today is courtesy of a woman who traveled all the way from Ethiopia to come to Nairobi for radiotherapy for locally advanced cervical cancer stage 4. After treatment, she went back home and she sent me this dress. So many women, like Akiru, and like that woman who came from Ethiopia to Nairobi for treatment, they leave behind their children, the routine, the livelihood, and the dreams for these children. So, why this matters? Because these women are not dying because of biology. It is because of the broken path. And this pathway is broken both inside the radiotherapy center and outside the hospital. And where timely care is available, many women, more than what we are seeing, the 60–50%, are surviving. And that is what the enhanced study is trying to address by trying to innovate shorter treatment fractions. And with the technology also, we are going to use AI to speed up treatment planning. So this study was trying to show whether shorter fractions are efficacious, reduce toxicity, and maybe ultimately improve survival. This was a phase 3 study done at Kenyatta National Hospital Oncology Center. We randomized patients to 45 gray in 25 and brachy 8 gray times 3, while the study arm we gave 45 in 20 gray and brachy 9 gray times 2. There's a lot of evidence that is coming up about hypofractionation in cervical cancer, and one of the studies was done by none other than Dr. Komen at Wits, where he gave 40 gray in 15, I think in 16 fractions. And also we have the heroic studies which are also trying to hypofractionate. So they're trying to see how, if we can shorten the treatment for these women who are leaving families behind to seek care. The study was meant to accrue about 140 patients. We only reached 73, and we stopped because the machine broke down. So you know, you recruit. Now when you start treatment, they can't. The machine is broken. So based on this, we just recruited fewer patients. And in terms of the distribution of the stage, most of them were stage 3B and above. We also wanted to see the burden of HIV, and one of the the finding was that for cervical cancer patients, cumulatively for both the arms overall, 23% were HIV positive. And we compare this to the general population from the statistics, we see the general population is around 4%. So it means probably, though the numbers are small, like HIV could be, or these women, because when they have HIV, they go for screening. Maybe that's why we are picking up more, but we need more research to see why we have a higher prevalence of HIV in cervical cancer. Then in terms of side effects, the patients in the shorter treatment fractionation had fewer dermatitis. However, for all patients, most of the side effects were grade 1 and 2. In terms of the other adverse events, the side effects patients reported, it was mainly loss of appetite, vomiting, diarrhea, fatigue, nausea, constipation, and anemia. And it's important to look at this slide because it is calling out for multidisciplinary care, and nutrition is very key when these patients stop eating. In terms of treatment delays, so many of these patients delayed treatment because of machine breakdown. This was followed by blood transfusion. In fact, every time I had a patient I'm recruiting and the HB drops, I'm like, oh my God. Because you have to send them away to be given the blood transfusion. Then for chemotherapy, we saw that for the 5 weeks which was the study arm, the 45 in 25, the one in blue at the far end, you can see majority of the patients managed to get 4 cycles of chemotherapy. But when we went to the 5th cycle, fewer patients completed 5 cycles. One of the reasons because if you miss your radio maybe this week, and by the time you reach chemo the following week, you find the 4-week patients could finish radio early, and when you send them for chemo, the nurse is like, no, you've already finished your radio. I mean, which is reasonable. We can't give chemo. Now we book you for brachytherapy. So what is coming out is majority of the patients could manage 4 cycles of weekly cisplatin. So what did our study achieve? I think in terms of completing, most of them completed radiotherapy, the external beam. The toxicity was comparable in both arms. HIV, when we look at the patients who've succumbed to the disease, HIV had no impact in terms of accelerating death for the patients. So I think with the use of ARVs, patients are doing very well and comparable to the non-HIV patients. So when we look at the other follow-up outcomes, this study we started recruiting in April of 2024. So we are just down 2 years since. And when we look at the far end, the death rate, we see for the short arm, the 45 in 20, 22% of the patients have succumbed, while in the long arm, the 45 in 25, 27%. So not much difference. In terms of recurrence, it's also statistical, not different. So we are still doing long-term follow-up, and we'll give updated results as we go on. So some of the limitations we had is the slow accrual, as I told you, chemotherapy completeness, machine breakdown, and then this is just a single center report. This may inform policy, whereby these patients need a lot of supportive care. They get sick, they go to hospitals, but the medical fraternity maybe fails them. So there's failure both inside and outside, and also involving the nutritionist in the care, improving the access, because the waiting time, when we were enrolling these patients at our hospital, the waiting time was about a month. So if we treat more patients within a shorter period, we reduce that waiting time. And also financial protection. And some of the patients, from diagnosis to radiotherapy, as I was trying to analyze the data, they have taken 110 days from diagnosis to the first radiotherapy. So, for the next woman with treating smarter, maybe patient navigation, which we are doing at Kenyatta National Hospital, we may improve the outcome of these patients and also work towards cervical cancer elimination as we look to the next decade, as we strive towards the World Health Organization cervical cancer elimination strategy. I want to take this opportunity to appreciate the people who supported me in this study. The names are not showing clearly, but the study team in KNH and all the patients who actually agreed to enroll on this study. Thank you very much.
Thank you, Dr. Nyongesa, for a brilliant presentation. Just to wrap up her presentation, the take-home message is, in our public facilities, even in private facilities, our workload, our number of patients who line up for our LINAC machines are huge. So the idea of thinking on the hypofractionation in the reduction of the duration of treatment, this has been approached in many centers, including my very good friend can remind me, Dr. Melly, in National Cancer Institute of Cairo, when we were doing the fellowship in radiation oncology, we were pushing most studies in hypofractionation in order to clear the queue. So the take-home message from the enhanced study, it is possible to get non-inferior outcomes when we focus on hypofractionation. Thank you very much. Thanks again, Dr. Nyongesa. Dr. Zahra, my co-chair, my colleague, please welcome and introduce Dr. Gladwell Carey.
Morning, everyone. Such a beautiful Friday. So I'm here to introduce one of my senior medical oncologists, Dr. Gladwell Carey, who is a distinguished Kenya medical oncologist with over 2 decades of experience. She's currently the president of KESHO, and she'll be taking us through the topic of the role of PARP inhibitors in prostate cancer. Welcome, Dr. Carey.
Thank you very much. It's a privilege to be introduced by Dr. Zahra. We have great talent in the field of radiation oncology, and I think at the MP Shah Cancer Center they're doing some great work, including SBRT for metastatic lesions, which is very useful for us. This morning, I have the task of discussing a topic that is more medical regarding the drug use in castrate-resistant prostate cancer, and I'll talk about the use of PARP inhibitors. So very specific topic. So I wanted to start and just say that there is a shift in the treatment of prostate cancer where we're moving from the common hormonal and chemotherapeutic agents that we use, which are still applicable in early disease or adjuvant treatment, But as the disease advances and in castrate-resistant disease, we're using more to biomarker-driven targeted strategies. For example, the homologous recombinant receptor gene mutations occur in 20 to 25% of metastatic castrate-resistant prostate cancer. And castrate-resistant prostate cancer means that the patients are no longer responding to the hormonal suppression of testosterone. So whether you're giving them Zoladex or abiraterone or Casodex, their cancer is progressing. And these mutations increase when they become castrate resistant. So some of the breakthroughs that we've seen, when our options are finished in use of hormone medicine and chemotherapy, are PARP inhibitors, and they address specific genetic vulnerabilities, and they offer targeted options that actually improve cancer outcomes, prostate cancer outcomes. So 1 in 4 of metastatic castrate-resistant prostate cancer patients will have that actionable HRR gene, the homologous recombinant gene alteration. This will make it a molecular target that will help the treatment in advanced stage. So these PARP inhibitors are a class of targeted therapies that block the poly-ADP ribose polymerase enzyme to prevent cancer cells from repairing damaged DNA. And ultimately, this cancer cell will die. They've been approved for metastatic castrate-resistant prostate cancer. And in these patients, they have that genetic abnormality of the homologous recombinant repair gene. And this HRR mutation is usually the BRCA1 and BRCA2 mutation. So the rationale and mechanism of action is that these tumors, when they have the HRR deficiency, when that repair is abnormal, they commonly have the BRCA1 and BRCA2 mutation. And they rely heavily, if they have that mutation, they rely on the PARP enzyme to fix the single-strand DNA breaks. But now if we block that enzyme from repairing, what will happen is that we'll have a fatal double-strand DNA break and the cancer cell will die. So we sometimes combine this cell death mechanism with the androgen receptor signaling that is linked to DNA repair. So sometimes we combine androgen treatment, like abiraterone, together with these PARP inhibitors so that we can kill the cell. So when we look at the way that we have what we call the single-strand browns, the PARP enzymes are very useful in repairing this break. So we know that in the evolution of a cell, there'll be some abnormalities that cause the cell to break down. And what the body does is that it has a system of repairing that cell. Now, what people discovered is that instead of repairing, we can be able to block that repair so that the cell dies. And that's when they get those single-strand breaks, they rely on the PARP enzyme to repair the cell. But what we do is we inhibit that repair. They prevent the repair, and what happens is that the PARP enzyme is trapped on the DNA stalling replication, and they converge these single-strand breaks to form double-strand breaks, so the cell will die. That's what we call lethal blockage, and these tumor cells, which have BRCA1 and BRCA2 mutations, we cause an error in the repair, and we cause genomic collapse and cell death. And you see, in cancer treatment, what we want to do is to kill cells. So PARP inhibitors have what we call synthetic lethality, lethal or killing in cancer cells. So you can see in that demonstration that the BRCA1 and BRCA2 mutations are on the homologous recombinant repair gene. so it's abnormal. So what it does, it's relying on the enzyme, the polymerase ADP ribose enzyme, to be able to repair, to keep the cell alive. So you can see even there in the BRCA mutation, if it's mutated, it's relying on the PAP enzyme. Now, when we block that PAP enzyme, what will happen is that we'll have cell death using the PAP inhibitor, and we kill the cancer cell. So what happens with PAP inhibitors? We have enzymatic inhibition, and we trap the enzyme, and we cause cell death. So to be able to have a scientific rationale on this mechanism of action, we must do biomarker testing. So we must do genetic testing, both somatic and germline, mandatory to be able to identify these human recombinant repair genes. Like we have to identify who has this mutation: BRCA1, BRCA2, ATM, PALB2, CHEK2, and CDK12. These have the highest efficiencies in being able to bring cell death. Patients with the BRCA2 alterations have the greatest clinical benefit, significantly improving survival because we kill the cancer cells. So PAP inhibitors are very effective drugs as monotherapy. But I'll also talk about the new combinations that are coming up. So they are very useful in patients who have metastatic castrate-resistant prostate cancer with HRR alterations. So this genetic testing is quite important so that we can be able to make treatment decisions. So as I'd mentioned earlier, when we have metastatic prostate cancer, we rely on chemotherapy, on hormonal therapy to keep our patients alive. But we all know at some point along the road, these patients are going to become castrate resistant, meaning that we cannot use abiraterone, we cannot use Casodex, we can't use Zoladex, we can't use enzalutamide. So what are we going to do? And that's when we investigate other methods using their genetic tests. So those are some of the somatic changes that we have. 23% of men with metastatic castrate-resistant prostate cancer will have these DNA repair aberrations. And the incidence of these alterations is higher in men with metastatic prostate cancer than those with early disease. We also have the germline mutations, which will be 12% of men with metastatic prostate cancer will have germline mutations in one of the 16 genes. Now, we do know that people with these mutations have a worse outcome. And some of these studies you can see on the graphs, the Kaplan-Meier curves, you can see those who are non-carriers, the orange line, they survive longer. Those who have the BRCA1 mutation are a little better than those who have the BRCA2 mutation. So you can see here is a comparison of the three, and you can see the big difference between the BRCA1 and BRCA2 mutation carriers and those who are non-carriers and have castrate-resistant prostate cancer. So after many studies that were done, like for example, the PROFOUND study looked at the use of olaparib for the treatment of these patients who had mutations on the HRR gene, and they had progressed after the use of abiraterone, Casodex, with Zoladex, enzalutamide, and some of them had even had chemotherapy. So these two drugs, olaparib and later rucaparib, in the Triton-2 study, showed that patients with those BRCA1 and BRCA2 germline or somatic mutations who had been previously treated with chemotherapy did very, very well with some of these new drugs. You can see the difference there in the PROFOUND trial, that there was increased survival in the patients who are given olaparib, and they were able to survive longer in both the disease-free survival and the overall survival. Then, of course, we had the rucaparib, which was in the Triton 2 study that also showed significant benefit in some of these patients. So, of course, next came, are we going to get a better outcome if we combine them? Remember, they are castrate resistant. But you're asking yourself whether there is a synergistic mechanism action for PARP inhibitors and the androgen receptor signaling inhibitors, the ARSIs. So PARP inhibition was shown to upregulate the androgen receptor signaling, and it enhanced the mechanism of action of abiraterone. So what we saw is that if you use olaparib and abiraterone, we get a better outcome and longer disease-free survival. So we can use olaparib and abiraterone, niraparib and abiraterone in the magnitude study, and also talazoparib with enzalutamide. All showed increased benefit when they were used in combination. And those are some of the curves showing a difference in disease-free survival of 19.5 months as opposed to 10.9 months with use of the combination. And that too also shows an increased overall survival and prevention-free survival. So we know that some of these drugs have been used in other malignancies. For example, we know that talazoparib has been used in breast cancer, niraparib has been used in ovarian and fallopian tube cancers, olaparib in breast and ovarian cancers, and of course, rucaparib in primary peritoneal, ovarian, and fallopian tube cancers. So in the current landscape, olaparib is approved for metastatic castrate-resistant prostate cancer that has those germline mutations, and also rucaparib is also approved, and also we have the combinations with use of abiraterone and enzalutamide. So the rationale, as I've explained, is because when we combine, we get upregulation, meaning somebody was already resistant to abiraterone, but when we use them in combination with olaparib, there is upregulation, or the receptors that had lacked before and become resistant become available to be blocked. So those combined effects leads to greater anti-tumor activity on the HRR mutated tumors and also the non-HRR mutated prostate cancer tumors. So I just wanted to mention a little bit that there are side effects to the drugs like olaparib, and we can have anemia, nausea, vomiting, diarrhea and constipation, and a lot of fatigue, and sometimes even pneumonitis. You can see the list and the grades of some of the side effects we had. The other thing that was noted is the development of cardiac failure and thromboembolic events. And it's very important to actually be aware when you're treating some of these patients. We all know on the basic, like the hormone testosterone increases basal metabolic rate. When we block it, these patients get overweight, their cholesterol increases, they have water retention, and remember, they also have other comorbidities, and these are some of the side effects that you'll see. I think those are similar with what I've talked about. So they also did an analysis about the quality of life, and the combination of olaparib and abiraterone resulted in no detriment to the quality of life, helping many patients to stay on therapy. Those of us who treat them day to day know that these are treatments that can carry on for years. But as I've mentioned, you need to watch out for bone marrow suppression, give them neuters, give them elbonics, and also look at the factors that cause fatigue. Sometimes it's purely because of the drug, but sometimes you need to investigate other factors that can make patients tired, like heart failure. So some of the ways that we would manage some of these side effects is to reduce the dose. From olaparib 300 milligrams twice a day, you reduce to once a day, or you give them treatment breaks so that they can be able to recover their bone marrow function and also some of those side effects. The hypotension and cardiovascular side effects as well, you closely monitor for other cardiovascular disorders and also giving them a break, monitoring their blood pressure and their heart rates, and also managing their antihypertensive medication and adjusting their doses. I think I've mentioned all those, including the nausea, the vomiting. Sometimes we use ondansetron, and then we have to escalate to some of the 5-HT3 inhibitors like aprepitant. And of course, lifestyle modifications, like using other things like ginger, oil, acupuncture to reduce some of these nausea problems. We use all these mechanisms. And so what is new now is that we were using these PARP inhibitors for metastatic castrate-resistant prostate cancer, but there are now studies trying to see their use in earlier prostate cancer. There are also studies looking at combinations of PARP inhibitors with immunotherapy. And they're using the PD-L1 status and the tumor mutation burden to see who will benefit greatly. They have the HRR mutation, but do they have PD-L1 positivity? Do they have the tumor mutation burden being high? Then, of course, there's a big study being done on talozarib and avelumab. Avelumab is an immunotherapy. So this combination currently are at phase 2 and phase 1, and we are waiting for the jury on that combination in treatment of some of these patients. PARP inhibitors are also under investigation to see whether they can be used together with chemotherapy, and some of the drugs that are under study is the use of PARP inhibitors and temozolomide, and we shall wait to see the outcomes. So in summary, these are the synergies and the emerging first-line treatments that I've mentioned, the use of PARP inhibitors with hormonal agents, immune combination potential, and of course the biomarker selectivity. And then after that, we have to look for ways to overcome resistance. Because we all know eventually the disease develops resistance to olaparib and the rest. So probably the take-home message today, my dear colleagues, is that it's mandatory to do molecular screening. All patients with metastatic prostate cancer, as data has it today, should undergo early germline and somatic HRR genetic testing. Number 2, we need to look at optimized sequencing of using PARP inhibitors, preferentially in the biomarker-positive patients, to achieve prolonged survival before alternative heavy toxic chemotherapies. And of course, we should be very proactive in managing the side effects, the toxicities, the hematological toxicities, and the GI toxicities, and also the fatigue. And with those few remarks, thank you very much.
Thank you very much, Dr. Gladwell-Chiari. We can't agree more. For the last 5 years, precision oncology, especially in prostate cancer, has taken a center stage. In the interest of time, I'd like to introduce our international delegate who's currently on Zoom. She's Dr. Pelika Ford. She's an oncologist from South Africa with extensive experience in genitourinary malignancy. So she'll take us through a landscape of management of the metastatic prostate cancer. Please, doctor, welcome. Hello, hello, Dr. Palika. Can you hear us? Please welcome.
Good morning, sir. Good morning, everyone. I hope you can see me. I'm trying to share my slides. I'm not very good with this. Am I able to share my slides?
We can now see your slides.
Okay, thank
But
you very much.
you can go on full slide.
Okay. So, good morning, gentlemen. Good morning, ladies. Good morning, colleagues. Thank you very much for this honor to present my topic.
Excuse me,
I've
Dr.
been tasked.
Pelisa.
Yes, sir.
On your PowerPoint screen, you can start from the beginning.
Okay.
From beginning. No, not that one. From beginning. From
That's the first
beginning.
slide.
And then from beginning, there's an icon from beginning. Not that one. The first one. No, up again.
Okay.
No,
Current slide.
no, from, yeah, good, thank you.
Okay, all right. So I've been tasked to speak on the role of external beam radiotherapy in oligometastatic prostate cancer. I have no disclosures. I thought to approach this topic by giving a little bit of a background where we come from and then attack from the primary prostate EBRT in de novo oligometastatic cancer or low volume metastatic castrate sensitive prostate cancer, and then we move towards the metastasis directed treatment. Our background really comes from our long-term and established use of external beam radiotherapy in the treatment of primary tumor in localized prostate cancer. We have extensive data on that, and that forms the basis of our definitive and curative treatment for external beam for prostate cancer. However, when we start to talk about oligometastatic prostate cancer, our background of use of radiotherapy involved only castrate-sensitive prostate cancer. And the other important thing to consider, as this is what our data supports, is the number of lesions. This is based on the charted trial where high metastatic burden was defined as 4 or more bone metastases with 1 or more outside of the vertebral bodies or pelvis or visceral metastasis or both. So importantly, low volume only includes patients with less than 4 metastases. And then the other important distinguisher is that we have 2 distinct evidence bases. The first being for prostate external beam radiotherapy in our low volume de novo disease, which has been backed with good survival and disease control benefit, and that's well established. Then we have a different topic altogether, which is metastasis-directed external beam radiotherapy. And unfortunately, in this area so far, our best data is phase 2 data. And I guess the pathophysiology or what the philosophy of this is to try and see if we can delay progression and delay systemic escalation. And particularly, as we know, in patients with prostate cancer who have metapronous oligorecurrent castrate-sensitive prostate cancer. So after having the first line of treatment and we given the patient treatment, the patient recurs, and we have to then treat again. So the idea is that we want to prolong these islands of good health or disease control as much as possible, giving the patient a longer life with less treatment and therefore a better quality of life. So it's very important for us to remember that our evidence that we have is in synchronous oligometastatic and metastatic castrate-resistant prostate cancer. These two particular groups are limited, and so we have to use radiotherapy more selectively. So looking at primary prostate external beam radiotherapy in a patient who has de novo oligometastatic or low volume castrate-sensitive prostate cancer, our base is the STAMPEDE trial. In this trial, we were shown that there was improved overall survival in patients who had low metastatic burden, but not the patients who had high burden. And when the final analysis was done, after the initial analysis at 5 years and a further analysis done, we saw that in patients with low burden, there was no detriment in the quality, the global quality of life, and very low long-term grade 3 or more urinary or bowel toxicity when patients were treated to the prostate, a primary prostate disease, despite the presence of the metastasis. At the 3 to 5 year analysis, we had shown that there was improved failure-free survival with radiotherapy with a hazards ratio of 0.76. And importantly, in that particular trial, the regimens that we used was 55 grain, 20 fractions, and then which was the initial fractionation, and later on, once SBRT picked up, the 36 grain, 6 weekly fractions was then allowed. The results of the STAMPEDE trial, when we look at the overall group, overall survival, doesn't seem to indicate much of a difference between the control arm and the radiotherapy arm. However, when these two, when the cord is teased out into the patients with low volume and those with high volume, in the middle column, we can see a definite improvement in overall survival and failure-free survival in the patients who had low metastatic burden. So, sorry, and then in the overall group, we see that the patients who were in the control group slightly had the proportion of the patients who had life-prolonging treatment thereafter, after they had received this treatment, was slightly higher than those who had had radiotherapy. So giving radiotherapy to the prostate in a patient who has oligometastasis improves the patient's quality of life in the long term and delays the requirement for additional treatments thereafter, or at least prolongs that period. Then we look at the primary prostate radiotherapy in patients with de novo oligometastatic disease or low volume. Another study that was done, the second study after the STAMPEDE trial was the HORROR trial. And here they were looking at the effect of androgen deprivation alone versus androgen deprivation combined with radiotherapy to patients who had bone metastasis, bone-only metastasis. Important, this was a prospective randomized clinical trial involving 432 patients, and this was the definition of the was that the patients had a PSA of more than 20 nanograms per mil. They had to have primary bone metastases, and this was according to conventional imaging. So So importantly, not involving PET at that time or PSMA. The primary endpoint was overall survival, and secondary endpoint was also time to PSA progression. The patients were treated with 70 gram per 5 fractions to the prostate gland over a 7-week period, or given an equivalently, a biologically equivalent dose of 57.76 gram 19 fractions, 3 times a week for 6 weeks. The results of the horror trial did not show an overall survival benefit in the overall group in those patients who had metastatic disease, but in the patients, in all the patients, there was improved time to PSA progression, the hazard ratio of 0.78, and then at a later stage, past the 5-year mark, later analysis showed that there were fewer local events and longer time to local intervention with prostate radiotherapy. So treating the prostate improves the patient's longer term requirement for interventions with a hazard ratio of 0.61. That is on the right, you can see in the forest plot that 2 distinct, or at least 3 distinct categories or variables, metastases that were higher than 5 to 15 if you look over there, and then in patients who had a poor performance status, these patients did not benefit much, but everyone else benefited. The stopgap then put the Stampede trial and horror trial, and giving us a patient population of 2,126 men. Here, there was still no overall improvement in survival or progression-free survival, but there was an overall improvement in the biochemical progression and failure-free survival. This actually translated to a 10% benefit at 3 years, and also quite significantly a 7% improvement in 3-year survival in those men who had fewer than 5 bone metastases. As a result of this particular systematic review and meta-analysis, the NCCN then recommended radiotherapy to the primary tumor with systemic therapy for most patients who have synchronous oligometastatic castrate-sensitive prostate cancer. And also the AUA does recommend that clinicians offer prostate radiotherapy with ADT in patients who have low volume metastases and hormone-sensitive prostate cancer. So then we move over then to the next group of patients. These are patients where we want to use metastasis-directed radiotherapy or SBRT. The best randomized data that we have is in metachronous oligorecurrent castrate-sensitive prostate cancer. So this is patients who's having recurrence at different times after the metastases happen after the primary tumor has been treated. We have the Oriole trial, which is a phase 2 trial. And these patients had recurrent hormone-sensitive prostate cancer with 1 to 3 metastases. They were treated with SABR versus observation. And this treatment reduced the 6 months progression from 61% with observation to 19% in those patients who were provided metastasis-directed radiotherapy or SBRT. And it improved their progression-free survival, but did not reach, it was not reached in the treated arm versus those patients who had observation, who had progression-free survival for about 5.8 months. Importantly, there were no grade 3 plus toxicity. This is the Kaplan-Meier curves for the Oriole trial, and we can see a vast difference between SABR in the blue-green line versus observation in all different clinical outcomes that were measured. when we look then at metastasis-directed EBRT, SBRT plus ADT, now, because previously they were just observed, and the standard of care was then that patients received ADT. We have 3 trials, which are all unfortunately phase 2 trials: the STOMP trial, the Radiosa trial, and the EXTEND trial. And if we look at the first, the STOMP trial, metastasis-directed therapy improved the median ADT-free survival from 13 to 21 months, and pooled long-term analysis of the STOMP plus the Oriole trial showed a longer PFS with MDT, and the hazard ratio was 0.44, quite impressive. The Radiosa trial showed a median clinical progression-free survival of 32.2 months versus 15 months, almost a doubling, if not more, for the metastasis-directed arm versus, and also giving the patients 6 months of ADT versus giving them radiotherapy alone, and the hazard ratio here was 0.43. In the EXTEND trial, the median for PFS was not reached versus the 15.8 months in the patients who received ADT alone. The continuous ADT basket later showed a 47 versus 22 months hazard ratio of 0.5, and combined analysis showed 36 versus 17 months with a hazard ratio of 0.45. Also quite significant. These are the Kaplan-Meier curves for the 3 trials, and we can see there in all these trials that SBRT together with ADT in the red outperforming SBRT alone. So what does this translate to for us? We then have the NCCN mainly recommending that for de novo low volume metastatic castrate sensitive prostate cancer, prostate EBRT is evidence-based and should be integrated with systemic intensification. So whereas that, despite the fact that we have so many systemic treatments, and it's quite encouraging that we can use triple therapies, we can go to the olaparibs, we do our patients a disservice if we do not treat the prostate with radiotherapy. And then for metachronous oligorecurrent castrate-sensitive prostate cancer, offering EBRT or SBRT to all visible sites is supported mainly to prolong progression-free survival and delay ADT or escalation. And the NCCN considers MDT with or without short-term ADT as an option. For patients who have synchronous metastasis-directed radiotherapy to metastatic sites, there is randomized evidence which shows is still remaining preliminary. But however, experts on MedNet suggest shared decision-making for trial enrollment when feasible. For oligometastatic castrate-resistant prostate cancer, NCCN does allow metastasis-directed radiotherapy only with recommended systemic therapy, not as a substitute for. You have it's combined. So technically, NCCN also prefers SBRT for the metastasis-directed radiotherapy as opposed to giving a usual palliative dose of, say, 3/10. And then when we do that, it's important that we pay attention to the OAR constraints and the daily 3D imaging guidance. And when treating nodal metastases or elective nodal coverage to the involved chain with boost to the gross node is generally recommended. So that is how we apply this data to our patients. Thank you very much, and these are my references. I'm happy to participate in any discussion. Thank you very much.
Thank you so much, Dr. Pelisa, for the extensive presentation on role of radiotherapy in low-burden metastatic prostate cancer, and also the role of stereotactic body radiotherapy in metastatic disease and oligometastatic disease. So we shift gears to rectal cancer. We are going to be discussing the OPRA trial, organ preservation in rectal adenocarcinoma. This trial was first published in ASCO 2020, and since then a lot of strides have been made and taking it into the clinical practice. So it's my honor to introduce Dr. Alex Muturi, who is a consultant general gastroenterologist and colorectal surgeon at the Kenyatta University Teaching and Referral Hospital, an adjunct lecturer, Department of Surgery at the University of Nairobi, laparoscopy and endoscopy instructor, and a patient safety cancer center and medical educator advocate. Dr. Muturi.
Thank you for the kind introduction. I wish to introduce the actual presenter, who is one of my mentees. It's called Dr. Maureen Nganga. It's one of my senior residents who we are mentoring to take over from what we are doing. So, karibu Maureen.
Good morning. We are very excited to present our findings for the watch and wait protocol that we instituted in our facility at KUTRRH. As introduced, I am Maureen Wanjiru Nganga, a third-year COSEXA resident at KU, and I'm co-presenting with Dr. Alex Muturi, our colorectal surgeon. So the management of rectal cancer has undergone quite a transition. We know traditionally the approach was that we do surgery first and then adjuvant radiation therapy and chemotherapy. But with progressive strides, we've moved from even the neoadjuvant radiation therapy to now doing total neoadjuvant therapy, where we give our patients radiation as well as systemic chemotherapy. And then now, should it be required, we get surgical intervention for these patients. What was noted with the introduction of total neoadjuvant therapy was that for a subsection of these patients, they were able to achieve what was referred to as complete clinical response. So that now in evaluation with endoscopy, clinical evaluation via DRE, as well as an MRI, they were noted to not have the tumor present. And this set the precedence for what is now termed the watch and wait protocol. So, watch and wait protocol is a surveillance protocol. It is not an avoidance of surgery per se. It is more an organ preservation pathway where we monitor these patients very closely, which is what we instituted in our facility. So we had 4-monthly DRE, CEF, flexible sigmoidoscopy, and pelvic MRI for the first 2 years, as well as 6-monthly CT scans for surveillance, so chest, abdomen, and pelvic CT scan. The reason for the very heavy surveillance in the first 2 years is because this is the time when recurrence is highest, the point when you have maximum regrowth. After that, the follow-up is done every 6 months to 1 year. And so we looked at our patients between March 2025 to June 2026. These are the patients we enrolled. We had a total of 14 patients. These are patients who underwent total neoadjuvant therapy for rectal cancer. And following the total neoadjuvant therapy, they were noted to have either complete clinical response or near complete clinical response. Of the patients, we had 10 male patients and 4 female patients. All our patients were either ECOG 0 or ECOG 1. Some of the patients had comorbidities, but all the patients were eligible for surgery should it be required. In terms of the tumor characteristics, Most of the patients had rectal adenocarcinoma, but 2 of our patients were actually noted to have colon adenocarcinoma, but within the rectum. Most of the patients had T3 disease, that is 12 of our patients, and most of the patients had N1 disease, about 7 patients. Of note, despite the fact that traditionally, watch and wait protocol is not instituted for patients with metastatic disease, we had 1 patient who inadvertently had M1 disease, but for this patient specifically, they had indeterminate nodules in the lung in the initial evaluation, but this was later noted to progress despite there being resolution in the primary tumor. So our patients underwent induction chemoradiotherapy, which the preferred mode for watch and wait is consolidation chemoradiotherapy. However, we know the challenges that we face with radiotherapy. So for the benefit of our patients, we just started them on induction chemoradiotherapy, and we were able to actually achieve clinical complete response in 8 of our patients, with 6 of our patients achieving near complete clinical response. Now, for those who achieved clinical complete response, to date we have 7 patients who are still on follow-up and are maintaining the complete clinical response. And of our patients, of all our 14 patients, 7 of the patients underwent surgery. From the patients who underwent surgery, 4 underwent surgery due to tumor regrowth. This is in keeping with the published data that shows that about 25 to 35% of patients under the watch and wait protocol will need to undergo surgery due to tumor regrowth. And of the patients who underwent surgery, 3 of them underwent surgery due to preference. Because as we can imagine, it is a very labor-intensive, very financially taxing, and even psychologically taxing process to undergo the surveillance as we've detailed it. At this point, we wanted to just give a demonstration. So that is a colonoscopy. It's a sigmoidoscopy for a patient who had near complete clinical response. As you can see where the cursor is, sorry, it keeps moving, but I'm sure we can all appreciate that there is ulceration at this region. Ulceration with what looks like a bit of active bleeding. So that is a patient who had near complete response. So you can see that the tumor is not, we are not seeing a very obvious tumor, but we are seeing the ulceration and there's a bit of stricturing around that area. So this is a patient who will follow up, but likely, based on the previous patients that we've had, the patient may need to undergo surgery. However, when you see this patient now, here we have, as you can see, we don't have any obvious tumor, there's no obvious ulceration. We have a bit of a flat white scar. I hope you can see the cursor. I don't know if, I apologize. There's a bit of a flat white scar at the region of focus of the colonoscopy with just a little bit of erythema. So this is a patient who achieved complete clinical response and is a very good candidate for just following up with a watch and wait protocol to see if we can be able to preserve their organ. This is the rectum in this case. So a bit of information about our patients. So 50% of our patients underwent surgery, of whom 3 underwent low anterior resection and 4 underwent anterior perineal resection. Of note is that one of the patients who underwent low anterior resection had such severe complications that they opted to eventually undergo anterior perineal resection. So we are seeing that despite the fact that surgery often is curative, it is associated with such severe complications that patients sometimes are unable to tolerate the complications that come with the surgery. Just a side note on some of the other patients, about 14 months after APR for one of our patients, we had one developing an ascending colon mass, and they subsequently required a right hemicolectomy. Then we had patients, interestingly, one of the ones who had near complete response, who opted to undergo surgery. The pathology specimen actually came back having pathological complete response. This is in keeping with actual data that has been shown that when you have near complete clinical response, with time, about 19 months in, is when you're able to properly determine if the patient can get complete clinical response or not. In our small cohort, we had one patient who unfortunately passed away They had an anastomotic leak with subsequent pelvic and abdominal infection, and they unfortunately did not make it. So this is our take-home message from this presentation, that the watch and wait protocol is actually a very viable program for organ preservation for patients with rectal cancer who are able to achieve clinical complete response. And the basic premise is that in the first 2 years, you need to have very strict surveillance to make sure that you pick up anyone with regrowth. And for these people who have regrowth, then in that case, you go through salvage surgery, which has been shown to be very successful and achieve good oncological outcomes. So we are not really compromising care for these patients at all, but we're offering them a longer period for which they're able to have preservation of the rectum and have just good quality of life. Thank you so much.
Thank you, Dr. Maureen, for a brilliant presentation. I think the Q&A session has been postponed, so I would love to hand over to my senior brother here, my senior colleague, Dr. Jess Opacus, who will be taking us through the next session. In the interest of time, the organizers, the scientific committee, would you want us to have a short discussion, or? Dr. Jess.
Thank you, Dr. Ari. Good morning, everyone. Yeah, maybe you can just stand up for 1 minute and stretch. Yeah, so you can lift your right hand, the left hand. Karibuni, Nairobi. So my name is Dr. Jesse Opacus. I come from another town. It's called Eldoret. Karibuni, have a seat. Thank you very much for your, yeah. So today it's a great honor to be with you guys, and I think I know most of you. We are very happy today, at least, to have our team prepare this meeting, and we'd like to start with the next session. So I think Dr. Melly is around. Yeah. So the AFROG is a great chance for us actually to evaluate and see what we do actually in terms of being Africans, in terms of being Kenyans, and in terms of our local empowerment, and a way of actually organizing ourselves to contain and be able to control our response to the challenge of cancer. So I would actually encourage us to network. I will encourage us to meet each other, develop connections, and be able to enhance our approach, and in terms of being able to improve our cancer care. Yeah. So in the meantime, I think we can do Q&A, question and answer for the panelists who have just been here. So karibuni, Dr. Kiarie, Dr. Nganga, and Dr. Muturi. Yeah. We'll just add a short change because I know our Waziri is on the way. So we can take this session, and Dr. Zahra, maybe then. So I will want us to start with a question. I would like to start, and one of the questions which I'll ask is,
thank you.
Dr. Kiarie, could you let us know, like, how accessible these therapies, when you talk about the PARP inhibitors for patients with prostate cancer, and what steps have we made to ensure that when a patient is getting something like olaparib and abiraterone or enzalutamide, how do we make these more accessible to our patients? Thank you.
Thank you very much, Jesse, for that question. Now, we know that cost is a big handicap, so I'll address about availability in the pharmacy and affordability. Now, and accessibility starts from being able to do the test. How many of our patients are going to be able to do the HRR? How many are going to be able to do the BRCA1 and BRCA2 mutation? And we know that that testing is not covered by SHA, but is covered by the other regular insurance, and they have to pay that out of pocket. So the test is available. Many of the ordinary labs will outsource. Even the big labs send the BRCA, the HRR testing abroad, and so the turnaround time is close to 2 to 3 weeks. So when you're starting treatment for this patient, it is very important to request some of those tests. Patients can tell you, let me prepare myself to be able to afford, and therefore it gives you a little time as you start the other treatments. So Jesse, one is accessibility to be able to do the tests. And you can imagine they are struggling with all other things. They probably need radiotherapy, they probably need to check their PSA, they probably need a prostatic biopsy first, so it's quite a lot. Availability, the drugs are available. Olaparib is the commonest drug and the oldest drug. We have the original, and we also have available generics, and SHA is able to cover for the monthly use of the drug. Of course, when you use olaparib and enzalutamide, or elaparib together with abiraterone, the cost increases, but there is SHA reimbursement, and the drug is available for use. I know probably in the outskirts, outside the main cities, the main areas like Kisumu, Mombasa, Eldoret, probably the availability goes down, but I have seen that even patients in Meru and Nakuru are able to access these drugs. And sometimes all you need is to do the prescription, do the SHA application, and work with your pharmacy to be able to order the drug. So to your question, Jesse, finance may be the big impediment, especially with the testing, but the drug availability is there. Thank you.
Thank you, Dr. Kiarie. Just a follow-up question. The program from AstraZeneca, does it cover both germline and somatic mutation testing?
Good question, Dr. Zara. I don't think they cover both. I think they cover somatic, but I can be corrected. I don't know if anyone else also knows.
Anyone from AstraZeneca who will be able to answer that? Yes.
Okay. Sorry, just to repeat, I think for us at Aga Khan, it's the germline that has been discounted heavily.
And Angela, is it available everywhere, or we have to send them to Aga Khan?
I think so far the collaboration is with Aga Khan. I'm sure it'll expand soon, yeah, but heavily discounted.
Thank you very much. My question goes to Dr. Alex and his team. Beautiful work. I appreciate the work that was done. Very beautiful, and we need more studies like this to help us to enable organ preservation in our patients. But I just have a few queries, and I needed some clarifications on those issues I wanted to raise. You didn't mention the histology groups, subtypes of these patients that responded to the total neoadjuvant chemotherapy, and those who didn't respond to. I would love to know which of the histology types, because we know that there are some histologies, patients with some histologies that will not respond. Those who didn't respond, were they part of the group that didn't respond? I will need some answers to that. Then you didn't tell us if you ran molecular studies on the patients that you had, because we also know that there are some group of patients, particularly those who have the MSI subgroup, that would necessarily not require chemo radiotherapy for their response. And it's interesting to also note that the candidate who had an ascending colon mass after a biopsy after some while showed a complete tumor response, which is almost what we see basically in most of our clinical practice, because masses that show on imaging don't necessarily mean that these patients have a recurrence or they have a progression. So that time is needed and necessary for us to ascertain that treatment was appropriate. Then it's also interesting that we should note the age limits of the patients that were recruited. Are there young adults in those groups, or they were all old patients in their 4th or 5th decades? Thank you.
Before I pass on the mic to Dr. Alex, I'd like to remind our participants to introduce themselves, their station, and keep the question brief so we can get many.
All right, I'm Dr. Ajay. I'm a clinical lead GI Oncology, MedServ, Luth, Lagos.
Please welcome.
That's quite a bit to unpack, but if I respond to the first bit of what histological subtypes seemed to predict either response or lack thereof. So what Dr. Morin did not put there because of the time allowed for the presentation, but among those who did not respond or had a very quick period to regrowth are the ones with the mucinous adenocarcinoma, and also the odds of regrowth or the odds of getting a poor response seemed to correspond to patients with poorly differentiated adenocarcinoma. We didn't put any of the anal squamous cell carcinomas here because the protocol for management of those is entirely different. So the other question is about the age distribution. The median age was 63 years, but increasingly in our center, we see much younger people. As you may be familiar with the early onset colorectal cancer. I would actually say 40% of the patients I see with rectal cancer are below the age of 50. And my youngest patient with rectal cancer is 19 years old, without any predisposing family history or a familial risk factor. Now, I'm kind of sure if I can remember the last bit of the question.
Immunotherapy for those.
Oh yes, about the molecular testing. We do not have universal testing because of the resource constraints. So testing is offered on an individual basis, especially among those who are young, below the age of 50, or anyone with a significant family history. So we may not be able to have molecular profile for all our patients because we don't have that as a standard. But as a surrogate, if you are responding to chemotherapy and you're responding to chemorat, achieving complete clinical response, you're unlikely to have been MSI high because we know that the regimen we use, especially with the capecitabine, this patient with MSI high will not do well with that kind of chemotherapy. So if you're showing very good response, and you probably were MMR proficient. The other something to consider is only about 5% of rectal cancers will be MSI high. So unless we have funding, unless it's taken up by the state, we're not able to offer MSI testing for all our rectal cancer. Thank you.
Maybe just to add up, Dr. Muturi, the study on dostarlimab, I think the patients who are MSI high did achieve 100% pathological complete response on immunotherapy. So maybe we should do something as an African population to be able to test all our patients for MSI before distinguishing which treatment they should receive.
Just quickly respond to that. In our practice, and even when you look at the tumor board practice of Nairobi Hospital, we are very strong on recommending molecular testing for all patients below the age of 50. But resource constraint becomes a major barrier. But let it not be that the patient did not get testing because we didn't request it or we did not recommend it. From our point, we recommend. Let the resource issue be the barrier. The other thing maybe to remind ourselves is IHC for MMR protein is a fairly cheap test. Most labs, whether you're thinking Aga Khan, Nairobi Hospital, or Kalebi, is anywhere between 12 and 15,000 to do the IHC for MMR. So it's quite within reach for most of our patients.
Thank you very much, Dr. Alex Muturi. I just want to highlight a point, just a simple one regarding the pathological complete response. I want to remind my colleagues that pathological complete response has not been validated as a surrogate endpoint for survival. So we need to interpret pathological complete response as a different entity to the survival outcome.
I think for the interest of time, we'll wind up. The main guest of honor is here. So thank you so much to the panel. That was an amazing first session and introduction of the second day of the conference. I'm going to call in the choir. Kindly come up. We need to introduce Waziri, who is on the way coming. Please. Round of applause.
Good morning, ladies and gentlemen. Yeah, before you is Kenyatta National Hospital Choir. This is a group from the health workers from Kenyatta Hospital. We have clinical officers here, psychologists, public health officers who have come together, who love music. They're here today to entertain you with the myriad and beautiful collections from the African culture. I believe that you're going to be blessed and to enjoy the music.
Karibu. Karibu waziri. Yeah. Makofi kwa waziri. Thank you very much. Yeah. Thank you very much. Karibuni.
I'd like to, before we begin our meeting this morning, can we rise up for the national anthem? kindly invite Madam Rosemary to begin with a word of prayer. The choir, let's stay put. We will have one song for entertainment after the prayer. Madam Rosemary.
Let's bow our head and pray. Father, in the name of Jesus, we come before you this morning with thanksgiving, O Lord. We want to thank you for this day, Jehovah God. You brought us here safely. We want to thank you for the planning of this conference, O Jehovah God. It has not been easy, but with your hand, O Jehovah God, we have managed to reach here. We want to thank you for our leaders, especially our Minister of Health, O Jehovah God, who has come to witness this occasion, O Jehovah God, and all the leaders and all the doctors who are here, O Jehovah God. We want to thank you for the good work they are doing for this country, O Jehovah God, especially the line of cancer, which has been a big issue in our country. We want to thank you even for the journey mercies you give to our visitors who have come from far. Jehovah God, we pray even as they go back, you be with them. As we start, we want to start with you. Bless everything, and at the end of it, oh God, we will glorify your name. In Jesus' name we pray.
Our chief guest this morning, Cabinet Secretary, Ministry of Health, Honorable Haden Duale, our Principal Secretary, State Department of Science, Technology, Research and Innovation, our Governor, Kisumu County, Professor Nyang' Nyong'o, the President of AFROG, all protocols observed. Ladies and gentlemen, good morning. We are honored today to have our Minister of Health being our chief guest and to grace this meeting. Our Cabinet Secretary, sir, we will have the Kenyatta National Hospital Choir give us one item as a piece of entertainment, and we will continue with the program. You're welcome. very much, Kenyatta National Hospital, for that great piece. Our Cabinet Secretary, sir, we have delegates from all over the continent, and that was a great piece to invite our guests as well, including yourself. Sir, we want to really appreciate your support through your leadership at the Ministry of Health, and specifically in the area where it's the reason we are here today, in preventing cancer and improving outcomes of cancer care. The investment through your leadership in this space, in this country, which has also influenced what happens in the continent, has been enormous, and we really, really appreciate. A round of applause for our Cabinet Secretary. His vision is great, and I know he's going to speak about that. Allow me, sir, to invite the President of Africa Radiation Oncology Group, Dr. Catherine Nyongesa, who is going to speak to us a little bit about why we are here and why this conference is very important for all of us who are here today. Let's clap for Dr. Catherine, who is also a continental, great person. He's influenced, sir, a lot of us who are practicing in oncology in this country. She is among the premier radiation oncologists. We do appreciate her. You're welcome.
Thank you so much. God is good, and all the time. Yeah, so all protocols observed. Our CS, we're really grateful for your coming. Professor Shaukat, our immediate AFROG president, Professor Tajuddin Olasinde from Nigeria, Professor Nyang Nyong, our scientific chair, Dr. Abeid. And I also want to acknowledge our representative for the CEO of KNH, Dr. Joel Lesan, for being here. So African Radiation Oncology Group is an association that talks about matters cancer and specifically radiotherapy. And in this, we have three musketeers. We have the medical physicists, the radiation therapists, and the radiation oncologists. And we don't work in isolation. We work with the partners, the people who manufacture the radiotherapy equipment. And we are now moving to a new frontier called theranostics, and we are being supported by the nuclear medicine. We appreciate all people who have come here. And I can also add that this conference is hosted by the new kid on the block, the Kenya Radiation Oncology Group. We call them Cross-K, and they volunteered to host this conference in Kenya. Kenya is really on fire in matters oncology. As I speak this year in November, and Dr. Gladwell Kiari is here for Kesho, will be hosting the Kenya Society of Hematology and Oncology Conference, and next year we'll be hosting the Aortic Conference, and then we'll also hold the World Cancer Summit. So, Your Excellency, without further ado, I really want to acknowledge the support we've gotten from all the companies you've seen in the booth, our sponsors for this. We also have representatives from various countries, just to name them, Kenya, Nigeria, Uganda, Tanzania, Ethiopia, South Africa, Malawi, Egypt, Ghana, India, the United States, and even from China, just to name a few. And we are all gathered here globally to support the African Radiation Oncology Group Conference. And this year's theme is about innovation and precision in radiotherapy. And Your Excellency, we really thank you because you've been on the forefront in terms of innovation. We are getting new equipment at Kenyatta National Hospital, state of the art. KU is leading as the National Teaching Referral Hospital also in support with KNH. We are also training doctors at Kenyatta National Hospital in collaboration with University of Nairobi, and many other universities are supporting oncology. We have two, Moi, JKU Art, KU, just to name just a few. And even KMTC is producing oncology nurses. We have many. So Kenya is making a lot of strides in oncology, both in equipment, in human resource, and now we are looking at how do we innovate. And today is the second day of our conference. Yesterday we started with a patient perspective, and in this forum we actually have survivors of cancer. You can't tell by looking at the crowd, but we have survivors who have come to experience. They want to be part of this journey. They want to be on the table to make decisions about their care in future. So we really appreciate you taking out your busy schedule to come and be with us. And without further ado, I will return the mic back to our MC, Dr. Elias Meli.
Thank you very much, Dr. Catherine, for providing leadership in this space of radiation oncology, as well as the cancer space in general. Sir, the focus here is making sure we guarantee quality of cancer care to our patients. I know quality is at the heart of what you would want our patients to receive in this country. Sir, I know you have asked us to make sure we allow you live within the shortest time possible because you have a busy schedule. Allow me then, sir, to invite our own Professor Anyang' Nyong'o, who has been also an inspiration, providing leadership in this space from when he has served in different leadership positions, including when he was the Minister of Health. He has really been supporting our Cabinet Secretary. There is no cancer meeting that Professor Anyang' Nyong'o would miss. Can we clap for him? He is a true advocate, and you can see the work going on in Kisumu County. Thank you very much. Welcome, Excellency.
Mr. Minister, and my colleague for many years, Honorable Duale, Grace, ladies and gentlemen. Well, I'll be very brief, but I'm here really just to tell a personal history, a personal story about cancer. 15 years ago, I sat in a doctor's office in San Francisco and heard words that changed the trajectory of my life. Prostate cancer. I remember the particular kind of silence that follows those words. It is not the silence of an empty room. It's the silence of a mind trying to absorb something too large to fit. I'm sure this is a familiar situation for most of you here. I was fortunate because I got access to treatment at the University of California, San Francisco, under the care of a famous prostate cancer specialist, Professor Mark Roche. And I'm glad that Mark Roche is scheduled to be here. He was delayed in Paris or one of those airports. He would have arrived earlier, but he'll be here. It's Mark Roche who I am delighted to see is going to be here with you today or sooner. I had a family that held me together, led by my wife Dorothy, who took that diagnosis and turned her own fear into something this country would eventually benefit from. But I have never forgotten the question that haunted me then and haunts me still. What happens to the man who hears those same words in a county hospital in Kisumu, or Garissa, or Mombasa, and as none of what I heard? That question is why I'm here today, and it is why this conference matters. When I returned to Kenya soon after, I made a decision I would not hide behind the privacy that my position afforded me. I would talk. I would write. I would stand before cameras and say the words that too many African men still cannot bring themselves to utter. And those words are, I have brought with them. That decision was not about me. It was about the thousands of men who are dying in silence because a disease that is entirely treatable when caught early was being caught far too late. I'm glad that my advocacy has helped drive real change. It has helped put screening, treatment, and palliative care firmly on the public agenda. It has helped expand cancer centers across this country, from the Kenyatta University Teaching and Referral Hospital, Referral and Research Hospital, which many once thought too ambitious, to regional centers now operating in Nakuru, Mombasa, and Garissa, with more coming up in Kisumu and Kilifi, in the case of Kenya. We have learned something crucial in the process. When we decentralize cancer care, we do not simply reduce distance, we increase survival. But let me be direct with you about why we still have so far to go. When I was diagnosed in 2010, Kenya was recording about 37,000 new cancer cases a year. Today, that number is closer to 5,000 in 2 years. It is projected to rise to nearly 58,000. Many of these have been found earlier with a very different trajectory. As you all here know, cancer is no longer a rare disease or something that happens to other people. In other countries, it is here, and it can happen to you. It is in our markets, our churches, our matatus, and the county hospital. And too often, it is diagnosed too late, not because our people lack strength or courage, but because they lack information, they lack access, and frankly, they lack the money to find out early when cancer is most salvageable. The greatest tragedy in oncology on this continent is not that we lack knowledge. It is that knowledge does not reach people in time. The gap between what medicine knows and what our people receive is what must be narrowed by all means. The theme of this conference, Innovation and Precision in Radiotherapy, speaks more directly to my own life and to the lives of millions of Africans who deserve what I was fortunate enough to receive. In my opinion, innovation is not only about new machines, but also about new ways of thinking. Similarly, precision is not only about forgetting tumors with millimeter accuracy, no, not only about targeting tumors with millimeters accuracy, but also about targeting the systems that keep cancer care out of reach for the majority of our people. Precision is radiotherapy. In Africa, must mean something specific. It must mean treatment that is available not only in Nairobi or Johannesburg, but in county hospitals and subnational health facilities across the continent. It must mean early detection systems that do not require a patient to sell their land to afford a scan. It must mean training enough radiation oncologists, medical physicists, and radiation therapists so that no African has to wait months for treatment that should begin within weeks. We are beginning to see what is possible. At the Jaramogi Oginga Odinga Teaching and Referral Hospital in Kisumu, for example, we are building a regional cancer center with a dedicated bone marrow transplant unit. This is not just an abstract ambition, but something in the process. But they will not scale without policy. They will not reach the people who need them most without political will, without sustained funding, and without the kind of cross-border collaboration that AFROG represents. I have spent much of my career in health policy, first as Minister of Medical Services, my colleague is here, and now as governor, working every day to strengthen our county health systems. I have seen how long change can take and why persistence matters. When I was minister, I first pushed for what would become the cancer center at Kenyatta University. At that time, many thought the vision was too ambitious, but advocacy, persistence, and conviction carried it forward. Today, it stands as living proof that in cancer care, persistence saves lives long before medicine ever does. That is the model I believe in: advocacy that changes systems and service that touches lives. I am speaking from a point of being all-knowing. Ladies and gentlemen, I'm not here because I'm extraordinary. I'm here because I was lucky. And luck is not a health policy. Every African who faces this disease deserves the same chance that I had. Not because they can afford to fly to San Francisco, but because their own country has built the capacity to treat them where they are. To the researchers and clinicians, your work is not done when the paper is published or the protocol is perfected. It is done when a woman from the remotest area in your country can walk into a clinic and receive the same standard of care that a woman in London receives. It is done when a father somewhere does not have to choose between his diagnosis and his children's school fees. For you policymakers here, the costs of inaction is measured in lives. The cost of building these systems is measurable in budgets. The cost of not building them is immeasurable. Today I say again that I stand before you, not as a case to study, but as a witness. As I've seen what early detection, quality treatment, and access to care can do, I've also seen what happens when those things are absent. The Africa Cancer Foundation, which my wife Dorothy and I founded, has now provided free screening to over 36,000 Kenyans across 27 counties. We have learned that when you tell a woman to come back next week for results, she often never returns. Not because she does not care, but because she has no money for transport, no time away from her children, and no belief that the system what the system will deliver to her. I finish by saying that I am alive today because of innovation and precision in radiotherapy. Professor Mark Roche and his team of UCSF gave me that. But I'm also alive because I had the means to reach them. And that there is the part we must change. Africa does not need charity. Africa needs systems. We need cancer centers in every region, not just the capital. We need screening programs that reach people where they are, not where the hospital happens to be. We need training pipelines that produce the oncologists, physicists, and therapists this continent desperately lacks. We need social health insurance that does not leave the poor to die from curable diseases. And we need the political courage to say that cancer is a public health emergency because it is. I'm grateful to AFRO for this platform, and to each of you for the work you are doing. Let us not leave this conference with good intentions alone. Let us leave this conference with a shared commitment that the next generation of African cancer patients will not have to travel halfway across the world to find what should have been waiting for them at home. Thank you.
I think that is not adequate. Can we have a better round of applause for our Professor Anyang Nyong'o? We salute you and we appreciate you, Prof. Your lived experience and your investment, including the leadership in that space, really inspires all of us who are here. Our Cabinet Secretary, sir, allow me now to invite Professor Abdulrazak Shaukat, who is our Principal Secretary, State Department of Science, Research, Technology and Innovation. Sir, Professor Shaukat is also a central key person in the cancer ecosystem in the continent and globally. While serving at the International Atomic Energy Agency, it is the reason why we have so much radiotherapy investment in this continent and in this country as well. Can we clap for Professor Shaukat as he walks into the podium? And after this, our Principal Secretary will invite our Chief Guest to address us. Thank you very much.
Thank you very much. Our Cabinet Secretary, Honorable Aden Duale, our Governor of Kisumu, His Excellency Professor Anyang Nyong'o, the Chair of this gathering, Dr. Catherine, and the Chair of the meeting, Dr. Abeid, my good brother and a friend, Tajuddin, Professor Tajuddin, distinguished delegates, ladies and gentlemen, I'm really honored, Your Excellencies, for me to get a little bit of time to share with you some of my thoughts in regard to this very important subject on cancer care in Africa. And I was asked, Cabinet Secretary, to speak about capacity in terms of building equitable radiotherapy services in Africa, so to speak. I think Melly has mentioned that I spent almost 10 years, to be specific, 9 years and 7 months at the International Atomic Energy Agency, and I was really pleased to be there so that I could see this issue on a global perspective, if I may say so. And the big question we are asking is, how can we create a radiotherapy service on this continent that is not only present but equitable? And I think, Excellency, the Governor has mentioned this. Services that will reach for those who are coming from this country, Turkana, some of our farthest end of this country, not just at the executive, midst of Nairobi. And I must say that our Cabinet Secretary, really, you are doing a commendable job in trying to expand these services. And again, we need to really appreciate it. It pains me when I see that these figures, the Africa raising cancer burden, 1.1 million, newly diagnosed with cancer on annual basis, with over 700,000 deaths annually. And again, it is projected by 2040, if we do not do much, then we're gonna have even double these numbers. These are not just projections of strangers. These represents our mothers, brothers, patients, and ourselves. I bet if I ask you people in this room to raise your hand, whether you have at least experienced somebody in your family that has been diagnosed with cancer or has passed away as a result of cancer, either family, friend, or colleague, I am sure I will see many hands. I have seen that in my own family. So half of the cancer patients will require definitely radiotherapy at one point for cure, for control, or for relief. Yet, when you look at this issue, as much as we do chemotherapy, radiotherapy is still very low in quite a number of African countries. In fact, our estimate, and now things are improving, we have almost 20 countries in Africa that do not have a single radiotherapy center. And Cabinet Secretary, let me single out a country like DRC, that when I was there, we are trying to help with 100 million people, not a single radiotherapy center. Those who are coming from Malawi, I am pleased that while we were there at the IAEA, we were able to help Malawi to have their first radiotherapy center. Chad is going to have their first radiotherapy center. I'm mentioning this because things are changing, and I'm glad that African heads of state and ministers of health are taking this matter very, very seriously. So we've got quite a number of countries that now they're really moving forward. And in my opinion, cancer is curable. The global north or Asia should not be a death sentence for Africa. I mean, it is estimated that if you are diagnosed with prostate cancer, in some of the African countries, your survival rate would be about 35%. When you compare to Europe, that is going to be 75%. Cervical cancer is the same. You know, if you are diagnosed cervical cancer in some parts of Africa, is literally a death sentence. We need to change that. And we can only do that through policies. We can only do that through vision and making sure that we can be able to have equity and, of course, looking at the economics aspect as well. Investment in radiotherapy, actually capacity, is not just a cost, in my opinion, to be endured. It is an investment that returns have got more economic benefits. You can imagine at one point, even quite a number of African countries will have to take their families to fly abroad. And I think the minister has alluded to this here, that he had that opportunity, that he was able to go abroad and be able to get the treatment. And I'm glad now, if that was to happen, we can be able to treat this in the country. So this is the game changer that we are talking about. When you look at these issues of the systems to treat rather than the machine, and I really want to emphasize this because I have seen quite a number of African countries initiating, starting radiotherapy centers, having fantastic linear accelerators, but at one point they all go down. So the unit of investment must never be a machine. We must be able to ensure we have the entire planning services, including a contract that would be able to sustain those machines. So a linear accelerator, in my opinion, or if you're looking at a medical physicist, so to speak, must be able to ensure it's a comprehensive sort of approach rather than just a machine and an individual to be able to treat. But we must make sure that we have an entire workforce to be able to manage. And this is very critical for Africa, that Africa must be able to train at scale and retain. And I'm glad at the agency we were able to build capacity and capability in African countries, the North African countries. If you go to the West Africa, we have Ghana that have got training opportunities, of course, South Africa. And I'm glad that Kenya has got that. And I think Kenyatta University Teaching Referral Hospital is one of our best here that should be able, and I'm working on that, Minister, to ensure that it can become a collaborating center of the International Atomic Energy Agency to train more. Again, we must be able to look at the regional entity training networks like this. We have AFROG, we have medical physics network, what we normally call FAMPO. While I was there, I also initiated Radio Pharmacist Association for Africa as well. All these three entities should be able to come and work together. We must develop harmonized curricula and be able to follow the path with adequate budget. In my opinion, a radiation oncologist takes a decade to form, and retaining them matters as much as training them. And I really want to emphasize this. I have seen brain drain in Africa. We must be able to have brain gain and brain circulation by making sure that we can compensate our experts, Cabinet Secretary, well, so that we can be able to retain them. If you go to some states in US, you'll find there are more doctors there than the doctors in Ghana, just because of this issue of the brain drain. So we want to train, but at the same time, we want to retain as well. We must work together. We must be able to have partnership. I am glad under the leadership of DG at the IEA, iMidwife, the Rays of Hope initiative, that now is able to bring on board at least 45 African countries. They are benefiting under that Rays of Hope initiative. We also have the anchor centers that IAEA has initiated, and these are centers that we can be able to train people and be able to have all these cutting-edge technologies. So African capacity, building African capacity with the international partners, in my opinion, is very, very important. But again, let's go into this, subject. We have been consumers of technology for a long time. We must be able to generate our own data. We cannot plan if we do not measure. Data centers, cancer registries are very, very critical. If you're looking at the precision medicine, then we must be able to have African data that will be able to influence the training sort of programs in the continent. So data instruments that convert encodes into policies as well. And I think for a long time, we have been, in my opinion, outsourcing intelligence, so to speak. And now in this country, we have the AI strategy. We are developing AI policy, and we want to see that in the areas of health as well, these are all aligned so that we can use these emerging technologies such as AI to be able to influence our areas, including the ones of cancer care as well. Just quickly, I don't want to go into details of this slide. You can see it. I'm talking about 5 very important pillars when you're looking at equitable radiotherapy, the issue of national commitment, which I am glad that all of us here are, the fact that we've been able to come here, decentralization with quality, I think that has also been mentioned, making sure that we have the efficiency, evidence-based practice, a workforce pipeline with regional solidarity. We cannot afford to have each and every country have training centers. That's why we have what we call regional designated centers, collaborating centers, so that we can be able to build capacity and capability. And above all, we must be able to have innovation. We cannot afford to continue doing what we've been doing for a long time. The State Department of Science, Research and Innovation that His Excellency the President has created is actually providing that platform so that we can be able to use the emerging technologies. We be able to create the platform and be able to ensure that we can use this innovation science technology. Just to give you one example, and Cabinet Secretary, we are looking forward to the government commitment of 1% of the GDP. If that was to come through, then one of the areas that I would like to create is a grand challenge of the national innovation and research in cancer care in this country. The other areas that we can also be able to look at is by bringing institutions of higher learning and research such as Kenya Medical Research Institute with the research chairs again, because we must be able to have a before I conclude, Excellencies, I'm just saying that a call to action, we must be able to have radiotherapy and be able to have the essential infrastructure. We must be able to leverage of international partnership. This disease does not know borders. We can be able to get expertise all over the place, and we must be able to ensure that we can have the data that is being driven with the information and be able to advocate for an agenda in Africa by Africans for Africa. I think this is what I would like to say, and as says goes, the little by little fills measure. In Kiswahili, we normally say kidogo kidogo hujaza kibaba. I'm telling my brother, Professor Tajuddin, so that before he leaves here, he learns more Swahili, which literally means that small, consistent action will eventually add up to a significant results over time. The era of little by little, in my opinion, must now give way to an era of deliberate financial continental scale. We must be able to do a domestic financing, and His Excellency the President, of course, the Cabinet Secretary here knows very well, we are advocating for that. Africa must finance herself, and then we can be able to leverage on the partnership that we have. In my opinion, the cancer patient's country should never determine her prognosis. Let us build together a continent where this is not the case. So it doesn't matter wherever you are living. If you're in Africa, it should not become a death sentence. Science is already proven. We have the evidence. Here, the economics are favorable. The evidence, of course, is increasingly ours. So what is remaining, in my opinion, is will, and in my opinion, the glass is half full. We are on the trajectory of changing the situation in Africa. I thank you for listening to me, and I wish you all a very fruitful deliberations. It is at this point that I want to state, before I bring on board our Cabinet Secretary, when His Excellency the Governor was giving his story, I was just reflecting, Your Excellency, when you were the Minister that time, I was serving at the National Commission for Science, Technology and Innovation, and we had a lot of discussions where the National Cancer Institute was set, and I must say that I was really honored to sit on the board. And now you can see that our current Cabinet Secretary, Honorable Aden Duale, if you follow his trends, if you follow his mission, if you follow his dedication, you can see how he has transformed the entire sector, health sector in this country. And he's placing us not just at the national level, the regional and international level. So really, we are very proud, Your Excellency, our Cabinet Secretary, for the leadership that you've provided in this sector, and we are going to continue working with you. It is now my humble duty and pleasure to welcome, can you please rise and welcome our Cabinet Secretary, Honorable Aden Duale, to come and give us the official opening remarks on this very important gathering, looking at the matters of care. Thank you very much.
Please, let's be seated. The governor of Kisumu, my former leader and friend. When I say my former leader is when I joined politics many years ago, he was the Secretary General of the party that I belong, so he signed my nomination certificate 20 years ago. So he played a very big role in my journey to leadership. The Principal Secretary for State Department for Science and Innovation, the CEO of National Cancer Institute, the President and members of the President of the African Radiation Oncology Group, the President and the members of the Clinical Radiation Oncology Society of Kenya, the representative of the International Atomic Energy Agency, development partners, distinguished scientists, clinicians, researchers, professional societies, colleagues from the Ministry of Health, ladies and gentlemen, good morning. It gives me great pleasure to welcome you to Nairobi for the 11th Africa Radiation Oncology Group Scientific Conference. And the theme of this conference, Innovation and Precision in Radiotherapy, could not be more timely. Across Africa, we stand at a very defining moment where technological advances are rapidly changing how we diagnose, how we plan, and how we treat cancer. Our challenge is to ensure that these innovations are not confined to a few centers of excellence, but are translated into equitable, affordable, and accessible service for every patient, regardless of their geographical and socioeconomic status. Cancer remains one of the fastest growing public health challenges globally. In Africa, more than 1.2 million people develop cancer annually, with over 700,000 lives lost each year. Kenya is not spared. We diagnose over 35,000 new cases annually, and nearly 23,000 Kenyans succumb to the disease every year. Behind these statistics are families, communities, and very productive citizens whose their lives and livelihood are profoundly affected. Cancer is therefore not only a health issue, it is a national development issue requiring a whole of government and a whole of society action. The government of Kenya, under the leadership of His Excellency Dr. William Samoei Ruto and our fifth administration, we have placed health at the center of our national development through the universal health coverage agenda under the Taifa Care. And our objective is simple but very ambitious, that no Kenyan should be denied quality health care because of the financial hardship they face. This philosophy equally applies to cancer prevention, diagnosis, treatment, rehabilitation, and palliative care. Through the Social Health Authority, we are fundamentally transforming healthcare financing by providing financial protection for patients requiring cancer care. These include, under that package, diagnostics, surgery, chemotherapy, radiotherapy, and other targeted therapies. Dialysis where indicated, palliative care, and other specialized intervention within our defined benefit package under the Social Health Authority. This represents one of the most significant reforms in Kenya's health sector, ensuring that the cost of cancer treatment no longer condemns families to high expenditure or to poverty. These financing reforms are being complemented by a very deliberate investment in service delivery. We are guided by our National Cancer Control Strategy of 2023 to 2027. We are continuing to strengthen the prevention, the vaccination and the screening and early diagnosis, treatment, survivorship, the palliative care, the cancer surveillance and research, and through the National Cancer Institute of Kenya and the Ministry Technical Departments, we are reinforcing national coordination, while at the same time we are expanding partnership with our counties, with academia, and with our international partners. Recognizing that early diagnosis saves lives, we are embedding cancer prevention and screening within our primary health care networks. Our community health promoters have become an integral part of this strategy by creating awareness, by supporting screening, facilitating early referrals, navigating patients through the health system, and finally doing a follow-up within our communities. The future of cancer control begins long before a patient reaches the radiotherapy machine. We have equally as a government prioritized the decentralization of service, which the governor of Kisumu and the PS have said. We have heavily invested in our regional cancer centers in Mombasa, Nakuru, Garissa, and Kisii. We've also expanded our services at Kenyatta National Hospital, Kenyatta University Teaching and Research Hospital, and Moi Teaching and Referral Hospital. And in all this, we are bringing a very comprehensive oncology service closer to the patients. We are also investing in Jaramogi Oginga Odinga Teaching and Referral Hospital, We're going to build another regional cancer center in Meru and in Nyeri and in Kilifi. All these we're doing that in order to reduce the travel distance of our patients, shortening their waiting times, and advancing equity in access. This remains a very central pillar of the universal health coverage. Radiotherapy remains indispensable in comprehensive care, in comprehensive cancer management, with almost 60% of the patients requiring it at some point during treatment. As innovation accelerates through precision medicine, image guided by radiotherapy, advanced techniques, adaptive treatment planning, and artificial intelligence, our greatest investment, colleagues here, must remain our people. Kenya is therefore expanding specialist training for clinical and radiation oncologists, medical physicists, oncology nurses, radiation therapists, biomedical engineers, and all the other allied professionals, because we recognize that technology is only as effective as the skilled workforce that is behind it. Kenya is equally positioning itself as a regional center of excellence for oncology services. We are proud to be among the few countries on the continent with a cyber-knife technology, while our investment in PET-CT imaging and theranostics continue to serve patients from more than 15 countries across our region. These investments demonstrate our commitment to making Kenya a hub for specialized cancer diagnosis, treatment, training, and research for East and Central Africa. As we strengthen our service delivery, we are equally pursuing the health product security and local manufacturing under the bottom-up economic transformation agenda of this administration. Through institutions such as the Kenya Biovax Institute, strategic partnership with the industry and research institutions, our broader local manufacturing agenda is on course. Distinguished delegates, no country can overcome the cancer burden in isolation. Scientific collaboration, multi-center research, knowledge exchange, and harmonized standards of care remain very essential. I therefore commend the Africa Radiation Oncology Group for creating this platform, and also congratulate the Clinical Radiation Oncology Society of Kenya on its official launch today. I assure you of government's continued partnership in advancing clinical excellence, research, innovation, and professional development. As you deliberate over the coming days, I encourage you to develop practical evidence-based recommendations that will help us improve access, quality, safety, and affordability of the radiotherapy across Africa. Innovation must ultimately be measured not by the sophistication of our technology, but by the number of lives that we have saved, the suffering that we are going to reduce, and the dignity restored to our patients. Allow me to sincerely thank the Africa Radiation Oncology Group, our development partners, the sponsors, the researchers, and the healthcare professionals for your unwavering commitment to improving cancer outcomes across our continent. I wish you a very productive scientific deliberations, meaningful collaborations, and every success during this conference. To our international guests, I also invite you. You are not very far from the national park, and this is the only city in the world with a national park. you must experience our warmth of Kenyan hospitality. Our weather is at its best this time of the year. It's not cold, it's not too hot. And as you walk around this park, you must be very careful because you might encounter a lion. And our lions are not domesticated, they are wild. So be very careful. But please, go to our parks, don't go back, look at the wildlife, look at the landscape, our cultural heritage. And it's now my singular honor to declare the 11th African Radiation Oncology Group Scientific Conference officially open and to launch the Clinical Radiation Oncology Society of Kenya. Just to wrap up, I just want to remind the governor of Kisumu, my good friend, Professor Anyang' Nyong'o, that the 18 months I was the Minister for Health, let me make it and confess, I am the 23rd minister since independence. And when I look at the photos at the Ministry of Health in the morning when I walk in, I look at those ministers, some of them have good. Professor Anyang' Nyong'o is a great leader, he was a minister there. Our third president was Minister for Health, President Mwai Kibaki. But when I go through the files, a lot of the things that interest me and I say I must do it well and I must fix it are issues that Professor Anyang' Nyong'o started. So I really want to thank you most sincerely. And I tell colleagues, some of them are here, I wish my PSS and the Director General of Health was there, and I tell them, you guys, you can see Professor Anyang' Nyong'o had a vision for this ministry. And Professor, I want to assure you that the Ministry of Health that you left is no longer the same. From the building to the men and women who work. And they were telling me yesterday, and I had to repeat it, so my team told me, Minister, on Friday, you should give us lighter duties. Now I'm talking about the top leadership. So I went and reflected on it, and I said, wait a minute, at least the people asking me are not Muslims. Because Friday is important to the prayer day for Muslims. I am the only one. I should have been the one asking for lighter duties, not them. So this morning I told them, okay, I have agreed to your lighter duties, but for you, not for me. Because I have to fix so many things. But Professor, you and many of your colleagues who were there before at the Ministry of Health. And today I'm very proud to say, very, very proud to say that at least many Kenyans, if you walk to Mombasa Cancer Regional Center, in a particular day they serve close to 180 patients. You go to Garissa, they serve close to 120. You go to Nakuru, they serve more than 200. We're doing it in Kisii. I think very soon it will be operational. You go to Kenyatta University, you go to Kenyatta National Hospital, the numbers you see. So access, we're expanding access. In terms of affordability, I think the Social Health Authority currently, since independence, has the highest benefits package for cancer patients in our country. In fact, we were doing, the authority was doing the numbers, and they were telling me only close to 3,000 patients, the whole country, now use out of pocket after they exhaust their package. And we will keep on. We have our advisory and benefits advisory committee we're now looking at what are the main ailments. And I can assure you, if you go to Kenyatta University Teaching and Referral Hospital and you encounter Dr. Abeid leading his team, Kenya will be a leader in this space and this ecosystem. So I really want to thank you, and I thank you all, and may God bless you. Thank you.
A round of applause for our Cabinet Secretary, who has provided true leadership that is impactful in the Ministry of Health and in this country. Thank you very much, sir, for honoring this meeting with your presence today. We truly appreciate. Sir, allow us, we indulge you for 15 more minutes to officially launch the Clinical Radiation Oncology Society of Kenya. This association is registered after we went through the due processes within and through the Ministry of Health, because we do appreciate that since you go to the ministry, matters policy must be adhered to, and one of them is how professional associations are being registered. So I would wish at this opportunity to invite the Secretariat, the Executive Committee of the Clinical Radiation Oncology Society of Kenya, the Chairperson, the Treasury, the Secretary, to come up front just by this beautiful cake that is here before us. And I'll kindly invite our Chief Guest, our Cabinet Secretary, our PS, and our Governor to join them as we formally launch this association. That is Dr. Jesse Opakas, CS, who is the Director of the Moi Teaching and Referral Hospital Cancer Center. And after this, I am going to invite all the clinical radiation oncologists, the medical physicists, and the radiotherapy technicians who are here to take a photo with our Cabinet Secretary. Our team, so let us proceed. Can we clap for them as Kenya Radiation Oncology Society of Kenya is being launched? Makofi. This is one additional professional association towards improving cancer care in our country. Thank you very much. We will have a test of this later. Kindly allow me to ask all the members to join us up front. If you know you are a clinical radiation oncologist working in Kenya, you are welcome. I would also wish to invite medical physicists and radiotherapy technicians who are in the meeting today. Some can come up here for the sake of this beautiful, this is going to go into the record. Some of you can join me up front, but be careful. Thank you very much. I would ask us to sit down, except our Cabinet Secretary, our Governor. We are going to do the gifting session. Thank you very much. Can we now release our cabinet secretary? Hebu tumpigie makofi wakati anaondoka. Thank you, CS, for honoring us with your time. While the cabinet secretary is leaving, just to reorganize ourselves to continue with our meeting, kindly the Kenyatta National Hospital team just walk up front and give us one piece as we reorganize ourselves to continue. Thank you very much. That marks the end of our opening ceremony for this regional conference. My name is Dr. Elias Meli. For those who do not know me, I didn't introduce myself. I'm the Chief Executive Officer of the National Cancer Institute of Kenya. Thank you. God bless you.
Excuse me. Thank you so much. We are going to proceed for a very short tea break, then we go back, we continue with the program. Please take the fastest time possible so we can go back and continue with our program. Thank you so much.
Good evening, colleagues. What a wonderful day we've had at the AFROG 11th Scientific Congress Pre-Conference Day. We started the day off with a talk from Professor Olasinde from Nigeria, and the morning session ended with a patient perspective. So it was great to hear and start the day with the patient's aspect from radiotherapy. In the afternoon, we had multidisciplinary discussions, and now currently we're having our trainees registrars doing contouring on esophageal and breast cancer cases. So it's a day that started with patients, multidisciplinary discussions, and now our trainees learn from senior colleagues.
I'm Dr. Kevin Makori. I'm a consultant clinical and radiation oncologist in Homa Bay County Referral Hospital, as well as Tenwek and Victoria Cancer Care and Research Centers. Today's events have been excellent. We have had a number of sessions from distinguished speakers discussing a wide range of topics. And especially this afternoon, we've had a very interactive session regarding the role of radiation therapy and the techniques that are applicable in prostate and breast cancer and even beyond. One of the highlights of this afternoon session was how we can be able to optimize the few machines that we have in our populations to serve the needs of our patients, particularly through hypofractionation techniques. It's also been a very interactive session that has seen colleagues demonstrating to those that are in training about how to approach radiation therapy in terms of contouring, planning, and so on. I'm looking forward to very interactive sessions in the upcoming days, and I know that this is a conference that has a significant impact, not just in Kenya, but in the entire African continent.
My name is Roslina Kumu, the President Oncology Nursing Society Kenya. Today, I'm super excited to be attending AFROG conference with the theme, Innovation and Precision in Radiotherapy. The day started well with the pre-conference workshops. We've learned about toxicities, patient perspectives, the support, the researches that are coming up, and just to ensure that we have end-to-end care, multidisciplinary talks, and a lot more is expected tomorrow. So I'm requesting people to join us tomorrow early morning, and we're gonna have a very exciting dinner at Carnival on Saturday. See you there.
Today was the first day, actually the workshop, for our 11th African Radiation Oncology Conference, AFROG, here at the Agile Grand Hotel in Nairobi, Kenya. And being the 16th of July, our theme for the conference is Innovation and Precision in Radiotherapy. So basically, the day has been amazing. We started very early in the morning at 9. Before then, we had breakfast from 7 to 9, and then from there, we started our presentations. So we've talked about challenges, solutions for oncology care, the patient journey, patient navigation, and ultimately we've had international speakers talking about precision oncology. This afternoon we are crowning it up all with contouring. We had 2 amazing presentations in breast and esophageal cancer. Then we had residents from the university who are doing radiation oncology contour cases practically, given the platform through Varian. And they are contouring, and we are just hoping to see the final product as we close the day. And thank you, Vital Signs Studio. Thank you, all the sponsors, for making this possible. And MMS for being like the coordinator for this conference. Thank you so much, and we're looking forward to day 2 of the conference, where we are going to meet government officials, and we are really looking forward. We are hoping our CS Health will come. We'll have Anyang Nyong'o and other industry leaders, CEOs of hospitals, and more amazing presentations. And we really thank you, and we want you viewers to be locked in. Please see you tomorrow morning. I will not miss, I'll be here. Thank you, bye.
Good evening, colleagues. What a wonderful day we've had at the AFROG 11th Scientific Congress pre-conference day. We started the day off with a talk from Professor Olasinde from Nigeria, and the morning session ended with a patient perspective. So it was great to hear and start the day with the patient's aspect from radiotherapy. In the afternoon, we had multidisciplinary discussions, and now currently we're having our trainees, registrars, doing contouring on esophageal and breast cancer cases. So it's a day that has started with patients, multidisciplinary discussions, and now our trainees learning from senior colleagues.
I'm Dr. Kevin Makori. I'm a consultant clinical and radiation oncologist in Homa Bay County Referral Hospital, as well as Tenwek and Victoria Cancer Care and Research Centers. Today's events have been excellent. We have had a number of sessions from distinguished speakers discussing a wide range of topics. And especially this afternoon, we've had a very interactive session regarding the role of radiation therapy and the techniques that are applicable in prostate and breast cancer, and even beyond. One of the highlights of this afternoon session was how we can be able to optimize the few machines that we have in our populations to serve the needs of our patients, particularly through hypofractionation techniques. It's also been a very interactive session that has seen colleagues demonstrating to those that are in training about how to approach radiation therapy in terms of contouring, planning, and so on. I'm looking forward to very interactive sessions in the upcoming days, and I know that this is a conference that has a significant impact, not just in Kenya, but in the entire African continent.
My name is Roslina Kumu, the President Oncology Nursing Society Kenya. Today, I'm super excited to be attending AFROG conference with the theme, Innovation and Precision in Radiotherapy. The day started well with the pre-conference workshops. We've learned about toxicities, patient perspectives, the support, the researches that are coming up, and just to ensure that we have end-to-end care, multidisciplinary talks, and a lot more is expected tomorrow. So I'm requesting you people to join us tomorrow early morning, and we're gonna have a very exciting dinner at Carnival on Saturday. See you there.
Today was the first day, actually the workshop, for our 11th African Radiation Oncology Conference, AFROG, here at the Agile Grand Hotel in Nairobi, Kenya. And being the 16th of July, our theme for the conference is Innovation and Precision in Radiotherapy. So basically, the day has been amazing. We started very early in the morning at 9. Before then, we had breakfast from 7 to 9, and then from there, we started our presentations. So we've talked about challenges, solutions for oncology care, the patient journey, patient navigation, and ultimately we've had international speakers talking about precision oncology. This afternoon we are crowning it up all with contouring. We had 2 amazing presentations in breast and esophageal cancer. Then we had residents from the university who are doing radiation oncology contour cases practically, given the platform through Varian. And they are contouring, and we are just hoping to see the final product as we close the day. And thank you, Vital Signs Studio. Thank you, all the sponsors, for making this possible. And MMS for being like the coordinator for this conference. Thank you so much, and we're looking forward to day 2 of the conference, where we are going to meet government officials, and we are really looking forward. We are hoping our CS Health will come. We'll have Anyang' Nyong'o and other industry leaders, CEOs of hospitals, and more amazing presentations. And we really thank you, and we want you viewers to be locked in. Please see you tomorrow morning. I will not miss, I'll be here. Thank you. Bye.
Good evening, colleagues. What a wonderful day we've had at the AFROG 11th Scientific Congress pre-conference day. We started the day off with a talk from Professor Olasinde from Nigeria, and the morning session ended with a patient perspective. So it was great to hear and start the day with the patient's aspect from radiotherapy. In the afternoon, we had multidisciplinary discussions, and now currently we're having our trainees, registrars, doing contouring on esophageal and breast cancer cases. So it's a day that has started with patients, multidisciplinary discussions, and now our trainees learning from senior colleagues.
I'm Dr. Kevin Makori. I'm a consultant clinical and radiation oncologist in Homa Bay County Referral Hospital, as well as Tenwek and Victoria Cancer Care and Research Centers. Today's events have been excellent. We have had a number of sessions from distinguished speakers discussing a wide range of topics. And especially this afternoon, we've had a very interactive session regarding the role of radiation therapy and the techniques that are applicable in prostate and breast cancer and even beyond. One of the highlights of this afternoon session was how we can be able to optimize the few machines that we have in our populations to serve the needs of our patients, particularly through hypofractionation techniques. It's also been a very interactive session that has seen colleagues demonstrating to those that are in training about how to approach radiation therapy in terms of contouring, planning, and so on. I'm looking forward to very interactive sessions in the upcoming days, and I know that this is a conference that has a significant impact, not just in Kenya, but in the entire African continent.
My name is Rosalina Kumu, the President Oncology Nursing Society Kenya. Today, I'm super excited to be attending AFROG conference with the theme, Innovation and Precision in Radiotherapy. The day started well with the pre-conference workshops. We've learned about toxicities, patient perspectives, the support, the researches that are coming up, and just to ensure that we have end-to-end care, multidisciplinary talks, and a lot more is expected tomorrow. So I'm requesting you people to join us tomorrow early morning, and we're gonna have a very exciting dinner at Carnival on Saturday. See you there.
Today was the first day, actually the workshop, for our 11th African Radiation Oncology Conference, AFROG, here at the Adel Grand Hotel in Nairobi, Kenya. And being the 16th of July, our theme for the conference is Innovation and Precision in Radiotherapy. So basically, the day has been amazing. We started very early in the morning at 9. Before then, we had breakfast from 7 to 9, and then from there, we started our presentations. So we've talked about challenges, solutions for oncology care, the patient journey, patient navigation, and ultimately we've had international speakers talking about precision oncology. This afternoon, we are crowning it up all with contouring. We had 2 amazing presentations in breast and esophageal cancer. Then we had residents from the university who are doing radiation oncology contour cases practically, given the platform through Varian. And they are contouring, and we are just hoping to see the final product as we close the day. And thank you, Vital Signs Studio. Thank you, all the sponsors, for making this possible. And MMS for being like the coordinator for this conference. Thank you so much, and we're looking forward to day 2 of the conference, where we are going to meet government officials, and we are really looking forward. We are hoping our CS Health will come. We'll have Anyang Nyong'o and other industry leaders, CEOs of hospitals, and more amazing presentations. And we really thank you, and we want you viewers to be locked in. Please see you tomorrow morning. I will not miss, I'll be here. Thank you, bye.
Good evening, colleagues. What a wonderful day we've had at the AFROG 11th Scientific Congress pre-conference day. We started the day off with a talk from Professor Olasinde from Nigeria, and the morning session ended with a patient perspective. So it was great to hear and start the day with the patient's aspect from radiotherapy. In the afternoon, we had multidisciplinary discussions, and now currently we're having our trainees, registrars, doing contouring on esophageal and breast cancer cases. So it's a day that has started with patients, multidisciplinary discussions, and now our trainees learning from senior colleagues.
I'm Dr. Kevin Makori. I'm a consultant clinical and radiation oncologist in Homa Bay County Referral Hospital, as well as Tenwek and Victoria Cancer Care and Research Centers. Today's events have been excellent. We have had a number of sessions from distinguished speakers discussing a wide range of topics. And especially this afternoon, we've had a very interactive session regarding the role of radiation therapy and the techniques that are applicable in prostate and breast cancer, and even beyond. One of the highlights of this afternoon session was how we can be able to optimize the few machines that we have in our populations to serve the needs of our patients, particularly through hypofractionation techniques. It's also been a very interactive session that has seen colleagues demonstrating to those that are in training about how to approach radiation therapy in terms of contouring, planning, and so on. I'm looking forward to very interactive sessions in the upcoming days, and I know that this is a conference that has a significant impact, not just in Kenya, but in the entire African continent.
My name is Roslina Kumu, the President Oncology Nursing Society Kenya. Today, I'm super excited to be attending AFROG conference with the theme, Innovation and Precision in Radiotherapy. The day started well with the pre-conference workshops. We've learned about toxicities, patient perspectives, the support, the researches that are coming up, and just to ensure that we have end-to-end care, multidisciplinary talks, and a lot more is expected tomorrow. So I'm requesting you people to join us tomorrow early morning, and we're gonna have a very exciting dinner at Carnival on Saturday. See you there.
Today was the first day, actually the workshop, for our 11th African Radiation Oncology Conference, AFROG. here at the Del Grand Hotel in Nairobi, Kenya. And being the 16th of July, our theme for the conference is Innovation and Precision in Radiotherapy. So basically, the day has been amazing. We started very early in the morning at 9. Before then, we had breakfast from 7 to 9, and then from there, we started our presentations. So we've talked about challenges, solutions for oncology care, the patient journey, patient navigation, and ultimately we've had international speakers talking about precision oncology. This afternoon, we are crowning it up all with contouring. We had 2 amazing presentations in breast and esophageal cancer. Then we had residents from the university who are doing radiation oncology contour cases practically, given the platform through Varian. And they are contouring, and we are just hoping to see the final product as we close the day. And thank you, Vital Science Studio. Thank you, all the sponsors, for making this possible. And MMS for being like the coordinator for this conference. Thank you so much, and we're looking forward to day 2 of the conference, where we are going to meet government officials, and we are really looking forward. We are hoping our CS Health will come. We'll have Anyang Nyong'o and other industry leaders, CEOs of hospitals, and more amazing presentations. And we really thank you, and we want you viewers to be locked in. Please see you tomorrow morning. I will not miss, I'll be here. Thank you, bye.
And that's going to be Dr. Elias Meli, the CEO of the National Cancer Institute. Then we will proceed to the next session, where we'll have Ms. Ekta Jala, Dr. Andre Foss from South Africa. Dr. Nyongesa will do a brief presentation, about 5 minutes, and then Dr. Marwa Rostam from Egypt. May I request all the presenters to ensure that their presentations are loaded. And before that, let me invite the AFROG Secretariat to make a quick announcement before we proceed.
Good morning, all. We have a quick announcement to make. This is an Afro conference, and one of the things we do wherever we have a conference is membership drive. So I've been reminded that we need to register as members. Radiation oncologists, medical physicists, radiation therapists, oncology nurses, and biomedical engineers who are here. Kindly, at the reception desk, register as a member. There's a membership fee of 50 USD. That is what is required to be a member of AFROG. So we expect you to register by the close of the day. And lastly, the second announcement, the AFROG family will be having a meeting after the program in the afternoon. So we expect you to be here. It will be a very short meeting that we normally have wherever we have a conference, just to give the status and how the conference is progressing. So kindly, I expect all of us to register. For those who have been sponsored by AFROG from the international family, the assistance will not be given until you register, because some are not members, and yet we are going to assist them in one way or another. So the Secretariat is insisting that you register. And for our people down here, kindly let us register. The registration fee is 50 USD. Thank you.
So let me invite Dr. Melly to make his presentation. And please give him a round of applause. You didn't clap for him when he emceed here. And now that you're the highest ranking ministry official, we'll address you as Waziri. Waziri Karibu.
Well, Chairman of this session, you just want to fire me while I'm on the podium. The Cabinet Secretary just left, and that is his position. Well, colleagues and friends, good afternoon. Is it afternoon? We're almost there. Yeah, thank you very much. I am honored and privileged to I know time is far much spent. I'm honored and privileged to again be up front here, not to MC, but to speak about, one of the most important reasons why we are here. This afternoon, these 3 days from yesterday to tomorrow, as colleagues from different countries, different institutions, different programs who are passionate about moving the radiation oncology care forward. My work is just to talk about the future of cancer care in Africa. And I am a clinical radiation oncologist. Other than, being the head of the National Cancer Institute, passionate, still doing clinical practice, teaching and research, what most of us here are involved in, working with all the partners in the space. Professor Shaukat presented a continental, futuristic presentation. And that mirrors a lot what my presentation is all about. And because time is far much spent, I'm not going to run through my entire presentation as I had prepared. He did talk about data, and I know we've talked about continental and country data from morning, and it is clear that the burden is rising. The incidences, the prevalence, as well as mortalities is wanting and it's worrying. And therefore, we need to work on, a coordinated approach. We've agreed that we cannot beat, cancer as each country, each institution, we have to work collaboratively. And in terms of what we really want to invest in is prevention, early detection. We have to invest a lot in technology and research and innovation. It is no doubt anymore that precision oncology and medicine should be the cornerstone of our practice on a daily basis. And this is anchored a lot on diagnostics, as well as targeted therapies, be it systemic or radiation, whether nuclear medicine or through external beam radiations or brachytherapy, we have to transition. We have to invest in minimally invasive interventions, as technology advances as well. And that is where we need to focus in Africa. And sometimes to achieve this where we do not have adequate, capacity, we have to leverage on what exists within the continent, what exists within the region. We've had, for instance, Ghana has trained a lot of our medical physicists. Here in country, we have had, University of Nairobi, Moi University, Aga Khan University train for even the continent. I remember the first gynecological oncologist from Uganda was trained at Moi University, who then went back and established the first gyn oncology training program in Kampala, and they are now building capacity locally. So collaborations is inevitable, and is the reason why AFROC is a continental regional program. It is also important in Africa, if we really have to address the cancer care, to have goodwill from the leadership. Having our cabinet secretary here in the morning represents, the interest from the government in what we are doing, and also in terms of aligning our work to the national priorities and policies that exist, which are developed through our ministries of health. So leadership is very key, and we have to invest that as countries. In Kenya, we have attempted 4 times to roll out universal health coverage. And for the first time, we are succeeding. And since my presentation is, cancer care in Africa, lessons from the National Cancer Institute of Kenya, universal health coverage, be it broad, cancer care is integrated. And a lot of investment going into primary health care, where all of us agree we have to focus on early detection through screening. And our country enacted 4 laws that enabled our universal health coverage. So governance and legal instruments to enable delivery of healthcare are very important, because those are policy documents that leads and guides what everyone should do. So each of our countries should, practically implement universal health coverage. And if you look at that across the entire continuum of care, from when a patient presents for a mammography, or a patient presents for, HPV DNA screening, or a patient presents for prostate, colorectal, and lung, all the screenable cancers, you definitely have to interact with our grassroots capacity that is available. And patient navigation beyond there is very important. In Kenya, we have worked with our partners to enable patient navigation. And this would address loss of follow-up and also address quality of care that our patients receives through our levels of care, all the way from, grassroots facilities in the primary healthcare space to the most advanced interventions at our APEX national institutions that provide multi-speciality advanced interventions. At the heart of implementation is diagnostics. And I want to believe across all our countries, our weakest link is diagnostics. And if we really have to practice precision radiotherapy and innovation, we have to improve on building capacity on, all the genomic space and all the other multi-omics that are now available to guide targeted therapies and interventions. We do all appreciate that we have, approximately 65% of our patients would receive radiotherapy, either for palliative or, definitive treatment. And we have cancers which are radiosensitive, that where an opportunity presents itself, we must be able to provide this capacity. And for a long time, in Kenya, we had Kenyatta National Hospital as the premier institution to treat cancer But over the last decade, we have decentralized comprehensive cancer centers, both in public and private. The first private center to treat cancer patients here was MP Shah CCK around 2010. But over time, there are now private centers, more in Nairobi, and there are now others also out of Nairobi, and more that are coming up. So if we have to learn on implementation of cancer policy in Kenya across our other countries is we have to increase access. And one approach is to make sure that we decentralize our services close to the people, you know, in the regions. We did a short study at Moi Teaching and Referral Hospital in Eldoret, where I offer my clinical practice in pediatric oncology, and we realized one of the barriers to access to care is distance. Patients may not be able to afford even $1 to travel to the next center, so they may not be able to get to the capital where a lot of technologies are available. So it is a reality that every country should invest in decentralization of the services close to the public in the most rural parts of the countries. In the continent, we have very expansive countries. We had Best of ASCO last week in Abuja, and you would appreciate, Prof, how expansive Nigeria is with that huge population. So as a policy implementer, we have been able in a small way in our small country, though now fairly not small, been able to ensure that the northern, eastern, southern, and western parts of the country, patients can access treatment without coming to Nairobi. Professor Shaukat talked about cancer registries, data, digital transformation. I think it's inevitable that we have to work on generating local data, that we can use it to make sure that we generate local solutions. We've been discussing with colleagues the recently released GlobalCan data last week, and while we appreciate, based on the capacity for registration available in our countries, that can guide our cancer policy and implementation. For now, there is more that we need to do to make sure this data is credible and it represents the burden that we have in our countries. So as the National Cancer Institute, we have been working day and night to make sure we generate reliable, credible data which is local, that is not relying on a very small sample that sometimes may misrepresent our true burden. And this is data collected from all our treating hospitals within public and private sector as well, because they are all available to take care of our patients within the country. And beyond the registry, from our hospitals, we've also invested in screening registries. I must appreciate that as a way of improving patient experiences and patient navigation, through what began initially as the effort of first ladies from our country, from our different counties, and working with the support of Roche Pharmaceuticals, we have an Empower digital screening tool that allows us to now look at our patients through the entire system, from screening to when they receive care and how they get integrated back into the community. I think that is an innovation that we can share. And recently we had a team from Cote d'Ivoire and Nigeria visit with us to benchmark on such programs that have been innovated through our work here in Kenya. And of course, we cannot underscore the role of technology in other areas, in pathology diagnostics, as well as in radiology imaging, planning for radiotherapy. We are all transitioning now to AI-guided diagnostics and planning, and also treatment. Yesterday, we launched our Institutional Scientific and Ethics Research Committee at the National Cancer Institute, as a way of also facilitating capacity to conduct research within the country. If you have an IRB, I know most of us here are scientists who are passionate about research, and one of the barriers that we've had in the past is how long does regulatory and approval processes take before one gets their protocol approved. Now we have an additional IRB that is approved by, NACOSTI, which is our regulator locally here. You are free now to send in your proposals as early as next week, and we have a very competent committee that is going to look at those protocols. And these would be available for the continent as well. As we continue to build that capacity. One other area that we can learn from the work we've done at the National Cancer Institute of Kenya in research is funding cancer research. Through our taxpayers' money, we are now sending out requests for proposals, and I know some of us here have benefited from our grants. They are seed grants, they are catalytic, and some of you scientists who have received our seed grants specifically for cancer. Previously, we've had research funded by National Research Fund, which was very broad for all the scientists, across different sectors. But here, we now have a fund that we are, available. And based on that fund, you can do basic work that can allow you to even apply for a bigger grant, which could be, international. And we've seen that happening. We are also building and improving capacities for our clinical trials. I am happy that for a long time, when we go to global meetings, you would always hear about clinical trials are only in South Africa and Egypt. Other countries are 0.0000001%. From the capacities within our country now, both in public and private, there are now active clinical trials in the country. And we would wish that this be a lesson for all our 53, 54 countries in Africa, because the treatments that our patients receive have always relied on foreign data, and appreciating how, there is inequities and disparities in our genetic makeup, cancer being a genetic disease, whether acquired or hereditary, definitely we know that our disease patterns are not the same. So we have to generate our own data to also inform development of interventions, health products and technologies. While we are investing on clinical trials which require a lot of capacity, both human resource infrastructure, I think the easiest to conduct is implementation science research, where we are leveraging a lot on what has been proven in other regions. I cannot underestimate the role of partnerships. Partnerships is what is going to advance our efforts. And we've worked with everyone who is here and some who are not here as well. We have to build a workforce. Most of us who are, I would say, mid-career oncologists trained outside the country. And when we came back, together with Catherine here and some of our colleagues who have gone before us, we worked on the curriculum to begin the University of Nairobi Radiation Oncology program, which has now graduated 3 classes. And it is worth appreciating the effort the team at KNH, as well as University of Nairobi, in quickly multiplying the number of clinical radiation oncologists in this country. Because probably the local production right now is almost, half, those who graduated from other programs outside the country, and people can receive treatment without a lot of interruption in their lives, and it is also quality training like what would be received in other places. Medical physics and radiotherapy training programs, I think there are quite a number now in the country. What we need to do is just to tighten the quality bit as we even begin more, so that we as a team, since the 3 cannot be, separated, we cannot work without any of the 3. So we would continue investing in that, including palliative care as well. Let me just go to the final slide on just a call to action that the future of cancer care in Africa will not be determined by the burden we face today, but by the choices we make today. And the best choice we have today is to be here, to contribute into a joint call as a region. We have to build strong institutions, innovations, partnership, research, people-centered care, and Africa can transform the cancer landscape for generations. Need for government-led coordination is important in our countries. And allow me to end by acknowledging the efforts our president has put in being the voice of Africa when it comes to discussing best interests of the regions at that higher scale, even globally. A president that I'm sure every African country now knows, because he always fights on, justice for our African countries, because they have historical injustices in terms of decisions that impacts and influences what we do currently. And having this also professional association, putting us together as a continent, gives us a better bargaining power when we are discussing on opportunities, even in continental, outfits like African Union, where our voices must get there, and also Africa CDC, that guides a lot of policy implementation at that continental level. Thank you very much, and have a good afternoon.
Thank you. Thank you very much, Buena CEO. And I would like to thank you for keeping time, recognizing that we already had about time. May I invite the representative from Siemens? My apologies for the delay. I think it's understandable. May I invite Ms. Ekta Jala to make her presentation this afternoon. Another round of applause, please. Welcome.
Thank you. Thank you very much. And before I start, I want to say thank you to AFROC to really invite us here and the opportunity to be here, present our portfolios, but also our commitments. And with that, just really wanted to appreciate all the efforts that have gone into making this event. So thank you very much, AFROC, for having us. We've been hearing a number of statistics last couple of days. One of them is 1.8 seconds. And you've probably already heard that every 1.8 seconds, someone, somewhere in the world, hears the words, "You have cancer." And that diagnosis changes not just their lives, but their families' lives. And a number of these statistics have been highlighted this morning. What it means for Kenya, what it means for Africa, we have heard. But today, I want to focus on some of the positives. And if I can, there we go. And positives in the sense of the story of radiation therapy. I think the story of radiation therapy is one of success. From 1991 till 2020, we have improved the survival rates of cancer patients by 33%. And that number is staggering, especially when we put it in context of the rising burden. If the survival rates are increasing, patients are living longer and a much healthier life. So yes, the cancer burden is real, but we are on our path of making great progress, and that requires your commitment alongside everyone else. So today, I want to invite all of you to take a moment to be proud of yourself and give yourselves a huge round of applause. So thank you very much. And I think that actually is one of the reasons why we are seeing the big difference. And if my slides would stay there, I could talk through. Sorry about that. So, and like I was saying, we see about 50%, and if you think about the recurring number of patients, 50 to 70% of patients with cancer benefiting from radiation therapy, one of the most cost-effective treatments. So how do we make this really scalable? How does that really make it into their, how do we give access to the patients? And this is where your work matters. This is where your community and the work that all of you do together, and forming the society was one such thing, so congratulations, really makes a difference. But today, we are in radiation therapy, we are at an inflection point. We have seen a huge strides, but there are more to come. This landscape is evolving with such speed that it is getting harder and harder to keep up with the technology and to keep up with the growing number of modalities that are available. So today, radiation therapy's use in number of diseases, or like lymphomas, is reducing, while its use in terms of SRS, SBRT, different types of techniques is increasing. We are connecting, and we are bringing more and more connecting our adjuvant therapies with theranostics, with immunotherapy, and that progress is being seen. It is noticed in terms of improving survival rates, and in terms of resurging roles in different disease sites, like pancreas, like growing roles in the early disease driven by screenings, etc. So we have been thinking about how do we give you even more of a way to be able to get these treatments available for your patients. We heard about the need for going end to end, the need for starting from screening and going up right up to survivorship, right from not just primary care, but also focusing on how the patient navigation works. But none of the platforms that you have available provide that, right? There is no one solution that you have available today that you can use to bring that safety and to bring that solution for your patients. Solutions are very fragmented. So we are building an ecosystem for the future with the mindset that efficiency leads to efficacy. And what do I mean when I say efficacy or efficiency leads to efficacy? So if you remember, and I think I'm old enough here, some of you probably aren't, to remember what the advent of IMRT was. When we started IMRT, the use of IMRT was for 1%. And I used to call it, IMRT stands for I am really tired, because the number of QA it made us do was really extensive. So that also meant that the way we started implementing it was slower. The adoption was much slower. But as we started adopting it, we were able to bring the efficiencies in. And that also resulted in an improvement of the survivorship, in an improvement of patient outcomes, clinical outcomes. That is where I mean efficiency leads to efficacy. So with that in mind, like I was saying, we are building platforms that give you a truly integrated approach. And integration is not just about platforms. So here today, when I'm saying end-to-end, we as Varian have combined forces with Siemens Healthineers, so we can bring you better integration. So we can give you a more complete solution from end-to-end, not just from technology perspective, also from our platform software perspective, but also with collaboration. And that collaboration is with you, is with your clinical partnership. So today it is my pleasure to talk about some of the innovations that really continue that journey and talk about how that innovation enhances outcomes. So at this year's Astro, our theme was Embracing Innovations, Enhancing Outcomes, which really brought our new platform, Halcyon, in the new version to life. And I'm Ekta Jala. I lead the marketing for Varian EMEA. And today, I'm very proud to bring Halcyon to you and introduce the platform to this market. And this is powered by the innovation. So Halcyon, in its true form, when we first introduced, you're probably aware that we were all hearing that this is platform only for certain countries. We do not want this. However, the advents or the innovations that have been introduced on this platform today surpasses everything that we have had so far, especially with the integrations that you see coming. So let's take a look at what am I talking about? Why am I so proud to bring you this platform? And I will highlight that while today I'm a marketeer, a few years back, I was one amongst you. For 18 years, I have been a clinical physicist. So my lens of looking at a platform is not very different to yours. Even today, when I talk about marketing, I forget some of the words and I start talking like a physicist because I'm challenging my teams to say, why does it matter to a physicist, to a radiation therapy who don't have the time to really take on the platforms? They need to be looking out for their patients. I'm not sure why the slides are. So with that, Halcyon here, we have now introduced the new version with integration of Identify, which is our surface-guided system, integration of Hypersight, which is our imaging technology that is across all our platforms, and a new couch called Perfect Kinetics Dynamic. Now, the speciality of this feature or this couch is that it enables 6 degrees of freedom on the Halcyon system. Now, you can imagine when it's a ring system, having 6 degrees on the couch is extremely challenging, but that is exactly what this platform brings. You can imagine that today, a number of patients are not getting the same level of accurate treatment as on TrueBeam on Halcyon because the platform or the couch wasn't able to do those things, or because they were not able to hold their breath in as long as required. Now, with the integration of Identify and the couch together with Halcyon, gives it one holistic system, which means you do not have to interfere and manually move the patient between their fields or between isocenters. So you do not have to think about whether the patient's breath has been translated to the actual patient position through the couch motions. So once the image is acquired, once the couch is registered the position through Identify, it automatically takes the patient in that position. So your accuracy is improved, your time is reduced, and you are more confident because you're seeing better images. So now I've explained what the value of this is. I'm going to take you a little bit through the details of the system. So you probably already know the technology highlights, right? This is a ring gantry system. Unlike TrueBeam, which most of you are aware of, is a C-arm, we call this as a ring gantry system. It also has a water cooling installation inside it, but the bigger component that is different to TrueBeam is the beam stopper. What this does is it stops the beam within the system so your primary walls can be less thick. That means your footprint or the actual bunker size can be smaller than what you require for a TrueBeam. That means the concrete that is required to build that bunker can be smaller, and we'll take a look at how much smaller. But that also means that the investment in building of a bunker is smaller. So this platform was designed and the innovations on this are designed with the total cost of investment in mind, with the total cost of your time in mind, and with the total cost of your efforts on an ongoing basis in mind, not just from a building perspective, but also from a day-to-day use perspective. How do we give you the confidence to be able to continue doing that every day without having to take more time and without having to have long trainings? So this is a single energy 6MV triple F and then dual layer MLC. So I will take you through what the MLC looks like, and we can discuss at the breaks if you have any questions around what exactly are the benefits with that. So Halcyon has a dual layer, double height, stacked and staggered MLC, but because of the double stack, it means the transmission through the MLC is really low. It's 0.01% with full field 28 centimeter over travel and 5 centimeters per second leaf speed and 5 millimeter effective resolution. So that was the MLC. That hasn't changed with the new platform, but the Perfect Kinetic Dynamic Couch is the couch that was introduced with this new version. And this couch has the additions of pitch, roll, and yaw, of course, alongside the rotations and the translation movements that you've already been experiencing, and that gives it the 6 degrees. So that allows you to really rotate and give your patients exact positions that you are seeing that is required for the accurate treatments. It also has increased longitudinal travel, so you are setting up more accurately and you're able to treat at any point in the patient in one single setup. So if your patient has dual isocentered through the body, you can still have them head first and be able to treat them in that same setup. But it also has an increased payload for those patients that require a little bit more of are heavier, they require a bit more of strengthen and the robustness in the couch, because otherwise the couch has a drift if the payload is not heavy. So that really increases the versatility of the couch, and then it has an image-based calibration, so your calibrations can be made easier. You're not, and the physicists here probably know how you calibrate the couch by loading up with kgs and kgs of water. At least on my back has really still remembered all of those times of loading the couch with water. So what I was trying to highlight early about the platform itself was that the combination of this dynamic couch along with Identify does help us make it more precise, more accurate, and it makes it a much more safer delivery system. But I don't want you to just listen to me. So there is a video here, and there we go. If you can hear it. I wanted to bring you voice of some of our users that really shows, and this is Dr. Palm from Germany. Can I get the volume? It's all right. Don't worry. I think you can read the quotes. But these are centers that are from Germany, from France, from Australia, and they are very proud in getting these platforms because from their perspective, it has expanded the patient pool that they can treat on these systems. What was previously a limitation because of the breath hold patients is now enabled with this platform and with the integration. So more and more of these centers are adopting Halcyon mainly because it gives them the flexibility of having the number of patients that they're always used to, or needing to expand that number to a point where, if you remember, one of the centers, first adopting Halcyon, were treating 200 patients with the single machine just by having shifts in a single day. So that patient throughput can still be achieved. And today, most of our centers can treat up to 80 patients on a single machine with Halcyon. And that really, really increases the patient experience because they are just in and out very shortly. But also the therapies or the radiation therapists experience because they can really speed up and put their time and attention towards the patients. I think it was Nancy yesterday who was talking about how technology doesn't heal, but it is the compassion from you that provides the healing. Technology provides treatment. So to be able to have that compassion, you need time. You need time away from the technology so you don't have to focus on the technology. And this platform allows you to do that. So I talked about Identify. What does Identify look like? And here is a picture of it, and somehow it keeps going in the screensaver mode, so I do apologize for that. The Identify system has 3 cameras in the room. It has a large in-room monitor, and it has automated beam hold. Now, when this is already implemented with Identify, and you can connect that with the LINAC, then you're not having to manually monitor and hold the beam yourself. So the automation itself means that you can be more precise in your treatment. The automation of couch shift means that you can really implement those shifts on the patient on a automated way and get that done in a very short time. So some of the more details around Identify components with regards to the respiratory management system in the CT room, some web-based planning tools, and some treatment room, which is for the SGRS. Now coming to the efficiency itself of the Halcyon system. So Halcyon, I talked about initially from a total cost of ownership perspective, but when it comes to commissioning, it has also implemented much more acceleration in terms of installation and commissioning. And if you compare that with any other platform today it can do it in 10 days. So that fast install and deployment is translating and giving you a much shorter time in terms of acceptance, in terms of commissioning, and in terms of installation, which means your entire install and commissioning, your machine can be ready in less than a month, which means that your time on the machine can really be reduced and you can focus on how you need to get that ready for your patients. With the commissioning, it comes with pre-installed golden beam data, so you are only needing to do spot checks, and this golden beam data is across the world, the same across all Halcyon platforms. They are matched across all the machines, and therefore you don't need to spend hours and hours collecting those beam data for every day. So that was a bit about the installation time. Now the efficiency and achieving more, like I said, the 2 weeks for installation time, 1 week of commissioning time, and the time your patients spend in average is about 8 minutes. The 65% is about the estimated amount of concrete reduction and 70% of power consumption reduction. And I have those numbers a bit more bolder up here so you can take note of that. So it reduces your power consumption, which is a huge thing within this continent, is 70%. 24% of less weight, so the machine itself is less heavy, and 30% of less concrete, and we've already translated that in terms of the bunker size and the footprint, etc. So overall, you can see the changes from Halcyon right from 2017 up until today with the innovations extended and implemented across the world. But to summarize that, I wanted to bring up that slide which talks about how this is one of the only machines that is a truly automated IGRT machine because it follows the 6-step, follow the blue light principle. So you can really automate and really get through that patient treatment in an efficient way and in an optimized way. It has a very patient-centered, so patient's comfort is improved and the RTT's comforts are improved. So that is the progress that we are seeing in terms of the technology itself, but this is bringing a new level of revolution around radiation therapy, especially when it comes to the number of patients that require treatment, especially that it requires about 200 patients, like I was saying before. And with that, I want to move to giving you a little bit of an update on the other platform, or our most favorite or most largest install base of TrueBeam. And TrueBeam is our flagship today, is also our second, well, rather most versatile platform. So today, when we keep calling TrueBeam our flagship, the reason being that we've got Halcyon as coming up right alongside it and talking and taking up almost the same number of patients as a TrueBeam can treat and much more. But it gives you the same versatility. It gives you a lot of additional ways and patients that you can treat. Of course, if you are doing very, very focused SRS with, say, 4 millimeter sort of trigeminal neuralgia treatments, you would still want to keep that on TrueBeams, but everything else is now available for treatment on Halcyon, and there are lots and lots of publications that give you that ability to implement new treatment techniques on the Halcyon platform. So TrueBeam, though, is built, that is where our trust and our reliability was built. That is the focus of most of where we started from the C-arm. It is one of the most versatile platforms. It is one of the most optimized and customizable platforms because it can bring a number of different techniques and different imaging modalities that you can use at different timestamps in your patient journey. So the number of different images that, or rather image acquisition techniques that are available are all allowing you to give different types of treatments and opening doors for different types of indications like 2D, 2D, 3D, 3D, gated, 4D, you name it. And it also gives you ability to be able to use triggered imaging that is hugely important when you're doing 4D treatments. So that was a little bit about the TrueBeam platform, but what I also want to touch on or highlight is HyperArc. And HyperArc is one of the most essential on the TrueBeam platforms, especially if you're doing multi-met treatments. So if you've got patients that have multiple brain metastases and you are treating them one by one, currently, without HyperArc, you are needing to treat each individual met separately, taking up 15 to 20 minutes per met. And that's not even the planning time. That is your time on the machine. So overall, if there are about 6 to 8 mets, that's easily over an hour or so. Patients lying on the couch for over an hour. Now, with HyperArc, you have one arc that you can get with one isocenter and treat all the 8 mets or 10 mets, as many as you need, in that single arc with the imaging that is automated and with the motions that are on, or rather positioning that is automated. So HyperArc really allows you that single isocenter treatment for multiple metastases and has the anti-collision, non-coplanar VMAT kind of treatment deliveries. It has the automated imaging and patient setup, and also streamlines your workflow or your treatment planning workflows. It's done. This I will talk a little bit more about in my session tomorrow. However, what I do want to introduce is RapidArc Dynamic. Now, it was introduced a couple of years back on the TrueBeam platform. This has been a new treatment technique. So if you know of IMRT and then to VMAT, we introduced RapidArc Dynamic a couple of years back, and that introduces a new dynamic collimator and the ability to add static ports. But I will go into more detail about RapidArc Dynamic on the TrueBeam platform a little bit more in details tomorrow, because it takes more of the planning perspective, and then we can talk about how that delivery works once we've talked about the planning itself. And So those are the two main platforms that we have today. Of course, we've got Ethos, which is a dedicated platform for adaptive therapy. Not much of too much of news on there right now, except that the one big challenge that we've been hearing from our users was it being an island, which has now been rectified, and we've introduced some changes there. But what I wanted to next focus on was some of the developments across all our platforms, and that is HyperSight imaging solution. So you heard me talk about HyperSight a bit earlier in the session when I was starting to introduce the Halcyon platform, or the new version of Halcyon platform. But what I wanted to also do was give you a bit more insight about HyperSight. So HyperSight was introduced on the Halcyon platform a few years back. We now also have it on the TrueBeam platform. There is slight differences between the two systems, right? On the Halcyon, you have a much larger panel. The panel size on the Halcyon is 86 centimeters by 43, whereas on the TrueBeam, it is a 43 centimeters square. But with Halcyon, this also means that you get a much larger field of view. You do not anymore need to combine or stitch two cone beams together. That is also true for TrueBeam, whereas the field of view is not as large as Halcyon, but it still gives you an extended field of view relative to the cone beam CT setup today. So the HyperSight imaging panels removes the need for extended field of view, but that is not even its main feature or the main value it brings. The biggest value it brings is you get the confidence, because the image quality that it brings is almost similar to the diagnostic CT image quality. In fact, they have been compared, and I will show you some graphs that overlay each other with regards to the image quality. So HyperSight imaging gives you the confidence that allows you to really expedite your own decision making and be able to treat your patients without having to second guess yourself, without having to take multiple images to see some parts of it. And that itself has changed the time required per patient per treatment in a number of clinics. The other element is the new software algorithms that HyperSight has. And that actually gives you some reconstruction algorithms that are based on Accuros. So it removes metal artifacts that gives you all of those artifacts and a lack of visibility of some of the metals when it has metal implants. So HyperSight really allows you to look at the images with the quality and with the accuracy that you require. The other major benefit, and this is my major benefit, but I'll take you through some image quality. When I've talked about it, I'll show you some images here. So here you can see the stomach, the pancreas, and which are usually extremely challenging. And I think some of you radiation oncologists in the room here will probably agree with me in saying that those are one of the most challenging organs to see on cone beam CT especially. And I see a few nods, so thank you for confirming that. I will continue to the next image. There we go. So here you see the extra or extended field of view that I was talking about. On the left is your normal cone beam CT, and on the right with HyperSight, you see a much larger field of view that extends. So that really can enable you removing the need, because you only are needing 2 or 3 centimeters sometimes of that extended view, and that requires you to have 2 cone beam CTs that are stitched together. With this extended field of view, you can now remove that need. So HyperSight enables you to do that. And here I have a little bit of a comparison with regards to the SIM-CT, with regards to the conventional cone beam CT, HyperSight cone beam CT, and the cone beam CT with metal artifact reduction. So assuming I'm not in the way, but you can see the difference, and you can see how clear a view it gives you with regards to the setup. We didn't talk about the speed of the imaging, and this is one of the big other benefits. So what initially we were talking about some 23 seconds of image acquisition. With Hypersight on Halcyon platform, it can do imaging in 6 seconds. That is almost the time where any patient can actually hold their breath for 6 seconds. They may find it difficult for 14, but for 6 seconds, pretty much everyone can hold their breath. So we can introduce a single breath hold imaging, almost removing more and more of those artifacts that are introduced based on the breathing motion. When it comes to the TrueBeam platform, the imaging time required is close to the 14 seconds, but that was again reduced considerably from what your traditional cone beam CTs require. So single breath hold is all you need. Reduced imaging times increases options for breath hold patients, like I was saying. It expands your patient pool, and it improves the image quality due to less repeat image, optimizes the cone beam CT start-stop positions, and enhances your gantry rotation speed between the treatment fields. Be mindful, this is only the image acquisition time. Now, when I was talking about the precision, I didn't mention the precision of Hounsfield units. So with the advanced algorithms that are introduced with Hypersight, one of the benefits is the Hounsfield unit's accuracy from a cone beam CT is exactly the same as a diagnostic CT. So here you can see the difference between the SIM-CT and the cone beam CT, and they overlay pretty well. So this means that you can actually use a cone beam CT directly for your treatment plan. You can use that whether you're trying to adapt a patient's treatment plan midway through the journey, so you don't have to send them for a second CT scan, or if you are doing an emergency patient and you're needing a simulation at the same time. If you have access to radiology kind of limitations, that also opens up doors for more patients faster. Finally, I wanted to talk a little bit about Maxim QA. Now, Maxim QA is an automated QA that is integrated within the machine itself. So it provides an integrated and an automated machine QA solution that enables your adoption and use of advanced features. So you probably know a lot about the MQA today, or MPC. This is a form of MPC that is much more advanced. Therefore, you can do many more QA tests with that automation, and you can introduce and integrate that within your QA practices itself. Now, all of these platforms are developed and advancing at the rate because and alongside the advances that are made on the software platforms. And that platform is ARIA Core. So today I'm only alluding to it, but for more information on all of the ARIA Core and treatment planning systems, how are we bringing AI contouring in the mix, etc., we will talk more in details tomorrow in the session tomorrow afternoon.
Thank you. So maybe just wind up.
Yeah, last couple of slides. So with that, I was just about saying thank you, but what I wanted to also highlight is that to create that world without fear of cancer, which is what our mission is, we do want your support, your collaboration, and together we can do more and more innovations in that integrated way. So, where you live does not determine if you live. And for that, we do want to get your support in creating a world without fear of cancer. Thank you very much.
Thank you very much, Hector. The reason why I did not interrupt you is because I was told you're a physicist, and I'm told physicists have intense thought flow. If you interrupt, you'll have to restart that process. So thank you very much.
Thank you.
And welcome again to this part of the world.
Thank you very much for your attention.
Yeah. For the interest of time, we would like to request that the presenters that are supposed to be presenting after this to present in the next session. Albeit we will have to shorten the time so that we can accommodate all the presentation in the next session. So for now, we will proceed with lunch. Thank you very much. Another round of applause for Hector. Prof has directed, not requested, has directed that we should be here by 2 o'clock. So today we're going to behave like we're in a military camp and eat as quickly as possible.
With this work platform that unifies your entire team and all your teams together in one place. Now, no space for your flagship inbox, whiteboards and dashboards, calendars and must be a clear engagement plan for your team. Get more done. This is the future of mission recruitment. How do you use this? What's the name of today? How long is this? Get over this way. Projects on autopilot, where you have agents that assign and prioritize your team's tasks. So look at this one, everybody knows what to do, and even ready. Represent your work team, who always tries your best. The intern is taking all of that on, good for her. Click up. What's your disagree to in that meeting? And so how do I do that? Okay, send it to my team to review. Work faster with your team, doing multi-billion-dollar companies. How to keep the work. Yeah, click on. Today. I mean, really cheap. You choose it. She loves it, right? Alice, you can hear me. Right.
Let's say you're chatting with a friend on WhatsApp, then suddenly you see a photo catalog from your favorite brand. If you talk slightly, you're browsing, acting pictures, welcome to WhatsApp traffic, the future of e-commerce. But what exactly is WhatsApp traffic? It's a feature that lets businesses sell products directly through WhatsApp. When you visit websites, this browse, track, and buy all your benefits. Let's dive into the key benefits of WhatsApp traffic. Let's dive into engagement. Businesses will apply to WhatsApp traffic directly, ensuring no one got in it. This is a great way to increase conversation rate. Let's personalize traffic. Businesses can use your preferences to send tailored product suggestions, making traffic feel more personal and specific. WhatsApp traffic also lets businesses boost engagement. It's easier than ever for customers to complete their purchases, and it's mobile first. Customers can shop anytime, anywhere, without switching between brands. This is possible in very simple features. From tracking brands and selling all businesses, WhatsApp shopping exercise education. Whether it's browsing the latest iPhones, ordering groceries, or buying a new camera, businesses are creating seamless shopping experiences.
This is the
Cybersecurity is not just an antivirus. I'm Professor David Costa, the Dean here at Robert Kennedy College in Switzerland, and I'm here today to introduce the University of Lancashire Master of Science Cybersecurity with Artificial Intelligence. You can now complete your British Master degree entirely online in just 1 year. During the program, you will be studying 4 specialized modules in the area of cybersecurity with artificial intelligence to then proceed with a professional project which, unlike a traditional dissertation, is much more practical and can be used immediately in your career. Request our course catalog and get started today at the University of Lancashire, where opportunity creates success.
You know exactly what will take your business to the next level. Websites, apps, newsletters, slides, and animated videos to stand out. So you hire consultants to design them. 13 days later, not what you wanted. You ask an AI chatbot instead, and it replies with a list of tools and a single image. Still not what you needed. But there's a new way. Describe what you want and watch it become real. Slides, websites, apps, newsletters, animated videos. Replit recommends the next move and builds it, not just images. For everyone else, there's chatbots and cat image generators. For you, there's Replit.
My name is Rosalina Kumu, the President Oncology Nursing Society Kenya. Today, I'm super excited to be attending AFROG conference with the theme, Innovation and Precision in Radiotherapy. The day started well with the pre-conference workshops. We've learned about toxicities, patient perspectives, the support, the researches that are coming up, and just to ensure that we have end-to-end care, multidisciplinary talks, and a lot more is expected tomorrow. So I'm requesting you people to join us tomorrow early morning, and we're gonna have a very exciting dinner at Carnival on Saturday. See you there.
Today was the first day, actually the workshop, for our 11th African Radiation Oncology Conference, AFROG, here at the Agile Grand Hotel in Nairobi, Kenya. And being the 16th of July, our theme for the conference is Innovation and Precision in Radiotherapy. So basically, the day has been amazing. We started very early in the morning at 9. Before then, we had breakfast from 7 to 9, and then from there, we started our presentations. So we've talked about challenges, solutions for oncology care, the patient journey, patient navigation, and ultimately we've had international speakers talking about precision oncology. This afternoon, we are crowning it up all with contouring. We had 2 amazing presentations in breast and esophageal cancer. Then we had residents from the university who are doing radiation oncology contour cases practically, given the platform through Varian. And they are contouring, and we are just hoping to see the final product as we close the day. And thank you, Vital Science Studio. Thank you, all the sponsors, for making this possible. And MMS for being like the coordinator for this conference. Thank you so much, and we're looking forward to day 2 of the conference, where we are going to meet government officials, and we are really looking forward. We are hoping our CS Health will come. We'll have Anyang Nyong'o and other industry leaders, CEOs of hospitals, and more amazing presentations. And we really thank you, and we want you viewers to be locked in. Please see you tomorrow morning. I will not miss, I'll be here. Thank you. Bye.
Good evening, colleagues. What a wonderful day we've had at the
late, especially coronary side effects, DIBH would be my first choice. I'm just going to spend a little bit of time on fractionation. I know some of the other speakers are going to touch on that. This is quite a nice slide for me. This is basically just summarizing what's been happening with fractionation in breast cancer over the last 30 years, I would say. So, I mean, I think we all know the START-B, the UK FAST, and the fast-forward trials that's been dictating how we fractionate for radiotherapy. As we know, the START-B trials basically compared the normal 50 gray in 25 fractions to 40 gray in 15 fractions, and found that the local control as well as the late toxicity rates were the same. Then UK FAST went a little bit further and said, well, what if we give 28.5 gray in 5 fractions over 4 weeks? Is it equivalent to the normal 50 gray? And we found that it was. And then the fast forward trial came where we are delivering 5.2 gray in 5 fractions, resulting in 26 gray. And we found that that's the same to 40 gray in 15 fractions. This slide just basically shows that if we look at the UK or at the FAST trial, they actually compared 2 fractionations to the 50 gray in 25 fractions. They compared a 30 gray in 5 fractions and a 28.5 gray in 5 fractions. And the cosmetic difference was definitely better with the 28.5 gray group, which led to the general adoption that the 28 gray in 5 fractions once weekly is an appropriate alternative. Then the last little bit, or I must say the most recent evolution in hyperfractionation came with the fast forward trial, where they compared 1 week of radiotherapy to 3 weeks, the standard 40.06 gray. And I think it's important to maybe just look at the inclusion criteria for the fast forward trial. It was patients that had breast conservation surgery or a mastectomy. They could have had a lymph node dissection or a sentinel lymph node biopsy, and it was either T1, T3, and up to N1 disease. They basically compared the standard 40 gray and 50 fractions to 2 slightly different fractionated approach, the 27 gray and 5 fractions or the 26 gray and 5 fractions.
Kindly conclude.
Sorry?
Conclude, kindly.
Okay, thank you. Then basically, if we quickly look here at the outcome of the trial, we found that the in-breast recurrences as well as regional relapses and normal tissue effects were all comparable. The normal tissue effects were slightly better with the 26 gray group, which then I would say the conclusion is that 26 gray and 5 fractions is non-inferior to 40 gray, and it has slightly better tissue effects than the 28 gray group. And I'm going to stay on time. Thank you.
Thank you, Dr. Pos, for that wonderful presentation. Unfortunately, because of time, we need to sort of interrupt your presentation. I'm sure we can discuss more during time. So may I invite Dr. Nyongesa to present Wiki Moja.
So thank you so much, Caesar, for that leadership you are providing for the afternoon session. So good afternoon, colleagues. I'm going to present about the Wikimoja study, which is just a follow-up on what you've just presented, my previous speaker. And it is a 1 week radiotherapy comparing to 3 weeks, and this was done at the Kenyatta National Hospital. And why breast cancer matters? We know that from the morning sessions, most of the cancers we see, like say in Kenya, breast cancer is leading, followed by cervical cancer. And in Africa, it is a high mortality burden, and early and effective treatment is essential to improve survival. So why was this study needed? We noted that in public facilities or high volume centers, patients are waiting for so long before starting radiotherapy. We also have limited number of radiotherapy machines. We are not able to buy to meet the international standard of 1 machine per 1 million people. So, and then we have evidence that actually 3 weeks of radiotherapy is equivalent to 1 in selected cases. And when you delay treatment, the cure rate is also reduced. So the aim of the study was to test whether it had comparative results to the 3 week in terms of local regional control, treatment-related toxicity, quality of life of the patient, and overall treatment efficacy. And it was a phase 3. This time round, this is in real Africa setting where we are using 3D conformal radiotherapy, and patients, majority are stage 3, so we included them in the study. And the regimens, we gave 14-15, that takes 3 weeks versus the 26 in 5 fractions running for 1 week. So 1 week in Swahili means Wikimoja, and that is the name, Wikimoja Radiotherapy Study. So we had a challenge in accrual because you recruit and the machine breaks down. So with a very high ambitious number of 400, I stopped at 117 with 59 in one arm and 58 in the other arm. In terms of the tumor biology of these patients, 77% are hormone receptor positive, 20% loci 67 of majority of, 20% had a loci 67. And when we now looked at the stage, 64% of this cohort was stage 3, which means majority of this patient had neoadjuvant chemotherapy. Also, when looking at their treatment journey, because the decision, there are still a delay. And the worst hit are those who went through neoadjuvant, because now after the chemo, now they have to go look for the surgery, and there's a queue there. In terms of the treatment days, obviously Wikimoja is shorter as the 26 in 5. With the 3D, the cardiac toxicity, we are looking at the left-sided tumors, and if you look on the slide, we see that if you are using 3D conformal for 3 weeks, the EQD2 is 8.8 gray, but when you do the Wikimoja, then we got 3.03 using 3D conformal. But there's a study out of India which they used the DIBH, and their dose dropped slightly. If you look at that, the 3.01. And the fast forward, the doses were quite minimal. So as we improve on technology, we are going to reduce. But generally, if we do in equivalent terms, the 1 week radiotherapy has less dose to the heart. The same translates even into the lung comparison. In terms of toxicity, it still translates into what Fast Forward showed, that shorter fractions, like the 1 week, the week moja patients had fewer skin toxicity compared to the standard arm of 3 weeks. So in terms of adverse events, we have ticked that box. In terms of quality of life, on body image, most women reported better body image with the 1 week treatment, and it was statistically significant. When we look at the recurrence by each treatment regime, the longest we followed them up is 30 months, with a median of 17 months, and we are seeing the 1 week slightly better, but not statistically significant, so which means they're actually equivalent treatment protocol. So there's no loss of local control. The few patients who recurred, we went down again and analyzed, and actually it's the biology. Most of the recurrences and mets are in HER2-enriched tumors and in triple-negative breast cancer. So it is not the regime of radiotherapy, it is the biology of the tumor sometimes which dictates the recurrence rate. But with the improving early diagnosis and treatment, women with HER2-positive breast cancer and even triple-negative can live long. In terms of what we set out to achieve, I think it has ticked all the boxes. So this is a short follow-up. So we'll continue updating with more mature results. The strengths that we are doing in real in settings, even 3D conformal, has shown that you can actually use this protocol. The weakness is really the accrual, and then is a single site study. And with implications, I think it is one of the protocols we can implement, because it can expand access. Instead of treating patients for 3 weeks, you treat 1 week. Then in that week, you can actually, in a month, you can increase uptake of patients by 70%. And women go back home much faster. Then in terms of cost, obviously, you reduce out-of-pocket costs, because patients, when they come, they are spending money on transport, accommodation, and they are staying with family. So if you tell me I'll stay with my family for 1 week, I think it's better than staying with family for 3 weeks. So we need longer follow-up. And I want to take this opportunity to thank the patients who agreed to go on this study, and my co-investigators, Dr. Njiraini, Regina, Daniel, and Christine Wamboi. Thank you so much.
Thank you. Thank you, Dr. Nyongesa, for the wonderful presentation. Yeah, because we're already 1 hour late, maybe you could have that discussion with Dr. Nyongesa as you sip champagne, I guess. You know. So may I invite the next chair of the session? I don't seem to see her here. Where is Nancy? Okay, in the absence of Nancy, let me just invite Dr. King to chair the next session. So in the next session, we are going to have Dr. Athman start off.
So the next session will be a plenary on equity, innovation, and supportive care. And we'll start with Dr. Professor Joseph Wingard. The title will be Historical Determinants of Access to Cancer Care in Sub-Saharan Africa.
So yeah, while he's setting that up, I want to know, I said this yesterday, I'm usually a little too loud for a microphone. So do you guys think I should use a microphone or not? Yes. I'll use it then. But you've been warned. Yeah, so yesterday I was had the opportunity to talk about Rad Aid. So today I'm going to speak about a very, very different topic, kind of an oddball topic, I would say. Yes. Is this better? Yes, perfect. Yeah, so I'm going to be speaking about a kind of an oddball topic, I would say, namely talking about the historical determinants of access to cancer care in sub-Saharan Africa. So as we well know, right, access to radiation oncology throughout the continent is starkly heterogeneous, and we've seen a lot of high-impact publications over the last decade or so, and they all seem to end with calls to action, where the authors are imploring African governments to increase access to radiation oncology, and oftentimes I've seen those calls to action seem to be ignored or either only partially carried through. And it got me thinking, what determines whether a given population has access to cancer care or not? Well, it's really complicated, right? It's a complex interplay of economic, geographic, political, social, ethnic, and historical variables, right? So this got me thinking, right? I want to do a full analysis trying to figure out whether we can predict whether a given population has access to care or not. Doing all of that at first is too big of a step, so we're going to isolate one of the variables and just look at the historical factors and ask what impact did European colonialism have on access to care in sub-Saharan Africa. So as you guys probably all learned in school, European colonialism began in earnest in 1885 at the Berlin Conference, chaired by Otto von Bismarck, the bald guy in the center. And despite the fact that only one of the people at that conference had ever even stepped foot on Africa, they sliced the continent up like a piece of cake, right? And separated ethnicities into different countries, like the Luo, for example, in Kenya and Uganda. Or they took ethnicities that had been antagonistic for centuries and put them in a same country, like in Nigeria, for example, right? And my argument is that a lot of the problems that have transpired in Africa over the last 250 years originated at this Berlin conference in 1885. And the fact that they didn't have any African voices to defend themselves. So I've given this talk a few times in the US, and I always have to show this because they're not very familiar with the colonial map of Africa. But here, you guys probably are a little bit more familiar. So Britain had a big corridor of territory across eastern and southern Africa. They said from the Cape to Cairo. France, and they also had a number of West African territories like Nigeria, Ghana, and Sierra Leone. France had a large swath of Western and Central Africa. Portugal just had a few colonies. You see Angola in the southwest, Mozambique in the southeast, and Guinea-Bissau in the west. And Belgium had the big colony in the center of Africa, what they called the Belgian Congo, today Democratic Republic of the Congo. Spain and Italy were minor players, I would say. So Spain had Equatorial Guinea. Italy had what is today known as Eritrea and sort of Somalia proper. So we'll ignore them and just look at the main four: Britain, France, Portugal, and Belgium. So all of European colonialism was exploitative and extractive, hard stuff. However, there were differences in how those different European countries sort of regulated their colonial territories. England operated with a system of direct rule where they would kind of give orders to the local chiefs, so the local chiefs would then kind of propagate that out to their countrymen. They also had a number of settler colonies where people from England would come to Africa and live. And obviously they invested a lot in those colonies, such as here in Kenya and in South Africa. They also believed in education, and they allowed for the education largely to be in the local language, so it was more likely to be uptaken by the people in Africa. France also believed in education, but they insisted that education was in French, and that caused the education to be taken up less in the French colonies than in the British colonies. They also held on to power in Africa more violently. This is best illustrated with the Algerian Revolution, even though we're mainly talking about sub-Saharan Africa here, which was the most violent colonial war of the 20th century. And also, when the French left, they didn't really leave, right? They still exert neo-colonial influence on their colonies even 65 years later today. The Portuguese, during much of the colonial period, were under fascist rule. So the people in Portugal itself didn't even have any freedom. So as you can imagine, they didn't invest anything in their colonies at all. They also held on to power very violently, as the Portuguese colonies of Mozambique and Angola were some of the latest African countries to finally get independence, all the way in the mid-70s. And they needed violent civil wars to be able to get free from Portugal. And they, needless to say, they invested almost nothing into infrastructure. And then the worst example of European colonialism was Belgium. This is immortalized in Joseph Conrad's novel, The Heart of Darkness, where he basically ran an open-air slave state where he extracted from the native Congolese for the rubber trade, so he made millions and millions of dollars. And then even when the Congo became independent, the Belgians, along with my country, unfortunately, had a coup d'etat where they went in and kidnapped the prime minister of the Congo, Patrice Lumumba, handed him over to his Congolese enemies, and he was assassinated outside Lubumbashi. So basically, what does any of this have to do with cancer? And basically, my argument is that the European colonial legacy still predicts for access to radiological health services in 2026. 60-something years after independence, there still is the colonial legacy here in Africa. And that access, based off what we just talked about on the previous slide, access scales in the following order, with the former UK colonies being the highest, then coming France, then coming Portugal, then coming Belgium. So what we did was we organized the countries in sub-Saharan Africa based on their former colonizer and on their European language. We then quantified access to radiotherapy services using IAEA DIRAC database. We normalized based off the IAEA benchmark that there should be 1 MV unit per every million population. We did the same thing for brachytherapy, and then we quantified access to diagnostic imaging using the WHO's Atlas of Medical Devices, and again, normalized based off population. So what do we find? Kind of exactly what we thought we were going to find, that access to radiation oncology, even in 2026, is predicted by a former European colonizer, where the former UK colonies have the highest access to radiation therapy, then coming France, then coming Portugal, then coming Belgium. What you can see here is that roughly 30%, you could say, of former UK colonies had access to radiation therapy in sub-Saharan Africa, where if you go all the way down to Belgium, only roughly 3% of people in former Belgian colonies have access to radiation therapy today. You see a similar trend in HDR brachytherapy, and then across the gamut in diagnostic imaging. Similar, when we organized it by language, you see the same sort of trend where you see the English-speaking African countries are way more advanced than the French-speaking and Portuguese African countries in radiation therapy and in diagnostic imaging. So if we want to predict what's going to happen tomorrow, we want to look at education, right? So I'm a medical physicist, so I happen to look at medical physics graduate programs. And there was a publication from a few years ago by Professor Ige from Nigeria. And in that publication, this was 6 years ago, he showed that there were 17 graduate programs in medical physics in sub-Saharan Africa, 10 in Nigeria, 5 in South Africa, 1 in Ghana, 1 in Zimbabwe. Obviously, in Kenya now we've developed 2 here at TUK and Chuka, but at this time there were only 17. And what do you notice about all of them? They are all in English-speaking Africa. As far as I know, in French-speaking and Portuguese-speaking Africa, there are no graduate programs in medical physics at all. So me and my colleague, who is Brazilian but based in the US, we're trying to create a medical physics program for the former Portuguese-speaking colonies. There was a lot of local heterogeneity in this, right? Because obviously the UK didn't invest equally in all of their colonies. We were able to quantify how much they invested based off access to care today, and we saw a weak signal. I want to shout out my student, Dr. Iman Suleiman, who did a lot of this data analysis. Yeah, so in conclusion, colonial legacy predicts for access to radiological services in 2026, even 65 plus years after independence. We also ran a sensitivity analysis where we showed that this analysis holds up in the presence of removing outliers. And ultimately, this is just one step, right? We want to, like I said in the intro slide, we want to more robustly be able to predict for access to cancer care throughout the continent, and the historical dimension is just one variable. And this study has a kind of actionable consequence, right? Because it shows that those of us that work in global health, we need to really step up our game in the French-speaking and Portuguese-speaking world, parts of Africa. Also, those of us that work in global health from the West, you could say, need to understand that when we're building these collaborations, there will be justifiable suspicion. We Mzungus did not always have the best interest of Africans in mind, to say the least, right? So we need to work through that, and we need to build relationships with the local partners in the country to be able to establish these longitudinal relationships and to be able to help mitigate some of these disparities in terms of access to care. And we're currently in the process of publishing this, so it will be in print hopefully in the next couple months. I wanted to acknowledge a few of the people that we worked together on this project. I tried to have a team of African voices so that we got the perspective from multiple different countries. So I had a few medical physicists and physicians that worked on this project with me. Here's a few references, and with that, I thank you guys for your attention.
Thank you, Prof. Thank you, Prof. So, Professor Mark Roche is not there. Brad Zhao is not there. So the next session, which will run for exactly 20 minutes, will be a panel discussion, and this one will be chaired by Professor Tajuddin. Oh, sorry, there's one which was to come earlier by Dr. Abed, Immunotherapy in Local Advanced Lung Cancer, the Pacific Trial. Kindly.
Good afternoon. Good afternoon. I know it's very difficult after having the heavy meals to come and speak here, I will try my best to make it very interactive session. As introduced, my name is Dr. Beratman. I'm the head of oncology at the Kenyatta University Referral Hospital. Today I'm going to talk a topic close to my lungs, which is about lung cancer and how it interacts with the radiotherapy. Our topic of discussion is immunoradiotherapy in unresectable non-small cell lung cancer. So this is a disclaimer. It's a sponsored session, but free from any advertisement. And these are my disclosures. So let us start by looking at the data. Looking at the table above, we can see that in the latest GlobalCan 2024, this was published last week. The leading cancer in the world right now, it is no longer breast cancer. So breast cancer has been overtaken by lung cancer to become the most common cancer in the world. Despite being the leading cancer, it is also the leading cause of cancer death in the world. So we can see now it is not only the most common cancer, but also leading in terms of cancer death. That's why we said we need to do something about it. Breast cancer has now moved to number 2, followed by colorectal, prostate, and stomach. If you pay your attention, you can see a quarter of the cancers being diagnosed here, they are coming from the women. So women cancer are leading. Okay. So looking at this data over here, we saw that in the world, lung cancer is number 1. However, look at the last 4 columns in this table over here. You can see the countries in Africa, Eastern Africa, Middle Africa, and Western Africa. The numbers are extremely low compared to what we see in Eastern Asia and the Eastern Europe. Who could tell us what could be the reason why we are having low incidence of lung cancer in our countries like Kenya? Like previously in the GlobalCan 2022, lung cancer was number 11. In the GlobalCan 2024, lung cancer in Kenya, it has now moved from number 11 to number 7. So why is it moving and why is it still down? Anybody? Anybody? Yes, so the answer is misdiagnosis. We can see here a lot of lung cancer patients that are being treated in our clinics as tuberculosis. We are giving these questions like all form of medications. They are not improving. Instead of thinking outside the box, we are still inside the box, thinking like all this is because of TB. So usually with tuberculosis, you are supposed to see response within 3 days, maximum of 1 week. Your patient is going to improve. Any patient who is not improving after taking the TB treatment after 1 week, this is another diagnosis unless proven otherwise. It can also become co-diagnosed with lung cancer. Let us look at the lung cancer details over here. So we know that lung cancer can be classified into non-small cell lung cancer and small cell lung cancer. And most of the patients that are diagnosed, up to 40%, which are locally advanced stage 3, with up to 50% of them being stage 4. Looking at the table on your right, the 5-year survival of stage 3 moving all the way to stage 4B, we can see it is dimming down, moving, becoming lesser and lesser, and we can see it even here. The earlier you're diagnosed with lung cancer, the better chance of you surviving compared to stage 4 moving down and over there. Right now in the UK study, where they were doing the screening study, they found that screening diagnosis, it has been helping the UK government to have early diagnosis, and now the 5-year survival is really improving. You can see from this table over here, this is data coming from China. The 5-year survival for stage 1, 2 lung cancer, it is moving beyond 6 years. And now, because of the immunotherapy and the target therapy, the survival is even much better. Let us have a look at the definition of what is resectable and unresectable. On your right-hand side, any patient presenting with N2 nodal station, N2 which is bulky, N3 is bulky. These patients are all classified as unresectable. It means they cannot undergo surgery. Looking on the left side of your table, we have the patients who are coming with T4 invasion, with N1 disease, T4 with N2 disease, T3 with N2, and T1 with N2. These are considered unresectable. That means a big chunk of the lung cancer patient, they are not going to be resectable. Having a closer look at it in terms of anatomic, what does it mean, the T4? The T4, it means the disease has gone all the way into the pleura, or it has affected the big vessels over here. Then looking at the nodal station, we can see the nodal station over here, the N2, making it very difficult to operate because they have gone all the way to the airways, the trachea. It means this patient cannot undergo surgery. This is historical, like how we have moved, like in terms of survivorship, the evolution of the unresectable stage 3 lung cancer. Initially, we used to treat stage 3 lung cancer. Either we compared it with radiotherapy and sequential chemoradiotherapy, we found that it is much better treating our patient with a sequential chemoradiotherapy. Then we had this meta-analysis which proved the concurrent is slightly better, but not very big difference in terms of giving radiotherapy. Then we came the new study, which is Oncology 9410, which sets the standard, the sequential compared to concurrent. We saw that giving sequential to concurrent is superior than the sequential, and now concurrent radiotherapy with chemo and radiotherapy, it has become the standard of care because we can see there's much improvement in terms of survival. Let us have a look at the background of the Pacific trial. As I already mentioned, 1/3 of non-small cell lung cancer will be diagnosed stage 3, which is locally advanced disease at the time of diagnosis. The standard of care, it becomes very difficult because these patients, they're having either very poor, they might have very poor performance status or unresectable in most of them. We know that stage 3 non-small cell lung cancer is the standard of care is the duplet platinum chemotherapy combined with radiotherapy. We know that with this type of treatment, concurrent chemoradiotherapy, the 5 years, the progression-free survival is just barely less than 1 year, which is 10 months. And the survival of 5 years is just 15%. It means there's something lacking. It means most of our patients, they are going to die without much improvement. So after treatment, patients were on active surveillance with risk of disease recurrence. Previous attempts to show that increased toxicity with no improvement in survival or risk of progression. So we are going to present you the Pacific data to show that we can do better and our lung cancer patient can live much longer beyond the historical cutoff point. For you to understand why we need to discuss the importance of concurrent chemoradiotherapy, let us look at these studies which were done before. In the CALGB study 3980, which was published in 2007, they compared the use of carboplatin paclitaxel over the carboplatin, in a different dose with chemoradiotherapy. They found that there was no difference in terms of overall survival. Progression-free survival was the same, just 7 months versus 8 months, while the overall survival, the difference was just barely 14 months. We can see here the role of induction therapy did not give much survival. So induction therapy is not the standard of care unless you're having long waiting time with your machine, you can consider that, but it's not the standard of care. Looking at in 2008, the USO study, again over here, they're looking at the role of consolidation docetaxel. It increased toxicity without much improvement in overall survival. In fact, giving in the consolidation docetaxel, it had worse survival, which was 21 compared to observation 23 months. That means doing consolidation does not help our patient. We're just adding toxicity and treating ourselves. Looking at the 2023 SOC trial, over here they were looking at the role of adding gefitinib as a consolidation therapy over placebo in unselected patient. We can see again there's not much difference because that we saw that in the gefitinib they had inferior survival compared to placebo, which was at 5 months. Kindly note, gefitinib in the selected patient has better improvement in survival compared to here where the study population, it was unselected. So in the next study over here, we saw that the previous study had failed to modify or improve the standard of care, concurrent chemoradiotherapy in patients with unresectable stage 3 lung cancer. So we have this study over here, the KCG, the LTOG, and CALGB. None of them failed to improve overall survival. If you look in the column of overall survival, we can see it is still 21.8 versus 20.6. The same when it comes to LTOG, 28.7 with chemoradiotherapy at high dose of 60 gray over 74 gray. With this study of LTOG, it's established the standard dose of radiotherapy being 60 gray over here over 74 gray. So increasing the dose of radiotherapy, you are not helping your patient, but you are causing more toxicity. We can see much difference in terms of survival, 28 months over 23 months. And if you even add cetuximab, an EGFR inhibitor, the survival is not much difference, just 25 months. In the CALGB study, the same, we saw that in the stage 3A unresectable, the adding of erlotinib did not make any improvements. So what is the rationale of adding durvalumab? We know that durvalumab is a PD-L1 inhibitor. We all have our immunity, which is protecting us from getting cancer. All of us, we have active cancer cells, which are circulating in our body. However, our immunity is able to deal away with it. So here we are seeing that the role of the concept, they were giving immunotherapy alone. Then the combined immunotherapy, the blue one, curve on your right-hand side, you can see the curve is very high compared to the two curves in orange and green color. It means combining immunotherapy and radiotherapy, you are going to improve much survival. You can even see in terms of response on your left, the bar charts, the blue one, it has gone much higher response compared to the left one. So this was the baseline, the concept, the proof of concept, combination of immunotherapy and radiotherapy is going to improve survival. Over here, it is just an understanding how immunotherapy works. We have one side, the immunity. At the center, we have your T cell and your tumor cell. So the drug is coming to block the PD-L1 cell in the tumor cells, causing the blockade, therefore activation of your immunity able to fight the cancer cells. So this is how durvalumab and immunotherapy, immunocheckpoint inhibitors function. Let us look at the trial design. This was a phase 3 trial, which was the patients who were unresectable stage 3 non-small cell lung cancer without progression after definitive chemoradiotherapy. Remember, we started by mentioning the standard of care is concurrent chemoradiotherapy and not sequential. So this patient must have been 18 years old and older with a performance status of 0 or 1, available or archived cases of PD-L1 testing available. This patient must be randomized within 42 days. And this is the most important part of this study. Your patients must move from radiotherapy to continue with immunotherapy within 42 days. The study protocol was amended when they saw there was a futile cases, the patients who were randomized after the 42 days. So we have to be careful. We have to monitor our toxicities to ensure that our patients are getting immunotherapy within the 42 days. The patients were randomized into two groups. Group A, the one in blue, durvalumab, and group T was placebo in the ratio of 2:1. Our primary endpoint was progression-free survival. If you remember historically, the progression-free survival had been just 8 months, a maximum of 10 months. Our key, and also we are putting here overall survival as a key point. I think the company who was investigating this medication, they were very brave because we know that many companies, they ran away from overall survival data because it takes very long and sometimes they cannot even prove that overall survival, the patients are benefiting from this kind of treatment. Our key primary, secondary point, they were overall response rate. They turned to progression to the second treatment, progression for PFS2 and safety. Looking at this table, the patients were well balanced. You can say most of them, they were not very old, 64. We know that by definition, an elderly patient is somebody who was more than 64. But we can see we had a quite number of patients who were up to 90 years old. They were having more male patients compared to female patients. So generally, lung cancer is a disease of the male, so reflection here. Majority of the patients, they were white. They were underrepresentation of the African, just 2.5%. The Asians were presented a quarter of it. And majority of the patients were stage 3A and stage 3B. Most of them, they had performance status either 1 or 0. So like a few of them was not reported. It is very important when you are treating your patient to know this patient, they are having driver mutation or not. EGFR is a driver mutation. Remember when we were looking at the background, we saw that cetuximab and gefitinib and erlotinib did not give any benefit to this patient. So this patient, they were also included. However, their number was not very high. It was just 6% of the patient. They were trying to look in the patients who are EGFR positive, are they really going to benefit from immunotherapy or not? And most of our patients, they had PD-L1 expression, which was more than 1%, forming a bigger chunk. However, we can see that a bigger proportion of the patients, like more than 1/3, we didn't know whether they were PD-L1 positive. So characteristic, most of the patients, they were squamous type. We also have half of them, like adenocarcinoma. And most of them, they were former smokers. We can see that 74.5%. Because we know that the PD-L1 expression is very high in patients who are smokers compared to non-smokers. So history taking is very important when you're deciding the treatment of your patient. And we can see that we use different regimens of radiotherapy. However, up to 90% of them, they use the standard dose of 60 gray. We can see there the range of between 54 and 66. Very few patients, they went to receive higher dose of radiotherapy, which was just 74 gray. So most of the patients, they received like a concurrent. We had less than, with a small group of patients receiving induction chemotherapy. With this, we can see that 2% of the patients, they had complete response. Partial response was the majority, and a stable disease like a 46%, and fewer patients were able to progress. This is just to understand how the patients were treated. The patient received concurrent chemotherapy. Most of them, they received 2 cycles of platinum-based chemotherapy. Then with the radiotherapy, 60 gray. Then over here, we can see how the treatment was given before the disease progression. So durvalumab was used to be given every 3 weeks to ensure that the patient, they are benefiting the most from treatment. And the treatment was up to 2 years. So over here, we can see the results. Remember, historically, we said that the progression-free survival, the median progression-free survival was just few months. We said 8 to 10 months. Over here, adding in durvalumab, it even doubled almost to 17%, compared to placebo was just 5%. This is more than triple times. So you can see here, comparing giving immunotherapy to just adding durvalumab, we are going to improve progression-free survival 3 times. Over here, we can see the overall survival data. This is for the first study to show that adding immunotherapy, your patient can live more than 5 years. We can see here up to 42% of your patients, they are alive after 5 years. Remember, in the previous study, we said less than 1 year of your patient, they are going to be alive. In the placebo, it was very, just at 3%. This is translated into improvement by 28% with a hazard ratio of 0.72, and was statistically significant. Looking at this forest plot over here, we can see it doesn't matter whether you are young, old, smoking, disease stage, and everything, whether you receive chemotherapy or not. Everyone was able to benefit from immunotherapy. And because of this study, this became our standard of care. You can see here in the NCCN guidelines, they're giving durvalumab as induction, as a consolidative treatment, is the standard of care after concurrent chemoradiotherapy. Looking here at the PD-L1 status, remember most of the patients, they had lower PD-L1 expression. So it doesn't matter whether PD-L1 expression is very high or low. So testing, I can say, it is not necessary when you are giving your induction immunotherapy, because the benefit is the same across PD-L1 expression. And these are ESMO guidelines over here. We can see that adding durvalumab, it is now the standard of care even in Europe. So because we have seen that it is proving survival, reaching 5 years by 42%. And here, these are the adverse events. Like any other medication, immunotherapy, we know that we can cause side effects. The most common cause of side effect were cough, pneumonia, fatigue, and dyspnea. Of course, we also had pyrexia and hypothyroidism, like any form of immunotherapy. But kindly note, the amount of hypothyroidism here in this study is just 11% compared to previous studies with the immunotherapy here. And this is the updated safety. We can see all adverse events, like almost all patients, they were affected. However, we had grade 3, 30 to 30%, and 4% of our patients, they were able to die because of treatment-related, and 15% of them, they were able to discontinue. And here, looking at the reason of death because of, what was the reason of death? Because of the side effect of pneumonitis. It means all our patients giving radiotherapy and immunotherapy, we must monitor pneumonia very careful, because the pneumonitis here is presenting very different from the classic pneumonia. So this is just to conclude. We have shown that immunotherapy durvalumab has demonstrated statistically significant overall survival, with improvement of survival by 28%. After 5 years, up to 42% of our patients are still alive. Approximately 1/3 of the patients remain disease-free without any form of treatment. Then durvalumab was well tolerated with no new safety signals. Pacific study is the fastest study to demonstrate survival advantage of unresectable lung cancer, stage 3 small lung cancer. I think with this, I have been able to convince you using immunotherapy in combination with radiotherapy is our standard of care. Thank you, and these are my references.
I think Daktari deserves a better clap. Dr. Abeid, are you satisfied with the clap? Or you want them to clap again? Okay, clap again. Okay, thank you for that nice presentation. We'd like to call our next speaker. That is Mr. Brad Zhao with Affordable Innovation for Radiation Oncology. Yeah, you're welcome.
Okay, hello everyone. I'm very glad to give a presentation here. My name is Brad Zhao. I'm from China. I'm presenting our company, Shinwa Medical here. So today my topic is affordable innovation for radiation oncology. So firstly, before my presentation, I want to show you some data about the current situation of cancer across Africa. So firstly, the cancer burden, the projected increase in annual deaths compared to 2020 and 2030. There is a 85% surge. And number two is the clinical radiotherapy demand compared to the actual supply. So currently, if you, according to the WHO standard, the standard clinical radiotherapy demand at least there should be 55%. But the fact of the actual patient coverage in Africa may be only 5.5%. So I think access to the radiotherapy, at least the basic radiotherapy, remain one of Africa's biggest healthcare challenge here. So next one, I want to introduce you guys about our company, Shinwa. Who is Shinwa? So Shinwa is a company from China, firstly. We were founded in 1943 during the Second World War. We are starting from the surgical instruments, supplying to the military hospital. So actually at that moment, we're still not a company. After the new China government founded in 1949, we become a government company. So nowadays, Shinwa already be one of the leading medical manufacturer in China. So we have 6 R&D and manufacturing bases. So we got Park A, which is our headquarters. We got Park C, which is the manufacturer for the radiotherapy equipment, for the operating room equipment, for IVD diagnosis consumables. We also got Park E, which is the largest manufacturer base for the infection control equipment, for the hemodialysis, and also the animal laboratory equipment. We also got different branch company in Shenyang, in Chengdu, and in different cities. We got more than 8,000 employees, 1,800 R&D engineers, and over 600 service engineers. We also do a very good job in the domestic market in China. We have more than 11 regional marketing centers in China, over 2,500 salespeople. For international markets, we have over 150 plus countries and regions, and over 5 overseas marketing centers. So luckily, in 2025, we got 1.43 billion US dollars operating revenue. So for radiotherapy, this is the timeline about Shinwa radiotherapy development. Actually, we started very long time ago. We're from 1969, the first Quebec 60 manufactured in China. And from 1998, we got the first Linac made in China. In 2008, we got the multi-energy XHA 1400 with LMLC in China. In 2013, we got the first digital LINAC in China. In 2018, we got the first big ball CT simulator in China. And 2019, we got the first high energy XHA 2200 in China. In 2020, we got the IGRT, WIMART, SBRT, SRS, the new updated XHA 1400 radiotherapy equipment. In 2025, we just released our ORI ART LINAC in China. So we are the top 3 in the world for the linear accelerator brands, with over 500 user installation in China market. For the overseas market, till now, we have already 50 plus installation in different countries, like in Indonesia, in Thailand, Russia, Egypt, Korea, India, Congo, Tanzania, and other countries. So this is a layout map for our overseas installations. The second part, why does Shenhua conduct radiotherapy? So 28 years ago, why I say 28 years ago? Because the first LINAC from Shenhua and made in China is released 28 years ago. At that moment, most of the hospitals in China facing a problem. It's similar to nowadays, which we are facing in Africa. There are a lot of them suffering from the expensive machine, expensive after-sale support, and the technical monopoly. 28 years ago, China had only 0.07 to 0.08 LINACs per million people. It's far below the WHO standards, you guys know. It's at least 2 or 3 machines per million people. So it's very similar situation with Africa. Shenhua, as a state-owned enterprise, we undertake national projects. We want to do the same with European and America. Shenhua must raise the challenge and develop its own LINAC. This is the original reason for Shenhua as a government company to start the linear accelerator. So I hope Shenhua's and China's experience may provide valuable insights for other developing healthcare systems or countries. So the third part, I want to gladly introduce our integrated Shenhua radiotherapy ecosystem. Currently, our mainly doing is single energy SHA 600E, dual energy SHA 1400. Both two machines, we can do up to WIMART technology. And we also got the new released ORI LINAC, which is also 6 MV with the SRS, SBRT. We also got the big ball CT simulator and also the brachytherapy system with the Iridium 1 and 2. So with the equipment, the important thing is the training side. We do the installation training, absolutely, and we also supply the targeted training for the specialist. And also we do the clinical application training at the customer sites. So part 4, why it is suitable for developing countries. The first keyword, stable. I give you 2 examples about our users. First user, we started from China. Hospital name is the first affiliated hospital of Hunan University of Chinese medicine. This hospital treats over 70 patients per day. 90% of patients receive the VMAT treatment. So, and the annual operation rate is over 98%. The second hospital is from Indonesia. So they treat over 60 patients per day. Over 80% of the patients receive VMAT treatment. And the annual operation rate is 99%. The second keyword is easy to use. So it's a fully digital accelerator, adopts a real-time control technology with our new release oncology information system. And present, the digital control system is based on Windows multitask operation platform, can control the multi-modules at the same time. And there is also a standard expansion interface, convenient for hospital to add other standard radiotherapy auxiliary modules. The third keyword, lower cost. Why? Because all the parts we are using 100% made in China. Firstly, like the most important parts, accelerating tube. It's made by Shenhua, by ourselves. And we also got the made by ourselves the MLC. Yeah, and also the oncology information system developed by ourselves to make it a lower cost. Long-term service. So currently, we got 5 different service centers in Africa for multiple different Shenhua product lines. In Morocco, in Egypt, in Nigeria, Ethiopia, Kenya, and South Africa. We also got our training and service team working in our area. There are 5 of them, 1 from Ethiopia, 1 from India, 1 from South America, and 2 our colleagues from China. The next keyword, long-term service. This is an example in Tanzania. This is our customer, which we installed in 2016. They use over 10 years. They're receiving over 50 patients per day. And it's still working smoothly at site. This is also the first LINAC in Tanzania. Thank you, my pleasure. Thank you for your valuable time. Welcome to visit our booth if you got time. Thank you.
Okay, thank you for that impressive presentation. Let's give him another clap, please. So with the interest of time, I'd like to invite the panelists if you're in the panel, please, you can proceed to the podium and take your seat. Meanwhile, the rest of us can please stand up. Please stand up. Just stand up, please. Okay, turn to your neighbor and give them a name of an animal that starts with letter S. How many said snake? Okay. How many said snake? Snail. Okay, so any other snake, snail? Sungura? Sheep? Okay, thank you. We can sit down. From the
Okay.
Good afternoon, all. You're all welcome to this session, which I will be moderating or chairing. My name is Tajuddin Olasinde, a radiation oncologist and the immediate past AFROC president. Apart from the panelists, we have just 20 minutes, so that's just like about 5 minutes for each panelist. But this is a session I will want even participants to be involved. Maybe we might just take 1 minute each, or if we have maximum of 3 questions from the participants to equally participate. Please, can you just start by introducing yourself?
Hi, everyone. My name is Dr. Abed Athman, the head of oncology at KU Teaching Referral Hospital and the scientific chair for this program.
Good afternoon, everyone. Miriam Mutebi, breast cancer surgeon and health systems researcher based at the Aga Khan in Nairobi, Kenya.
Hello, everyone. My name is Joe Wiegand. I'm the director of global radiation oncology at Dartmouth in the United States, and also work at RadAid International.
Hello, everyone, and good afternoon. My name is Joan Paula Bor Malenya, or JP. I serve as head of the National Cancer Control Program in the Ministry of Health here in Kenya.
Good afternoon, everybody. My name is Dinesh Madhavan. I work as a consultant for multiple groups across the globe. At this meet, I represent Apollo as a principal consultant.
Thank you. Let me start with Dr. Bo, because I can see that you are like the desk officer for the National Cancer Control Program. So what is your government? Actually, we are discussing about radiotherapy technology priorities in Africa. Don't forget our theme is innovation and precision in radiotherapy. So, Dr. Bo, what is your government doing to expand access to radiotherapy care in Kenya?
Thank you, Chair, and thank you to the organizers of this conference. As my fellow panelists will bring in the clinical and the technical perspectives, I bring in the Ministry of Health perspective. How are we building a health system to make radiotherapy more accessible, more equitable, and more sustainable? I will begin by saying that our approach as Kenya is grounded in our National Cancer Control Plan, or National Cancer Control Strategy 2023 to 2027, as was mentioned by our Cabinet Secretary this morning. And this key roadmap identifies expanding access to quality cancer treatment, including radiotherapy, as a national priority. So one of the key initiatives under this plan is that we developed a bankable radiotherapy expansion and consolidation plan in 2023, led by the Ministry of Health and supported by IAEA. And this was a multi-sectoral effort. We also had members from the National Treasury, from the regulators of radiotherapy in Kenya, that would be Kendra, and even the Ministry of Thankfully, there are many microphones here. So this, we recognize that radiotherapy expansion is not simply a health sector challenge, but it is a development investment nationally. And what makes this plan unique is that we did not begin by asking how many machines do we need or what kind of technologies do we need, but we began by asking what prevents patients from accessing timely care and quality care in radiotherapy. And the answer extended beyond equipment. We found that there are barriers in terms of technical barriers, financial barriers, and this led us to develop this comprehensive investment framework, which covers infrastructure, it covers human resource and financing and long-term sustainability. So to be more specific, I want to highlight 5 interventions that are key if time allows. And the first one is infrastructure. And here, this plan that I have mentioned is, outlines that we will develop 5 new radiotherapy centers in the period of our strategic plan. And we will also consolidate radiotherapy in the other 6 centers so that we can be able to reach over 9,000 patients every year. And so this is about bringing services closer to the people and also addressing, inequities in terms of geographical barriers. Then the second thing that we are looking at is sustainable financing. So this document is like also an investment case, and it estimates that we will need about 5.8 billion Kenya shillings to do these investments over the 5 years, as well as running investments annually of 1 billion Kenya shillings for recurring costs. And then also we are strengthening our social health authority. You've heard about our oncology treatment packages as part of our universal health coverage agenda. And radiotherapy is covered there. We're still working to improve that, but that's something else. The third thing I want to highlight is the health workforce, because machines alone, as has been said, do not deliver treatment. So the health workforce requirements are outlined in terms of oncologists, radiation oncologists, medical physicists, the 3 musketeers really, as well as biomedical engineers and other professionals that are needed to safely operate and sustain radiotherapy services. And these are things that the government is investing in. The fourth thing is strengthening early detection and diagnosis, because radiotherapy can only have the greatest impact when cancers are detected early. And I believe you'll agree with me, even as oncologists, as the health workers working in this space, it's very frustrating, I think, when you receive patients in late stages and you give it your best shot and the patients, the outcomes are not good. So strengthening screening, strengthening diagnostic capacity and referral pathways, as well as patient navigation are other things. Lastly, Chair, we are also strengthening governance and partnerships, and this includes standardization of care. The ministry, we are very keen on having treatment guidelines that we have developed and radiotherapy protocols, to be implemented in all our radiotherapy centers. And this will help to improve care so that our patients get the best. partnerships, including with organizations like the IAEA and WHO, as well as with the private sector and other players in this space, are also things that are a priority for us. So ultimately, I would frame it that our goal is not simply to install more machines, but to ensure that there is a sustainable ecosystem that supports the patient at the farthest corner of our country getting care with the least amount of stress. Thank you, Chair.
Thank you very much. Just by coincidence, I will call on another lady because as the chair of African Organization for Research and Training in Cancer, EOTIC, we want to know, looking at it from African perspective, what are actually the barriers to radiotherapy access in sub-Saharan Africa, and how can we address this? Please quickly in 3 minutes.
Thank you, Chair. And just to clarify, I'm the immediate past president for the African Organization for Research and Training in Cancer, which is the largest continental body that's really been trying to look along the entire spectrum for cancer control. And I think rather than spending 3 minutes sort of talking about the barriers, which we probably know intimately ad nauseum, and as a breast surgeon, I incredibly appreciate the role of radiotherapy in terms of what I'm able to do safely for our cancer patients. I'd like to maybe perhaps focus on the opportunities that exist and maybe build on some of the arguments that Dr. JP has made. We know we've talked about barriers around infrastructure, workforce, financing, access. I think we really have an opportunity, especially as Africans. We're at a critical inflection point. And so I think one of the first things that we can look at is how do we build systems, not just, facilities. And so in terms of looking at how can we ensure that we are having the entire ecosystem, all the way from the infrastructure, the maintenance around it, how can we start to look at the workforce, the quality assurance and multidisciplinary care that's needed. So just to sort of anchor that around the fact that technology without strong systems is just really unrealized potential. We do need to invest in systems, in people. Our greatest asset is our people, but it's thinking through what are the practical steps in terms of not just engaging and training, but also retaining that workforce, but also how do we expand that leadership to a regional level. I think it's important that we also think about how do we strengthen collaboration. No one country can do this alone. We know currently, despite, I would say, the increasing momentum, we still have a little over half of the countries in Africa not having access to radiotherapy, which is clearly an opportunity for us to think through then how can we build regional centers, how can we collaborate together to also have best practice. One of the things that we've done through Aortic is really building this, really ensuring that the dialogue, even amongst healthcare professionals, that they actually understand what goes on in radiotherapy and how we can work together to improve those. So I think, just in closing to keep the conversation going, I think even as we're framing our initiatives, the goal is simply not more machines, it's how can we get more patients treated in a safe, timely, affordable manner. Thank you.
Thank you very much. I will move to my immediate right, Dinesh. Now, technologies, we are having new machines coming up. How do we sustain this radiotherapy machine?
The chair of AFROG and the committee members and the chair on the panel, thanks for having me here. My experience has been across the continent and also largely in India, having set up close to about 50 plus cancer centers and close to about 1,000 oncologists. if you want to sustain something, first you need to build capacity. And that has to happen not out of technology and brick and mortar, but human capital. It's actually very gratifying that one of the early radiation oncologists that brought into this country spoke yesterday. There's somebody talking today who might gotten an employment in this country, and there's somebody talking tomorrow who does the largest number of PET-CT reading in this country. But that's an investment, it took a decision. If you invest in the right human capital, maintaining the equipment becomes easy. If you look back, the world started with the cobalt in 1951 in Ontario. It was called infamously the cobalt bomb. And it had a reason for so. So you don't actually need a cobalt today when Canada doesn't have a cobalt. And Canada in Ontario is the one who manufactured a cobalt. But how do you sustain technologies and give treatment when for a 2.5 million living population with cancer across a 5-year prevalence in the African continent does not even have access to it? Good thing is before this, there was a presentation by a Chinese company called Xinhua. And I know there's an Indian company which is going to install a LINAC in this country where the cost is as similar to the cost of cobalt. Almost $1 million for a LINAC with a 3-year CMC. That's about half the cost. You can't get equitable cost of maintaining equipment unless the purchasing power of the equipment itself is low, because your CMC cost is going to be pegged to the cost of the equipment. Once you get the equipment purchased at lower cost, you can figure out various models you can do it. Across the globe, my experience has been PPP, paper usage, capacity utilization, and we also stretch where we're the largest populated country in the world, and I'm sitting here where there's a continent which is about 1.15 billion, where you might have to go beyond ours and actually do treatment where you do an optimization capacity utilization as long as your physics team is in alignment with the radiotherapy team, saying that a QA/QC is pegged at what we expect outcomes to be. From a perspective of what needs to be done maintaining is, I don't think so every center needs to have a LINAC with an SBRT, SGRT, lattice, and talk about SRS when you need to peg it back to the type of cancers in this part of the world and what actually is needed. You just probably would need an equipment with an IMRT. You may not even need an equipment which needs a rapid arc, or it needs a hyperfractionation or an FFF. So ideally first is to figure out what is the need of the hour rather than going overboard. Allocate capital to find out the best technologies available, fix a CMC to that, and do an anti-obsolescence policy probably for 2 decades. In the rest of the world, probably it's about a decade, 10 to 12 years, but do it for 2 decades, and look at it backwinded to a CMC that reduces your cost, saying that if you can't even sell a LINAC with a 3-year CMC, there's something wrong. Because buying equipment for $1 million, if your warranty is not 3 years, then what's the call on the equipment you're actually buying? So at Pecker, it was 3, capital allocation, CMC cost, but before that, human capital. You need to get your physicists trained, you need to get your nuclear medicine, your molecular pathway clinicians trained, your radiation oncologist, and if you have them, you'll find means to actually acquire this and maintain it.
I cannot but agree with you, because we've had it since yesterday. There are even countries in Africa today without radiotherapy equipment. And with the erratic power supply we're having everywhere, cobalt-60 is still relevant in Africa. I can tell you this. So, and again, having maintenance contract, you mentioned that. So, Joseph, you've been speaking since yesterday.
That's
and
correct.
With your experience, you've traveled around a lot of countries in Africa. Is there a requirement for vendors to provide on-site, long-term technical training for our biomedical engineers? Because we seem to be downplaying their role, and they are highly needed to be available and to be well-trained. Thank you. Over to you.
Yeah, that is absolutely true. Thank you for allowing me to speak here as well. Biomedical engineers are absolutely critical to the safe implementation of radiotherapy. I think we all have experience in cancer centers, particularly in sub-Saharan Africa, where a LINAC might go down, and it's down for weeks, for months. I remember when I was initially thinking to start working in global health, one of the things that motivated me to work in that. I read an article in the BBC about the Uganda Cancer Institute. They had a single cobalt machine and it was down for 4 years or 3 years, something like that. And yeah, I mean, really, without an engineer in country, it's very difficult to get back up. I know, at least in the US, our machines go down all the time, really. Once a week, I don't think is an exaggeration. But luckily, most sites, either we have a biomedical engineer on staff if it's a larger hospital, or we have a service contract with the vendor, and they're able to come out within 20, 30 minutes, maximum 1 hour. And obviously, the logistics don't make that possible for here in Africa. So I think we're talking about three musketeers a lot in this conference. I think we do need to add a fourth because without a biomedical engineer on staff, right, a minor misoperation of the LINAC that could be down 30 minutes. If it was in the U.S., it would be down for a week, you know, and that really makes it difficult to treat your patients successfully. If you're treating a head and neck patient and the machine goes down for a week, what do, you know? So I think it's very of utmost importance that we include biomedical engineers in the conversation.
Thank you. Abe, you are one of our shining stars in this field. Is Africa really ready for AI in radiation therapy?
Thank you so much, Chair. Is Dr. Angela here? Okay, so just to bring to your attention, like most centers in Kenya, like Aga Khan, for example, and even I believe in HCG and even Nairobi West, they're now using artificial intelligence to contour. So AI is already here in Africa. So we in Kenya, we're already ahead of that. We are using AI to shorten our time. And I believe like these technologies, they are not cheap because now you have to acquire new license. Acquiring new licenses, this is the biggest challenge, like the main barrier to other centers in Africa able to incorporate artificial intelligence. Otherwise, in terms of workforce capacity, our people are ready, and the availability of AI is already here in Africa. So I think this one is the easiest one for us. It's a very low-lying fruit proof, and we are already implementing it already. Thank you.
Thank you very much. I'm time conscious. We have just 20 minutes. From the floor, do you have anything to ask our panelists? Maybe which I have missed? Nothing to ask them? If not, we still have about 2 or 3 minutes. Dr. Bo, okay, because I want it to be like a round table discussion. Don't let just it be from our end to you. Please feel free, you have them here. Ask questions. Thank you.
Okay, so thank you very much. The discussions have been interesting, but and I like Prof's suggestion about the biomedical engineer. But coming to think of the just people that just finished speaking now, the Chinese company, how they thought about the problem of costly development of equipment, and then how they were able to develop their indigenous technology, and now they're even trying to export it to other people. Don't you think it's about time to put some mechanism in place, let's say as Africa, not necessarily one country or the other, but can't we come together as Africa, as we're coming Afro now, and even if it's like a 10-year plan of developing our first teletherapy machine, is it a dream that is too big to start now, or very impracticable to achieve? I'm just thinking maybe we should. How practical is it for us to start thinking about this? Thank you very much.
Dinesh and Joseph, can you just respond to this in 1 minute?
So from what I heard from you is you were referring to Shinwa and you were talking about on-site. Our experience back in India is that we, at one of the locations, have a Shinwa equipment. Irrespective of the provider, you can keep it agnostic. If you, as organizations, come together and put up a regulation, where I've seen in multiple countries, one of the prerequisites for a company which manufactures Linacs and sells it directly through a distributor is to put a prerequisite to have a site engineer. It doesn't matter whether you have a single radiation unit or multiple of them. It could be a prerequisite, and there are multiple examples I can give. You can catch up with me on one-on-one in which countries this has been done. So you represent it as a voice of Africa or Kenya. Let's say you talk about Kenya, and the Kenyan Association can come together and say, if you have 48,000 patients and we got, let's say, 20 Linacs, we'd like to see so many on-site engineers. And if it's a Varian, if it's Accuray, or it's Electa, or it's Shinwa, it has to come as a prerequisite, and it's easily doable. If you have an intent to do it, and if as a group you come together, you can make it a prerequisite.
Yeah, I also agree. I think that's an excellent idea. I think the cumulative might of AFROG here, I think, is the perfect organization to perhaps put that idea into action. I think there are many people across the continent that are capable of doing that. We just need the infrastructure in place and maybe the training centers, and yeah, definitely.
Any contribution from this side? Thank you.
Maybe just a quick addition to the idea that we're discussing about a Pan-African lens. I was like, I cannot probably not mention at least the ongoing efforts. We would just come from Abuja last week, where we were running Best of ASCO Africa, but really with the emphasis about access to innovations and technologies. And one of the things that we do need to think about is really from an advocacy perspective. The thing is, we already have the commitment from our governments. In 2012, all members of the African Union made a commitment of 1% of their GDP towards research and development. Now, the question is, how do we as AFROG, in collaboration with AORTIC and other bodies, really start to engage civil societies and the broader oncology community to really push for how can we, get these technologies faster? Why is it taking us 10 years for some of these things to catch up? So there's a real opportunity for us to think through after this around what are some of the key concrete steps that we can do. We do have a couple of suggestions, but it would be good to kind of hear from the broader community about how we can continue to expand that. So the commitment is there. It's really about us really pushing for and demanding that, the pledges are actually upheld. Thank you.
Thank you. Over to you. Yes.
Good afternoon. My name is Faith Ndungu, a biomedical scientist and technologist. My question is to the representative from the Ministry of Health. Is there an oncology navigation program and a Ministry of Health in pipeline to address the systemic gaps in cancer care ecosystem?
Thank you. I missed some of your words. Could you please speak up a bit?
Is there an oncology navigation program? You mentioned something about oncology navigation. Is there an oncology navigation program and the Ministry of Health in pipeline to address the systemic gaps in cancer care ecosystem?
Thank you. Thank you, Faith. That's a very thoughtful question, because without that, patients might not actually get to the radiotherapy services they need fast enough. And maybe to be direct with your question, this has been a gap for some time, although we have had, you mean patient navigation. So we have had programs at Kenyatta National Hospital, and there's some work ongoing currently to expand this to the other cancer centers, including the regional centers. So there is work ongoing there, but we have identified that there is a gap in the community navigation and in the navigation from, the point of screening and diagnosis to linkage to care. And one thing is that this is quite unique because for cancer patients, the time is really of the essence. Time is really of the essence. And it's important for them to get a speedy, movement from the point when they are suspected to be having cancer, even to getting diagnosed. We know that patients get lost in the system. We know that it can even take, even up to 6 months for a patient from their first point of contact with a health facility to the time they get to a cancer center. So this is a gap that we have identified, and we are prioritizing developing a structured patient navigation guideline so that we have a way that patient navigation is being done, not just in the referral hospitals, but also from the lower levels of care all the way to the cancer centers. Secondly, we have the community health promoters, and we will involve them in that process. When we train community health promoters, one of the things we train them is in supporting patients through the patient journey. So that is another thing that we are doing. But we have identified that this is something very important, and let's work together and see how we can make progress in this area. Thank you.
Thank you. Can we have the very last question to the panelists? Everything is okay? Okay. Maybe we have just 2 minutes, 30 seconds each. The last for them to tackle, starting from Abed. 30 seconds.
Okay, thank you so much, Prof. I think for us in Africa, as Dr. Dinesh has alluded, is building local capacity. We need to maximize on whatever we are having over here to ensure that patients are getting the best care. Once we have the capacity, then everything will be very easy for us to ensure our patients are getting these innovations. Because even if you have innovations, but the local capacity is not there, it's just useless. Thank you.
I think my final reflection is that patients do not experience innovations or technologies, they experience systems. So really at the end of the day, our goal is around how can we ensure that each patient, irrespective of where they are in Africa, have access to safe, timely, affordable services. Thank you.
Yeah, one thing I want to point out is that being someone from the global north, people always ask me back in my country, how can I get involved in Africa? I want to help. We just don't have the infrastructure in place to put the people that want to help to the people that need the help. And I think the global radiation oncology community could really invest in kind of an infrastructure that really puts people that want to be involved into the people that need to, that would like to collaborate with people in America and Western countries.
I think for me, I want to reflect on the theme of the conference, which is equity, innovation, or the theme of this session, which is equity, innovation, and supportive care. And what I want to say is that innovation is not just about newer technologies, but it is about finding innovative ways for financing, for planning, and also for integrating these technologies into the health system so that they can actually benefit the patient. Thank you.
I'll conclude on my notes, taking a cue from my fellow panelists, because it spoke about finance and planning. And having established over 50 plus cancer centers, I understand the need of the hour in sub-Saharan Africa, or largely in the African continent, is the cost of capital for setting up a cancer center. And I'd use this platform to tell if anybody is wanting to buy a radiation equipment and is looking for means of financing, whether it's G2G or a line of credit, I'd be more than happy to engage with them, because there are 3 countries which are stepping forward to supporting this in the region. And they're large funds. And one of the biggest challenges I've realized is it's like the best kept secret. Very few people know, including radiation oncologists, that they can reach out to access to capital. Over a long period of time, very few centers, very few countries provide capital 15 to 20 years with a 3-year moratorium, which is the incubation period. So one is that. The second thing is, to me, capital can always come in, but if you don't build capacity of human capital, which is needed, there comes the biggest challenge. And one of the things from Apollo I could say is, we're more than happy to commit to train people. I see a couple of people in the audience whom I've trained in the past, and what it gets back to me is, they're today serving for those who are needy. So we are willing to support that. Thank you.
Thank you very much. Because of time constraints, we will stop here, but thank you very much, Dr. Abed, Dr. Miriam Mutebi, Joseph, Dr. Bo, Dinesh. Thank you for your contributions. And to the Participants, thank you for your rapt attention. And please, can you give them a round of applause as you can go back to your seat. Okay, can we have a photograph?
Okay, so thank you everyone for being here. We don't take your attendance for granted. As they come off the podium, I'd like to arrange you. Nataka kuwapanga. Okay, I want to arrange you literally. So we're moving into the next session. This one is breakout rooms. However, I'm going to give a few more instructions. I respect your Friday. So we're going into our breakup rooms for 1 hour. That is from 16:30 already. 16:45 to 17:45. Then after that, for 30 minutes, I'll wish to have the AFROG members, the executive. They will meet in these 2 tables. Then I'll give you 30 minutes to mingle and see our partners. Then after that, I respect it's your Friday. So we are going to make it up to you. So we're going to have our drinks out there. I know we are thirsty. Even water is a drink. So please don't rush home. We have to celebrate the Cross K launch today. Okay? So please don't rush anywhere. Just stretch, say hi, get some goodies out here, and then we'll meet then. So this half of the room is going to be divided. The first half is going to be Victoria 1. Okay? The first half of the room is going to be Victoria 1. The second half of the room is going to be Victoria 2. The second half will be Victoria 2. And then the third room is just outside here next to the registration desk. Okay? That will be... Oh, it's called Victoria 3. Victoria is lucky, eh? Okay, Victoria 3 will be here, sawa? So please, if you're in Victoria 1, just move forward. If you're in Victoria 2, move back. And if you're in Victoria 3, please come out and to the left, you'll find Victoria 3 there. Because of interest of time, kindly let's just be swift a bit. Yeah. We are going to relax in an hour's time. So please, AFROG executive members, please don't go. Immediately they are done, it will be a very short meeting, and then we can't wait to have you outside. Thank you. Kindly let's be swift, a bit more swift. Victoria 1 at the front, Victoria 2 at the back. Then the presenters, be ready with your presentation. It's going to be swift. All the chairs of the sessions, please be up and take charge of your stations. This is at the front. I'm repeating again. At the front here is Victoria 1. At the back will be Victoria 2. And Victoria 3 will be outside here. Okay? I'll ring a bell after 1 hour. Please, session chairs.
Said, you ready? Ladies and gentlemen, welcome to this breakout session. I'm Dr. Nurdin Somo, consultant clinical and radiation oncologist based here in Nairobi. We only have 1 hour. So, Dr.
20 gray dose in a single session, and the node was of 1.5 centimeter diameter, and patients were not able to have relief by giving 40 mg morphine every 4 hourly. So this is how we have made, you can see in this, we have made these nodes, and nearby areas they are having low dose areas. So high dose areas and low dose areas. So what we have done, we have planned VMAT based treatment. Dose is 20 gray, that was given in single fraction. And we have made 1.5 centimeter dia areas. And we have mixed this treatment with conventional treatment. And we have started this treatment in January only. So what we have seen, it was, the patient who came to us was what we can do by this treatment. Patient was morphine free. Till date, patient is morphine free. Patient is a doctor having osteosarcoma, has received every type of treatment. But by this radiotherapy, he is morphine free. Another patient, she was also having giant cell tumor, the lady, and she now can actually walk with the help of something, but she can walk. So tumor bulk till now has been reduced up to 50%, and they have regained functional mobility. And I have also taken one patient of head and neck cancer going under treatment. So why now? Why we are talking about this therapy now? So if you have listened all the physicists that have talked, so every treatment, either you talk about SBRT, osteotactic radiosurgery, or this treatment, there is, dosimetry is very important. So it is important to have a good physicist to measure what is going on, how we are giving this 20 gray dose in a single sitting with these nodes. So small field dosimetry had to mature when we are giving this type of treatment. So earlier we were not able to do that, and it was also important to have VMAT or IMRT, high resolution MLCs are required. Every center says, yes, we have radiotherapy center. But you should have a high resolution MLCs. So it is important to have IGRT also, CBCT of a proper, you should imagine properly. So if you are doing this lattice radiotherapy and matching is not proper, you are giving dose to intestine. It will create problem to patient and us also. So image guided radiotherapy is very important to understand the dose of 20 gray, where it is going. So it's I am not saying it is a new therapy. It's a therapy that we should understand. We are talking about new techniques in radiotherapy, and in this era of immunotherapy, the bi-radiation therapy, we can give. We can actually generate immunogenic cell death. So we ourselves can, by radiotherapy, can do immunotherapy, and that will actually give benefit to our patients. To conclude with, this lattice osteotactic, especially fractionated radiotherapy, this offers a practically, biologically rational option for symptom relief in bulky, unresectable pelvic bone tumors, as well as other sites also. So it is, by this treatment, we have meaningful pain relief, but you have to understand when we are doing this treatment, as I was hearing other people. So when we are planning IMRT and IGRT, it takes around 4-5 hours to plan. But for this treatment, it took 3 days to plan. And when we were delivering, it took half an hour to understand how this dose is going. So it takes a lot of time to deliver this treatment. We could get meaningful pain relief and improve mobility in both cases. And toxicity were, the normal toxicity as we can have in any type of treatment, hypofractionated treatment that we were having, not extraordinary toxicity we could have. So these are the references. Thank you so much for giving me this opportunity. Thank you, sir.
Thank you for the excellent presentation, Dr. Rashi Agrawal. Our next speaker is Saeed El Hafari from Vision RT. The topic will be the new standard of treatment with SGRT. So, when you're ready.
Thank you so much. Good afternoon, all. It's a pleasure to be here in Kenya for the first time for me. I hope it will not be the last time. It's my pleasure to have this presentation. I thank you, the committee of AFROG, and I introduce myself. So my name is Saeed Hafari. I'm a medical physicist and clinical application specialist with Vision RT. So just introduction to Vision RT, what is it? It's a company from UK. We are operating now for 25 years. Our anniversary was this year. So we are leading the market of SGRT with now more than 3,500 installation around the world. So we are the inventor also for many different systems on the SGRT, and we are also having a lot of data coming from our users. We can account for more than 300 peer-reviewed papers about every type of treatment done by SGRT. So a lot of questions were asked this sessions before me, and I hope I give some answers to those questions. So as you know all, when we set up the patient, we go out of the banker, and then we don't have any idea if the patient moves or not. So all the patients, I assure you, they move. So with the SGRT, we can monitor those patients and we can know when they move. Also, there is a lot of questions, as I said, about how we can treat more patients. So with the same number of machines that we have installed in Africa, so how we can treat more patients. So one of the solutions is to set up and treat the patient in less time. So with the SGRT, we can have less time treating our patient. That means that we're going to have more time to treat more patients. Also, the patient satisfaction. So also we need to look for the patient to be comfortable in their treatment. So SGRT can allow you to do treatment in less time, of course, but also it can give you the possibility to do treatment with less mobilization. For example, for the head and neck cases, for the SRS cases, we can do with open face masks, and also we can do without any immobilization, without a mask, and we are talking about digital mask with the SGRT. And of course, the return on investment for this kind of system, you can have a return of investment from the first year using the SGRT system. So the SGRT now is becoming a standard of treatment in radiotherapy. And as a company leader in the SGRT market, we have an SGRT system for all the workflow in radiotherapy. So because we don't have a lot of time, I'm gonna focus only today on the treatment part. So we are gonna present Align RT, which is the system for treatment. It's for the C-arm LINAC, but also for the inbore LINACs. So from Variant to Electa to tomotherapy, for example, we can work with all your machines. So Align RT is a system of cameras that use near-infrared light to help you to set up the patient and also to monitor the patient during the treatment. And all in 6 DOF. So you set up the patient without any tattoos, without any lasers, and then you can also manage the position. We don't have tattoos like 3 points, but with this system, we can say that we have 20,000 points all on the surface of the patient, and we can use those points, all of them, just to monitor the position of the patient. And you can see in this example that when I do the setup, for example, for a breast, we only have the tattoos. We don't know where the position of the arms is, where is the position of the neck and the head. So that's why we need to do multiple times the imaging, for example. And with this tool, like you see here, I can position the patient with ease, without any tattoos, but of course, it will be a setup that is more accurate. Of course, we can do the monitoring of the patient after the setup. When we go out from the bunker, we have the certainty that system and our cameras that are monitoring the patient, and if they go outside of our tolerance that we made, the system will automatically help and control the beam automatically. So we can do multiple, we can use the system for all our patients. So from head and neck to breast, to SRS, SBRT, to pediatrics. So also for pediatrics, for example, it will allow you to minimize the anesthesia for pediatric patients. So a lot of these cases, or a lot of these centers that use SGRT, also they have publications. And now it's more than 300 articles now published on SGRT for all this type of treatment. And a lot of these centers that use SGRT and Align RT, they use something called postural video. So postural video will allow you to set up the patient without any tattoos. And for my region and your region, we know that there is an issue with the tattoos. For example, a lot of women and people, they don't like to have tattoos and marks on their skin. I was here in the morning, yesterday morning. It was a lady survivor. She didn't like the experience with the marks, and she couldn't remove it for a long time during the period of the treatment. So I will give you just an example how we can position our patient. So as you know, the extremities are very hard to position. It will take you several minutes. It will take you even more than half an hour just to position the patient. With this tool and with Align RT, we can position. And this example, you have a leg. So you see the RTT, she's just doing the rotation manually, and we're gonna move the couch automatically to the isocenter of the treatment, and you will see that the real-time delta, all the real-time delta are zero out. So that means that we are in the isocenter of the treatment, and it took only a couple of seconds to set up this patient. After we set up the patient, we verify the position of the patient. We can also verify our beams. It's called Beam Guide, and with this tool, you can verify your beams. It's for 3D, that's like independent field, or for example, VMAT, ARCs, we can all check all of that before you start your treatment. So one of the things that we always face in radiotherapy, which is the anatomical change during the course of the treatment. But how we can see that? We always go and see that like the RTT is gonna see it, or during the consultation. But what if we have a tool that will allow us to see where is the anatomical change, but also it will give us quantification of this change. And from this information, we can decide if this patient needs a new simulation and a new planning. So with deformation tool, you can see, as in these examples, you can see where is my change, my anatomical change. For example, in the breast, we have an inflammation, for example, or in the case of weight loss, for example, for head and neck, we can see this change and we can quantify. For example, I will decide after I have 20% of change, I can decide that my patient need a new simulation. So I saw some presentation about the IBH. The IBH becoming now, or became, the standard of treatment for the left breast. Why? We want to spare our heart, the heart of the patient, but also we can spare the lungs. And the tool of doing the IBH, that's give you the possibility that the heart of the patient will go far away from the treatment fields. And that's, if you go through the publication about the IBH now, you can see that the amount of dose that we spare by it, the heart is huge. So how we can do the IBH with LINRT? It's very simple. We do the same. We set up the patient, but in free breathing, so we don't need to ask the patient to do a breath hold for several minutes. So we do set up in free breathing. After that, with the tool that we saw earlier, we can see that the patient is not in breath hold, not in the level that we want. So we ask them to take a breath hold, and we get to the level that we want in the breath hold, like here. So now we have all our real-time delta, not just the vertical. So in breath hold, we don't need just the vertical, because the breathing of the patient, it's not just vertical. We have the vertical, but also the longitudinal. But also we have something that happens with the patient. Sometimes they arc their back. So the vertical is good, but we have also some pitch. With LINRT, we are monitoring the patient in 6 DOF. That means in all rotations and also in all translation. One of them is out of the threshold that we fixed, so the beam will be held automatically after change. So we can do breath hold for the breast, but we can do also other type of breath hold, like EEBH. It's the opposite of the IBH for some cases of SBRT, for example, for the liver. So EEBH means end of expiration breath hold. So we have a tool that is like a small monitor that will go with the patient to coach the patient for breath hold, and it will help them to reach the breath hold level that we want, and then the treatment will start. A lot of guidelines now about the IBH is becoming the standard of treatment, but also guidelines about SGRT becoming also a standard of treatment for the IBH, but also for SBRT, EEBH, breath hold in general, SRS, and one of them is ESTRO from 2018, and also ESTRO ACRO 2022, and the most important one, it's the TG302 about the SGRT systems. So as I began the presentation about time saving, how we can treat more patients with the same machine, with LINRT we can save 22% time, so that means that we can have or treat more 22% more patients, and with postural video we can add to that between 25 and 155 seconds per fraction. So just to be quick, so one of the reasons that we do the IBH is to have or to spare the heart, and we have several publications about the IBH and the use of SGRT with the IBH. So without using the IBH, we can have 27% of the patients having some serious cardiac perfusion defect. And with the use of the IBH technique and SGRT, we can reduce that to 0. But also, the second type of treatment that is used by the SGRT is the SRS and the SBRT, and we have a lot of publication now about the use of SGRT with the SRS and also with clinical outcomes up to 5 years. We can do SRS head and neck treatment very comfortably for the patient with an open face mask, even SRS a non-coplanar, and with AlignerT you can have automatically going from a field to another field, and it will be automatically done. So the other type of AlignerT, which is not the C-arm, which is the inbore system, it's in plus of the ceiling camera. We can have a module of camera that go inside of the gantry. Why inside of the gantry? Because once we set up the patient in Halcyon, for example, or in Ethos, or even in tomotherapy, we set up the patient outside of the gantry, and then we go inside for the ISO treatment, for the treatment. So when we go to the inside with the camera of the ceiling, we can see the surface of the patient. You can see here on the left that we miss all the surface that we need to use and we need to monitor for the IBH, for example, and for head and neck cases. Even another thing from this paper that did a CBCT for patients before the treatment and after the treatment, what they found out that the patient, even with immobilization, they move. That's why we need a monitoring system to monitor the patient during the treatment. I will conclude very quickly. So just the last slide, I will skip 2 slides. So we have the biggest community for SGRT. It's on sgrt.org, so you can all be part of our SGRT community. It's about 10,000 affiliates, so please join our SGRT. You don't need to pay anything. It's free. You can have all the presentation about the SGRT used for different type of treatment, but also you can have the experience of other users, and you can benefit from them. Thank you so much for your invitation, and it was a pleasure.
Thank you very much, Mr. Said. That was a very good presentation. We look forward to the day when we will treat our patient without tattoos and masks. And clearly your system saves a lot of time. So without wasting much time, Mr. Jagadish, please, the floor is yours.
So, good evening to all. So, myself Jagadish, the medical physicist from Sinva. Now I'm speaking about the improving the clinical workflow in the modern radiotherapy. So already our colleague just explained the history of the Sinva. This is our major focusing medical radiotherapy series. XHA 600E, that's a single energy mission, and then XHA 1400, it's a dual energy mission, and then newly launched O-ring mission, it's the online adaptive radiotherapy facility is there. The Sinva's XHA 1400 having the CE certified mission. This mission having this 2 photon energies, 6 and 10, and then 6 triple F also is available. And then 4 electrons, 6, 8, 10, 12 MeV electrons available. The maximum dose rate is 600 MU per minute, and then triple F 1400 MU per minute. this machine having the MLC 60 pair MLCs, and then EPID and KV CBCT imaging facilities are available. So we are providing, we are collaborated with third-party treatment planning systems like RayPlan, MOSI, and D-Plan. So this machine is capable of treating 3D CRT, IMRT, VMAT, SBRT, SRT. So Amarpa silicon based flat panel detectors are we are using for imaging system. The fast image acquisition, reconstruction and registration. Now automatically it generates the X, Y, Z directional errors. It automatically transmits the error data to the accelerator for positioning correction. So it has the collimator with asymmetric X and Y jaw for maximum field size of 40 by 40 centimeter square, followed by the 60 pairs of tertiary MLC. The MLC leaves are having the interdigitization facility which helps us to do the better 3D CRT and VMAT planning. So our MLC having the 3 variable thickness, the nearby isocenter 0.5 centimeter thickness, and then 0.75 and then 1 centimeter thickness. Our planning system achieves the conventional radiotherapy 3D CRT, step and shoot, dynamic MLC planning, VMAT planning, SRS, SBRT also. So the advanced computer network technology seamless integrates the imaging and treatment equipment, enable fully digitized radiotherapy center with paperless and frameless operation. So the advantages of the 1400 machine, they reduce the treatment time from the 15 to 30 minutes, the conventional static MRT to the 3 to 4 minutes with the VMAT technique. The capable of doing 360-degree multi-arc irradiation at any angle offers the better dose coverage and the greater flexibility and enhance the precise dose delivery. The system dynamically adjusts the radiation intensity based on tumor volume and delivering the optimal dose while maximal sparing the critical organs and achieving the most favorable dose distribution. So the treatment workflow, image acquisition, and then auto contouring, and then plan design, QA, and then position verification, and then treatment delivery. So Sinva having the dedicated radiotherapy simulator is a 16 slice simulator. The bore size is 85 centimeter. The ultra high spatial resolution break through the constraints of resolution and aperture, diagnostic grade images, and makes the detail of clinical image recognizable, supports the prospective and regressive 4D scanning modes. The high quality diagnostic level image quality provides the imaging basis for the formulation of high quality radiation therapy plans. So our system having the integrated AI based auto contouring system. So 20 plus target volumes auto segmented, and then 200 plus OR auto delineated with the 98% accuracy. So developed in the collaboration with the top tier medical institution, incorporate with the contouring expertise from the leading radiation oncologist. The plan evaluation and verification, one click input of prescription dose for clear visibility and plan quality. Is the we can reduce the clinical goals to easy to evaluate the plan. Patient specific UA, so third party validation equipment was used for VMAT planning, VMAT plan verification. The 99.1% gamma passing rate in the 3% 3 mm Croatia. So the VMAT plan verified using the accelerator onboard EPAD module. This is the optional one. The treatment setup and position verification. So less than 15 seconds takes the image acquisition, and then less than 30 seconds for image reconstruction, and then 30 seconds for image registration, and then automatically applies the correction couch shifts. The integrated treatment console. The integrated treatment console system for precise treatment delivery and online record and verification system. The treatment record and statistics. Upon the completion of treatment plan, all data is uniformly transmitted and stored, enabling the centralized management of patient positioning images, treatment plans, and then treatment records. Statically analysis is performed on this data, including the treatment metrics, role-specific workload statistics, and disease-specific analysis to provide the robust decision-making support for radiotherapy centers and administrators. This is a few cases. This plan is made by XHE 1400 machine. This is with 60 pairs of MLC and then dual arc machine. You see the better tumor coverage and then better normal organs sparing. This QA passing ratio is the 98.1%, with the 2 mm gamma passing ratio. The another next case is the cervical case.
You have
2 minutes. This is the better conformity and the homogeneous dose distribution. Is the passing ratio is the 99.1%. The clinical benefit of the XHA 1400 mission: adjust the target volume margin, reduce the radiation dose to the normal tissue, decrease the radiotherapy toxicity, enhance the local control rate of target volume, increase the radiation dose to the local tumor, achieves the optimal dose coverage to the target. It improves the quality of life and prolong survival time. So this is the reference center, Mangut Watana Public Cooperative from Thailand. This setup having our mission 1400 mission with MLC 120 leaf, EPAD and CBCT, and then CT machine. They are treating 65 to 70 patients on daily. So, thank you very much. Thank you to all.
Thank you very much. Wandela is not around. Prof, please. Prof will be talking about re-irradiation in SBRT, pushing the dose limit.
So without wasting time, at the outset, I congratulate the AFROC, and also I really appreciate for inviting me and to share my experience. So good to see the familiar faces. I'm here for almost last 15 years. So Dr. Coleman, Dr. Bashir, and of course, Dr. Catherine. So I'm going to talk about 8 to 10 minutes of re-irradiation setting. So re-irradiation, SBRT pushing dose limits. So this is my credentials. So I thought it's mainly for the residents. That's why I prepared a little bit of the history of evolution of radiation as such, and even to the other people. So global count data is released 2024, top 5 cancers, the lung, or whatever we are looking at, lung, breast, GI, prostate. So overall cancer improvement in terms of survival, we are looking at in higher rates now compared to previously.
At any given point of time, we are going to see in coming years, most of patients are going to survive more of an oligometastatic, or where the condition is required to re-irradiate. So these are the patients what we are looking in present era. Radiation oncologists are going to be one of the most pivotal things in terms of cancer management. One size fits all is no more applicable. So we need a combination of treatment is the one what we are looking at. Actually, that's going to make a big difference. So this mainly improved survival, higher response rate, reduced toxicity, and better quality of life. And if you see the last line, why we are powered by precision and path to personalized care is the norm for today. If anybody of you, like any of the patients, when you are asking, if the patients can afford, definitely we should look into that as one of the main criteria. Multimodality approach is the key. Multidisciplinary team approach is very important. As a researcher or as an oncologist, understanding the biology of cancer, hallmarks of cancer is important. So every day is changing. It may be the overall, who knows, you may invent newer things. Radiation oncology, I prefer to consider as radiotherapist rather than radiation oncologist for a different, very important reason. Other than the radiation oncology, we are looking into non-oncological aspects of radiation, which is going to be cardiac, it may be functional, SRS, and also we are looking at including the pain management in terms of orthopedic or any of the pain areas. So that is important. If you see that we are coming into the lot of changes which has occurred, precision is the key, and here we are looking at the precision treatment to the tumor and as less radiation to the structures, surrounding structures, so that the quality of life is the key factors. Why now for re-irradiation? It's very important, better imaging. Now actually we can, the PET-CT scan, we can identify early recurrences or recurrences where there is always a confusion about that is really recurrence, post-treatment changes. Actually we can look into that. Very nice image fusion, functional scannings including the PET-CT scan and MRI, different types of molecules which makes a lot of importance. And better delivery of radiation machines. IGRT should be the minimal norm. If I take, like, no patient doesn't know that it has to be taken a proper treatment. They come up with particular disease, IMRT, IGRT should be the minimal norm. So how we manage with the management is your problem, not the patient problem. So higher SBRT capability, that's what we did it in terms of cyberknife, or robotic, or proton. MR guided radiotherapy is one. We are looking at carbonyl, millimeter accuracy, all those things. So we can safely deliver ablative doses while sparing the normal tissues. That is important now, and better biology. So understanding the BED and vascular endothelial injuries, immune activations, oligometastatic pattern, we are now going to understand why iDose precision RT works. Because of these things, SBRT as a precision oncology, the word of palliation should be a backdoor. I would like to call any patients as a palliative. Pushing this palliation to ablative to curative intent. Every patient has an opportunity. As an oncologist, we can always treat those areas effectively because we have the tools to do that. I'm not talking about only radiation as such, but radiation takes a forefront in combination with the other things. SRS, SBRT as the definitions. I'm sure that when you look at this, you have one of those things which makes you say, okay, that's one of my missions. So working with all the missions, I always feel that the man behind the mission is important. Doesn't matter. It may be more than 95% is common. That 2 to 5% may be a difference, but how we want to play with the machines is important. Radiobiology of SBRT. Radiation is no more a local treatment. It is actually systemic effect is enormous. We are looking not only for the short treatment, and we are looking for many things which is in combination with the systemic treatment and ablative treatments. which is going to be different. It may be rare, it may be in terms of cancer vaccines, ablative, combination with immunotherapy, radiation is exciting now. Indications of SBRT is increasing. It is not limited to intracranial. The size and the shape doesn't matter, the location doesn't matter, and definitely we are giving respect to the normal structures. So combination of SBRT immunotherapy hyperfractionations as actually is going to change in the way the oncology is going to be in future. Radiogenomics, it's not necessarily we are looking only for radiology as the genomics is one of the things. The combination of radiology, radiogenomics and radiomics is one of the things which is going to make a lot of difference in the future. Combinations of these things has to be a norm in terms of radiation is concerned. So this is about the CyberKnife. I would like to skip this because there is already a CyberKnife in the system and all the people in the audience have already know about the CyberKnife. So why CyberKnife? The motion management is robust. The patient comfort is better, and you can deliver the fractions between 25 to 30 minutes and within 5 days of treatment. Proton is definitely superior in many ways, as a radiation oncologist know. IMPT and IGRT based IMPT is the one which is making a lot of difference, and the radiobiologically is at its superior. If you are in that part of the world, please visit Chennai, and the proton has definitely advantages. Radiobiologically, I feel that we are unexplored the effect of hyperfractionation with proton. So as a radiation oncologist, this alpha beta ratios should be on any of the radiation oncologists in making should be, the chart should be there to understand and play around. So when we're looking at the re-radiation setting, important is, fundamental principle is, radiation is unforgiving. You should know that how much is the radiation given to the tumor, how much is the margins given, how much is the normal structures has got the radiation. And in terms of one, tumor may forget, but the normal structures repair and recover independent. It is one of the advantages what we are looking at in this. Alpha beta ratios and cumulative dose is the one what is important, and total doses has to be calculated. And tissue recovery time, the golden rule is very simple. 6 months is your time, minimum time should be 6 months, and the doses should be hyperfractionation, and as safe as possible, it should be, that is important when you're looking at re-radiation. What are the cases where we are looking at re-radiation setting, where we see that gliomas is one, anything in the brain, spine, lung, liver, head and neck. These are the cases where we are looking at increase in the survival, and the dose fractionations the normal re-radiation can be done in a normal also because of our IGRT issues. Hyperfractionation works better. I watch for hyperfractionation with doing all the hyperfractionation for last 18 years. So anything single fraction versus multiple hyperfractionations, 1, 3, 5 or up to 6. I prefer 5 fractionations because that works very well, and I don't think so it's going to be an issue about the normal structure is concerned. The dictum is your 50% dose should be within the 1.5 to 2 centimeter depending on the volume, or probably rule of thumb, so 1/3 of your tumor volume should be your 50% dose should fall. So you have to do that less than 3 months, little bit careful. Any progressive disease less than 3 months, you need to recheck, is it really required? Spinal cord is unforgiving, cord already has tolerance. Bowel attachment, you should prepare for that, telling that there is a possibility that there are perforations. If you can manage the perforation versus functional sparing, life sparing. If it is going to be life sparing, accept the perforation, but if the tumor is going to be curative. Of course, the performance status makes a little difference. And local control. The beauty is when you are looking at, this is some of the literature based, but when you see local control doing the SBRT for more than 7,000 to 8,000 patients, re-radiation for more than 300 to 400 patients. Local control, I'll still watch for more than 90%. We are reached. Especially in the brain mets and brain areas, I'll go more than 90 to 95%. So only thing is, sometimes in terms of maybe pancreas or wherever we are looking at bowel things, is treatment-related conflict. simple as head and neck cancers where there is a perforation, the blowouts is one of the things. So the planning workflow is very simple. Yes, retrieve the plans, plan, mark everything, mark everything. That is important. Organs, normal structures and all the other things. Dose, cumulative doses, give an optimized plan. Your physicist is your best. Your technologist is the one who are reflecting you. What do you want? You get it the best out of the technologist. He should know that where he is treating, where to account, adjust accordingly and give them the free hand so that they will take a decision. Do not do treatment if you think that it is wrong. So safety before the delivery is important. Checklist, plan verifications, the areas, how much the dose, QA, related to each patient is important. Common toxicity, yes. When we talk about 5x5 is our best method to understand the toxicities. But the moment if you talk about re-irradiation setting, it may reach to 5x20. So the 20% of the patients in 5 years may get the toxicities. Accept that, but still you have 80% of the patients are doing better, going to be survived. If you can accept it, please do it. 5x50 is another thing you should look at. Yes, all these things is important. Be prepared to treat accordingly. So late toxicities, radiofibrosis, necrosis, myelopathy, carotid blowout, perforations. These are some of the things what we are to look at. Fistula formation. So document. There's not necessary to get it scared. I'll tell you, in that 7,000 patients or 400 patients of re-radiation, I know that I've caused 2-3 patients spinal cord injuries. But document what time it happens. I've treated 4 times. Actually, one of the patients, he had but he survived for 9.5 to 10 years. So explain to the patient, deliver properly. Yes, the bottom line is the intention should be good. How to prevent toxicities? Appropriate patient selection, retrieve, review prior data, document, composite dose summation, respect cumulative OR restraints. No need to hurry about we need to finish off treatment as early as possible or complete so that the patient doesn't have to come back. Curie principles, target the tumor, all these things are important. Vigilance saves the patients. That is one thing I really like it. The power of precision, re-irradiation of cancer, the combination of any of the settings, metastatic disease, or if the patient has come, the recurrence is there, biology is the king. You need to understand, do not hesitate to go back and do the genomics and the combination treatment, talk to your colleagues, surgical interventions may be required, or the medications in terms of medical oncology, immunotherapy. I congratulate today for opening the clinical oncology setting. So the combination of immunotherapy and the radiation and the SBRT is the future. You're in the right time, you are doing it. Do not hesitate to continue that. So all this and oligomets, as I told you, that is going to be 40% of your cases in your clinic is going to be oligomets in coming future, or it may be more in that. So look into all this data. I saw that a lot of things in terms of future is considered. So start looking at this, collect the data. So monitor and adapt. ctDNA is another thing where radiomics response to your radiation. How is going to happen? All those things you can do it. It is already there. We are already doing this. So radiomics data to predict the response. Coming to the proton story, why I would like to go to the proton SBPT is radiobiologically SBPT is protection of the normal structures. T cells are one of the things we need to prevent giving irradiation to the T cells. So that can be done, especially in proton, very well, because 0 dose after the particular BRAC peak is over. So that is the things, ctDNA, delta radiomics. Look into these things as the one. Just some of the cases. SEA nasopharynx 23, patient is from Ghana. Patient actually came for proton therapy. We had a discussion. We had a difficulty in terms of re-radiation setting because the data was not available. We decided not to do it. But I've done at least minimum 45 nasopharynx re-irradiations. I did the re-irradiation in this. Before re-irradiation, carotid is the things what I've seen. Primary things, there may be nasopharynx, there may be fistula formation during the swallowing. All those things are taken into consideration, explained. So this is in November 24. 30 grain 5 fractions along with pembrolizumab was given initially. Patient couldn't afford, then we changed it to toreplimab. This is a complete response what you are seeing within 4 months, 3 to 4 months of treatment. So complete metabolic response. And now actually this is 19 months. Is doing absolutely fine. We continued for 6 months chemotherapy. We are continuing immunotherapy now. Probably like 1 year is completed. Depending on that, we are going to do maintain. Prostate cancer is another biggest volumes for you. Look for prostate re-irradiation. In oligomeds, treat the primary. Wherever there are radiation is already done, re-irradiation settings, we have published our data with CyberKnife. Here are the common things. The infill recurrence, outfill recurrence. I am talking about re-irradiation setting in the infill recurrence. So, brain tumors, all this is the re-irradiation within the things. We have published our data. So, usually the 6 months is the median overall survival. In ours is almost 15 months. Re-irradiation for brainstem glioma. So, when there is a possibility, yes. So, I have treated and we have published around 7-8 patients. And the success is a moving target. In this, actually, the patient came that do whatever is possible. We treated, disease came down, but patient become in a vegetative state. 9.5, almost around 12 months to 19 months, the patient was like that. That time, there is always a seeing that. So, remember, you should be ready for the worst possible things. Explain, be with them, that is what is important. So, I got actually recognized as re-irradiation setting authority in terms of the brainstem glioma, because the moment if the brainstem glioma recurs, the people say nothing can be done. So the future of AI supports all these things to be incorporated. Flash radiotherapy is another thing. Keep it in mind. As and when required, we can use it. Take-home points: longer survival, re-irradiation, SPRT, palliation to curative intent. Patient selection is crucial. Planning and dosing, no compromise in that. Combination of genomics, immunotherapy, and SBRT is going to be one. AI, you should utilize to the extent what we want. And it's going to turn around and make a big difference. If the people are interested, so SBRT, we are doing a course February 26 to 24, 26, 27, 28 in Bangalore. So you are welcome. This is going to be the first conference in India from our associations. I'll be doing it in Bangalore. I'll send you the details. Thank you for my patience hearing, and thanks for my team in the back home. Thank you.
Thanks a lot, Prof. That was an excellent presentation. Thank you, Prof. Dr. Lillian, you have only 5 minutes. All the best.
Okay, thank you. I think I should just say good evening, everyone. After those very excellent presentations, I think I must say radiation oncologists have the toughest job in medicine. Lucky for me, my role is not as hard. It's quite simple. I'll not be talking about contouring and planning, more of systemic treatment. So I hope I can take the 5 minutes that Dr. Nurdin has given me. So today I just wanted to highlight the current management guidelines when it comes to management of biliary tract cancers. So my name is Dr. Lillian Ouma. I work with AstraZeneca as a medical lead in charge of oncology for Sub-Saharan Africa, and it's a pleasure to be here today with the AFROG members. So just as a disclaimer, this is purely for educational purposes, and of course it doesn't replace your independent judgment. So I think this is information that we are all aware of in terms of classification for biliary tract cancers, where we have the intrahepatic, the perihilar, and the distal cholangiocarcinomas. Of course, the ampulla ovata cancers are excluded from the different clinical trials that enroll patients with biliary tract cancers. So this would also be included when it comes to the management guidelines. So when it comes to biliary tract cancers, the different genetic alterations vary by subtype. But of course, the IDH mutations, KRAS mutation, and FGFR2 fusions are the most common. However, any of the ones that are listed there can actually occur. So the burden when it comes to biliary tract cancers, this is more of a global burden, but you'll agree with me that it is not any different from what we see locally. Mainly that the burden is quite high. Biliary tract cancers are quite aggressive and have a poor prognosis, and especially in our setting where the treatment options are or may be limited, we have an even poorer prognosis. So the treatment options, of course, will depend on staging. I think I have the experts here today, so I won't go into that. My discussion today will mostly focus on advanced or metastatic disease and the systemic options, systemic treatment options that exist for this group of patients. So different studies have been done. The most protocols that have been used were based on the initial studies, primarily comparing the use of chemotherapy, so monotherapy or combination therapy with gemcitabine plus cisplatin. And of course, this has been the standard of care for quite some time, and I believe may still be standard of care in our setting. So it is important when it comes to biliary tract cancers to understand the immune profile and also the homeostasis via the various immunological pathways. So it has been shown that upregulation of PD-1 or PD-L1 is actually associated with worse outcomes in biliary tract cancers. And this is because when PD-L1 is upregulated, the anti-tumor activity is affected as well. So this is actually the backbone for considering anti-PD-1 or anti-PD-L1 in the management of advanced biliary tract cancers. So studies actually suggest that checkpoint inhibitors might actually suppress the immune response to tumors in the biliary tract, and this therefore makes them a potential target when it comes to treatment. So durvalumab is one such therapy option. It's a PD-L1 checkpoint inhibitor, and the PD-L1 inhibitors actually have limited efficacy as monotherapy, and they work best when combined with chemotherapy. And I'll look at the various studies that have looked at this combination. So of course we've highlighted the unmet need, the current first-line treatment, which has largely remained unchanged. So there is definitely need for us to consider what else we can do for these patients in order to improve their outcomes. So this is actually the rationale for the TOPAZ-1 clinical trial that now looked at the standard of care as the backbone of treatment, but then considering addition of durvalumab as part of the treatment for these patients. These were the trial sites that were included globally. I know the question is always, when will we see our patients also included in this map? But for a start, this was the global landscape for this clinical trial, enrolling patients with advanced or metastatic biliary tract cancers, the types that we have already mentioned. And these patients were randomized in a 1-to-1 ratio to either receive the standard of care, which is GemCis, and in this case a placebo was added, or addition of durvalumab to this standard of care regimen. And they received this treatment until disease progression. So the inclusion criteria is highlighted there, and I think you can also access it from the different publications. But the principle here was the combination treatment was given for 24 weeks, and then the patients continued with durvalumab monotherapy after that. And this was continued until disease progression. If you look at the baseline characteristics, they look very well balanced across the different arms. You'll also notice that all the patients were either metastatic or locally advanced, and then the PD-L1 expression status, more than 1% or less than 1%. However, very well balanced across the different arms. So looking at the efficacy data for this study, we see that the overall survival is actually significantly improved in patients who receive combination chemotherapy plus immunotherapy with durvalumab. Of course, we see the curves almost at the same point within the first 6 months, but then once the effect of chemotherapy, because both groups are actually receiving chemotherapy, so once the effect of chemotherapy has been felt by all groups at around 6 months, and then now the effect of immunotherapy starts to kick in, then we can see the curves starting to separate. Notice that at 1 year, we have an overall survival rate of 54.1 in patients who are receiving durvalumab, compared to 48% in patients who are on placebo. So this is about a 6% difference. However, as time progresses, we can see that significant difference, moving at 18 months, 35.1, 25.6, all the way to a 2-year overall survival, almost doubling with 24.9% and 10.4. And of course, looking at the hazard ratio, we see a 20% reduction in the risk of death. So again, this is now the updated data. Doesn't really, it is not really different from what I have already highlighted. So we can see what really the benefit is in terms of having these patients on immunotherapy. I'll just go back because I know the other question would be the median overall survival. We don't see much of a difference here, but you also notice that the significant benefit can actually be seen in the long-term responders. At the tail of the curve, we see that very significant, almost doubling overall survival benefit with use of immunotherapy. The benefit was actually observed across the different subgroups, and again, you can be able to have a look at this data. In terms of progression-free survival, we see a 25% reduction in the risk of progression in patients who receive immunotherapy as opposed to just chemotherapy. And of course, no difference when it comes to quality of life, so therefore showing that the patients actually tolerated the treatment. So in terms of safety, the two treatment arms actually have a similar safety profile, and we see the placebo plus GemCis arm being very consistent with the group that is also receiving durvalumab. So no new safety hazards when you introduce an immunotherapy in this group of patients. The incidence of grade 3, grade 4 adverse events, again, remain quite similar between the two treatment arms. So just to highlight, based on this data, the current guidelines when it comes to management of advanced or metastatic biliary tract cancer is preference for use of a PD-1 or PD-L1, durvalumab or pembrolizumab, in combination with gemcitabine plus cisplatin as category 1 treatment in these patients, similar with the ESMO guidelines. So just as a take home, that we actually can see the added benefit when there is use of immunotherapy in combination with chemotherapy in patients with advanced biliary tract cancers. So thank you so much for your time. Doc, I hope I've taken just about the minutes you gave me. Thank you.
Thank you very much. That was an excellent presentation. We only have Prof. and Dr. Ouma. So if there are any questions to our presenters, I can hand you the mic.
My question goes to Dr. Lillian. Thank you so much for this wonderful data. We can see at least there's much hope in our hepatobiliary patients. Now they're living longer with the addition of durvalumab. My question is when you're talking about the toxicity profile, you're saying almost the same. We know that immunotherapy has different profile, but why in this study there was no difference?
Yeah, Doc.
Yeah, thank you. Thank you so much, Dr. Abeid, for that question. Very interesting, because we already can see that these patients are getting an added treatment. However, very significant that the difference when it comes to what you'd consider a significant adverse event, grade 3 and grade 4, which is what I highlighted, was almost the same. So it doesn't mean that the patients did not experience adverse events. And of course, you'll agree with me, the very intense monitoring that goes on within a clinical trial. So you're likely to pick them at grade 1, grade 2. And if that were the case, even in routine standard of care, then it should be manageable. So grade 3, grade 4 adverse events that you'd be concerned about were the ones that were almost equivalent. Yeah, it's just the incidence of the two.
Dr. was asking about the type of side effects. With immunotherapy, you will see colitis, pneumonitis. So we didn't see that. Oh, okay, thank you. Any question for Prof? Yeah, Prof, you said you can do irradiation after 3 months. Is it safe to do? That's what I saw.
It all depends on the type of tumor where it is, this one. As early as more than 3 months. Less than 3 months, definitely not. If there is a less than 3 months, if the disease is progressing, I think that we need to accept that and identify the genomics of those things and use for the next patient. For 6 months is the best scale, at least minimum of 6 months, especially when you're re-irradiating the same area. So if it depends on the other areas, is there any progression of the disease? Only a local recurrence. I didn't talk about, especially in the brain tumor, the confusion about the disease progression versus pseudo progression or necrosis. Use of bevacizumab, low dose bevacizumab, actually makes a lot of difference. Many of the colleagues, they have seen, especially with my patients itself, where we thought that there is a tumor progression, and those patients survived more than 5-6 years with the low dose bevacizumab. So the brainstem story is totally different. Brainstem glioma as such, they are very, very aggressive. With some of the dose escalations we have seen, median survival is 36 months. Whenever re-radiation setting is there, you need to be very clear with the patient, especially what we are looking at. As an oncologist, I am looking as a tumor control. But as the sequelae of the treatment, it may be more. Neurological deficit is the scale for the patient and the relatives. As an oncologist, my tumor reduction is one of the scales. But you see comprehensively, re-radiation setting brainstem glioma is possible. We have done that. What I see is a re-radiation, third time re-radiation, because the patient survived for 3.5 years. So another patient I have re-radiated after 5 years. So the case-to-case basis we need to look into. And simple example, whenever there is a re-radiation, the patient has recurred with a longer duration, after longer duration, go back and check, can I re-irradiate? So that irradiation is the only thing. In brainstem glioma, medications are not there. No chemotherapy is effective. Surgeons won't even touch. So that is one of the areas where actually we can explore. Yes, it has to be under very much in permission with the patient and the relatives, so that you are not getting to the problem.
I now call upon the presenters plus senior officials for a photo session. Dr. Komen. Dr. Catherine. Abate. Makori. Actually, you can all join us. We are not that many.
iko cocktail at 6. Tafadhalini, machozi ya simba ama ni maji ya simba? Sawa.